For GI, the way I will be teaching is on the basis of various parts of the gastrointestinal system. Under gastrointestinal system, what do we have? We have the oral cavity, we have the salivary gland, we have the esophagus, we have the stomach, we have the small intestine. So we will be looking at the pathology of esophagus, then the pathology of stomach, then the pathology of small intestine, then the pathology of oral cavity, and then the pathology of intestine, then the oral cavity, then salivary gland, and finally few very important congenital anomalies related to gastrointestinal system. Starting off with esophagus. See, within individual part like esophagus as well, first, we will look at the non-tumor pathology or non-neoplastic pathologies and then the neoplastic pathology. So under non-neoplastic pathology of esophagus, first we have Achalasia cardia. Before understanding the pathology of Achalasia cardia, you need to understand the normal physiology. Because if you know the normal physiology, you can simply pinpoint where the problem arises, and then the pathology goes as per the story of the normal physiology itself. So important thing, you need to know the normal physiology. So for Achalasia cardia, you need to know the normal physiology of deglutition reflex. What is deglutition? The process of swallowing is called deglutition. What is swallowing? Food enters your mouth, then your pharynx, then your esophagus, and finally enters the stomach. The whole process of food traveling from your mouth, then pharynx, then esophagus, and finally into the stomach is swallowing or deglutition. That is why the deglutition reflex is divided into three phases: the oral phase, the pharyngeal phase, and the esophageal phase. All right. So you have your deglutition or the process of swallowing, which has three phases: the oral phase, the pharyngeal phase, and the esophageal phase. Within the esophageal phase, there are two major events that take place. Two major events. Number one, the lower esophageal sphincter that normally remains closed opens. As a result, the food from the esophagus is able to enter the stomach. Okay. And event number two, the food passes down through the esophagus away from the mouth or in aboral direction by the process of peristalsis. Again, first event, opening of lower esophageal sphincter. See, your esophagus, it is around a 25 centimeter long tubular part of gastroesophageal sphincter which connects pharynx with the stomach. Now, at the junction of pharynx and esophagus, there is a sphincter, which is the upper esophageal sphincter. And at the junction of esophagus and the stomach, there is another sphincter, which is the lower esophageal sphincter. The upper esophageal sphincter and the lower esophageal sphincter. Since the lower esophageal sphincter is present at the junction between esophagus and your stomach, it is also called the gastroesophageal sphincter. Since it is present where the cardia of the stomach is present, it is also called the cardiac sphincter. All right, basic anatomy. Now physiology. Normally, the lower esophageal sphincter, it remains closed. Why? In order to prevent the reflux or regurgitation of acidic content from stomach into the esophagus. But when you swallow food, the lower esophageal sphincter, it opens so that the food can enter the stomach. All right. Second, peristalsis. See, in peristalsis, the part of the esophagus above the food, it contracts. And the part of the esophagus below the bolus, the food, it relaxes. As a result, the pressure above is more than pressure below, so the food gets pushed downward. There's your bolus. The esophagus above contracts and the esophagus below dilates. The food gets passed down. Again, the esophagus above contracts and the esophagus below dilates and the food gets passed down. This is how the process of peristalsis takes place. Now the question is, what exactly is contracting and relaxing here? Obviously the muscle. So what is the muscle found here? See, you must know this much, that the sphincter at the end of the day is your smooth muscle. Which smooth muscle? The circular smooth muscle. So sphincter is nothing but a thick band of circular smooth muscle. So when the circular smooth muscle contracts, the sphincter closes. When circular smooth muscle relaxes, the sphincter opens. The same is applicable in peristalsis as well. The whole gastrointestinal tract, if you look at the histology, you'll find a layer called muscularis propria, which contains circular muscle layer, and this circular muscle layer, it contracts and relaxes. As a result, the tube constricts and relaxes. So this, where the esophagus has contracted, is where the circular muscle has contracted as well. The contraction of the circular muscle leads to the contraction of the esophagus, and the relaxation of the smooth muscle leads to the relaxation of esophagus. Okay, so the contraction of the circular smooth muscle leads to contraction of esophagus, as well as the closure of sphincter, and the relaxation of circular smooth muscle leads to relaxation of esophagus or the opening of sphincter. What exactly controls the contraction and the relaxation of all these smooth muscles, of circular smooth muscle? It is the nervous system. The nervous system found within the wall of the gastrointestinal tract is the enteric nervous system. So enteric nervous system controls the contraction and relaxation of the smooth muscle lining the gastrointestinal tract, in turn controlling the closure and opening of lower esophageal sphincter and the contraction and relaxation of esophagus that causes peristalsis. Okay, so the enteric nervous system. The enteric nervous system contains two types of neurons: stimulatory neurons and inhibitory neurons. Stimulatory neurons and inhibitory neurons. Stimulatory neurons produces neurotransmitter acetylcholine and substance P. Inhibitory neurons produces neurotransmitter nitric oxide and vasoactive intestinal peptide. Now, acetylcholine and substance P produced by stimulatory neuron, they result in contraction of circular smooth muscle. Since there is contraction of circular smooth muscle, the lower esophageal sphincter, it closes. So there is contraction of the lower esophageal sphincter. As a result, the lower esophageal sphincter closes. On the other hand, nitric oxide and vasoactive intestinal peptide produced by inhibitory neuron results in relaxation of the circular smooth muscle. As a result, there is relaxation of lower esophageal sphincter, and the lower esophageal sphincter opens and the food is able to pass from the esophagus into the stomach. Right? Once more, there's the enteric nervous system. The enteric nervous system, which has two types of neurons, the stimulatory neurons and the inhibitory neurons. The stimulatory neurons, they produce acetylcholine and substance P that cause the contraction of circular smooth muscle, that in turn cause the closure of lower esophageal sphincter. On the other hand, inhibitory neurons, they produce nitric oxide and vasoactive intestinal peptide. They cause the relaxation of circular smooth muscle, which turn leads to opening of lower esophageal sphincter. Now, the coordinated action of stimulatory neuron and inhibitory neuron, or coordinated action of contraction of circular muscle and relaxation of circular muscle, results in peristalsis. Because during deglutition, the esophageal phase of deglutition, when the food passes through the esophagus, what happens? There is continuous contraction, then alternate contraction, relaxation, contraction, relaxation, contraction, relaxation. As a result, the food bolus is able to pass in aboral direction throughout the esophagus. This is the normal physiology. Alright. Now, in Achalasia cardia, in this normal physiology, where does the problem arise? The problem arises at the level of inhibitory neuron. There is either no inhibitory neuron or if there is, it gets destroyed. There is either absence of inhibitory neuron or destruction of inhibitory neuron. Since there is no inhibitory neuron, there is no release of nitric oxide and vasoactive intestinal peptide. As a result, relaxation of circular muscle does not take place. As a result, lower esophageal sphincter does not open. See, normally when you are not eating anything, the lower esophageal sphincter remains closed. Right, remains closed due to the activity of stimulatory neuron producing acetylcholine and substance P. See, stimulatory neuron is producing acetylcholine and substance P. It is acting on the circular smooth muscle and the lower esophageal sphincter is closed. It is closed, right? Now, when you eat, when you swallow the bolus, now there is release of nitric oxide and vasoactive intestinal peptide from inhibitory neuron. As a result, it inhibits this contraction. Basically, relaxation takes place. The circular muscle relaxes, the lower esophageal sphincter opens, and now the food from the esophagus can pass into the stomach. But in achalasia cardia, since the inhibitory neurons are not there or destroyed, there is no nitric oxide or vasoactive intestinal peptide being produced, this contraction that is normally taking place is not inhibited. The lower esophageal sphincter will remain contracted. It will not relax. Then what will happen? You will try to swallow food, but the food will not get swallowed. The food will not enter your stomach. Another thing, there is coordinated movement of circular muscle, contraction, relaxation of circular muscle leading to peristalsis. Now, since there is no inhibitory neuron, there is no NOVIP, there is no relaxation of circular muscle taking place, peristalsis won't take place because one half of the peristaltic activity is not taking place. How will peristalsis take place? All right. So here's the diagram. Normally, the lower esophageal sphincter is closed. Why? Due to the action of acetylcholine and substance P secreted by the stimulatory neurons. When you swallow food, the lower esophageal sphincter, it opens. Why does it open? Due to the activity of inhibitory neuron secreting nitric oxide and vasoactive intestinal peptide. As a result, the food from the esophagus can enter the stomach. But in case of pathology, in case of achalasia cardia, the lower esophageal sphincter is closed permanently. It does not relax. Why? Because the neurons, the inhibitory neurons that are responsible for the production of neurotransmitter nitric oxide and vasoactive intestinal peptide, that is responsible for the relaxation of circular muscle and then the opening of lower esophageal sphincter, is not there or destroyed. These inhibitory neurons are not there. So the lower esophageal sphincter does not open. When this does not open, what will happen? You keep on eating food, but then the food does not enter the stomach. It will get accumulated in the esophagus, and the esophagus eventually dilates. It gets pushed and the esophagus dilates. All right, now let's get into the pathology, that is achalasia cardia. Achalasia cardia is also called cardiospasm. First definition. The name gives the definition itself. A means absence. Achalasia from chalasis, referring to relaxation. So there is absence of relaxation. Of what? Of cardia. Cardia is the part of the stomach that is in direct communication with the esophagus, right? There is esophagus and then the stomach. The part of the stomach is the cardia, So in achalasia cardia, there is absence of relaxation of the gastroesophageal junction or the cardioesophageal junction or the lower esophageal sphincter. There is absence of relaxation of the lower esophageal sphincter or the cardiac sphincter. Okay, so A referring to absence, achalasia from chalasis referring to relaxation, and cardia referring to cardiac sphincter, which is basically your lower esophageal sphincter. So there is absence of relaxation of lower esophageal sphincter. In other words, cardiospasm. Since relaxation is not taking place, right? Spasm, all right. Since relaxation is not taking place, that means it is continuously contracted. Since lower esophageal sphincter is continuously contracted or cardiac sphincter is continuously contracted, it is in a continuous phase of spasm, so called cardiospasm. All right. Now the definition. the accumulation of food in distal esophagus due to failure of opening of lower esophageal sphincter is achalasia cardia. Simple. It is associated with a triad. The triad consists of, so I said earlier, what does not take place? Number one, the lower esophageal sphincter does not open because there are no inhibitory neurons that produce nitric oxide and vasoactive intestinal peptide. So the lower esophageal sphincter does not relax, it does not open. So there is failure of a relaxation of lower esophageal sphincter. Second, I told, since one half of the activity of peristalsis is not taking place, peristalsis is basically not taking place, there is aperistalsis. Number three, since the lower esophageal sphincter does not relax, that means it is continuously contracted. So the tone of the lower esophageal sphincter is obviously high. A contracted muscle has higher tonicity, right? So there is increased lower esophageal sphincter tone. So this is the triad. Again, definition of achalasia cardia: accumulation of food in the distal part of the esophagus that is associated with the triad that consists of, number one, aperistalsis, number two, failure of relaxation of lower esophageal sphincter, and number three, increased tonicity of lower esophageal sphincter. Etiology. Based on etiology, achalasia cardia are of two types: primary achalasia cardia and secondary achalasia cardia. Primary achalasia cardia is congenital. Secondary achalasia cardia is usually due to infection like Trypanosoma cruzi, herpes simplex virus 1. I'll tell you the details of these etiology later on. So for now, just mug it up. Primary achalasia cardia is due to congenital reason. Secondary achalasia cardia is due to infection like Trypanosoma cruzi and HSV1. It is associated with, that is, in these particular conditions, you can find achalasia cardia simultaneously. In case of Chagas disease is caused by Trypanosoma cruzi infection. Then diabetes mellitus, then amyloidosis, sarcoidosis, systemic sclerosis, and dorsal motor nuclei lesion. It is also found in case of Allgruber syndrome. See, Allgruber syndrome, it is also called as triple A syndrome. Why? Because it is associated with three A's. First A, achalasia, which is the achalasia cardia. Second A, alacremia. Alacremia means there is either absence or reduced TR production. Then ACTH resistant adrenal insufficiency. Okay, so those are the three A's of Allgruber syndrome. Now combine those three A's together. A. Allgruber. Now take the S of the syndrome, S. So there is genetic mutation of AAAS gene, triple AS gene. It is also found associated with Sjogren's syndrome, and autoimmune thyroid disease. See, both Sjogren's syndrome and autoimmune thyroid disease, they are autoimmune diseases. From here, according to Robbins, this particular scenario suggests that achalasia cardia might be associated with autoimmune reaction as well. So this is the wall of your esophagus. Okay, so this is the wall of the esophagus, which contains the inhibitory neurons. Now your own body makes antibodies against these neurons. As a result, these inhibitory neurons get destroyed. So there are no longer inhibitory neurons, no longer nitric oxide and vasoactive intestinal peptide, no longer relaxation of circular smooth muscle taking place, no longer opening of lower esophageal sphincter, and no longer relaxation of esophagus, and no longer peristalsis. All right, the whole thing revised in one shot. Okay, now let's look at pathogenesis. I said I will be repeating the etiology. Here it is. So pathogenesis is based on what type of etiology we are talking about. First is primary cardiospasm or primary achalasia cardia. And second is secondary cardiospasm or secondary achalasia cardia. Primary achalasia cardia etiology is congenital. There is failure of migration of neural crest cells. These neural crest cells, they form inhibitory neurons. This is the esophagus, the wall of the esophagus, and these are the inhibitory neurons. Now, during the formation, during embryological development, the neural crest cells, they come and then they form these inhibitory neurons. If they don't migrate to esophagus, there is no formation of inhibitory neurons, and this is how there is absence of inhibitory neurons by birth. Okay, no inhibitory neurons at all. Secondary cardiospasm or secondary achalasia cardia. I'll take an example. So these are all secondary causes of secondary cardiospasm. I'll take the example of Chagas disease. Chagas disease. I said earlier, in Chagas disease, the infection of what is seen? The infection of Trypanosoma cruzi is seen, and let me underline Trypanosoma cruzi because that's the nomenclature, the rule of nomenclature, right? All right. So there is infection of Trypanosoma cruzi. What does this infection result in? It results in the destruction of inhibitory neurons. So here's the wall of the esophagus. Wall of the esophagus. The wall of the esophagus contains these inhibitory neurons. Inhibitory neurons, they were formed from the neural crest cells. In primary achalasia cardia, the migration of the neural crest cells does not take place. As a result, inhibitory neurons are not formed. In secondary achalasia cardia, the inhibitory neurons are there, but since there is infection by Trypanosoma cruzi, they go and destroy these inhibitory neurons. All right. Primary achalasia cardia, there are no inhibitory neurons. Secondary achalasia cardia, there were inhibitory neurons but got destroyed by Trypanosoma cruzi infection. As a result, at the end of the day, since there is a reduced inhibitory neuron or no inhibitory neuron, there is no neurotransmitter, nitric oxide and vasoactive intestinal peptide. As a result, there is no relaxation of lower esophageal sphincter, and you get the disease. Okay, grossly see. The lower esophageal sphincter, it remains closed due to increased tonicity of lower esophageal sphincter due to continuous contraction of circular smooth muscle. Now what will happen? Food will come. Food will not enter into the stomach. Swallowing will not take place. Accumulation of food will take place in the distal part of the esophagus. As a result, the esophagus dilates. So there is dilation of esophagus. Now, two possible cases are there to take place grossly in the wall of the esophagus. First, there is accumulation of food here, right? There is food. All right. Now, there are no inhibitory neurons, but the stimulatory neurons are still there. Means the contraction is taking place. It's just relaxation that does not take place. Due to continuous contraction of the smooth muscle, hypertrophy of the smooth muscle takes place and the wall of the esophagus becomes thick. There is thickening of the wall of the esophagus due to hypertrophy of the smooth muscle lining the esophagus, due to continuous contraction, due to continuous stimulation by stimulatory neurons producing acetylcholine and substance P. Okay. Second case. So this is cardiospasm. Or achalasia cardia with thick esophageal wall. Now, with thin esophageal wall. See, eventually so much food is collected or accumulated that the esophagus dilates. The esophagus dilates so much so that there is stretch in the wall of the esophagus. The wall of the esophagus stretches so much so that it becomes very thin. Okay, this is how you get thin-walled cardiospasm or achalasia cardia. How? Due to immense accumulation of food, increased dilation of esophagus, resulting in increased stretching of the wall of the esophagus, leading to thinning of the wall of the esophagus. Okay, now clinical features. What is happening? There is permanent closure of the lower esophageal sphincter. So the food from the esophagus does not reach the stomach. So there is difficulty swallowing, which is also called as dysphagia. Difficulty swallowing, dysphagia. Now this is very important. It is more difficult swallowing liquid as compared to solid in achalasia cardia. How? See, our normal mind would think that it would be much more difficult to swallow solid because they are present as solid chunks and large pieces as compared to liquid, which would be easy to sip in, which would easily sip in. Why is it that it's more difficult to swallow liquid as compared to solid? Why? First, small concept. If there is, let's say, tumor within the esophagus, right? Tumor within the esophagus, then this tumor will block the passage of large particles of food, large chunks of food, right? So it is more difficult swallowing solid. On the other hand, the liquid will simply seep through the gap. It will simply seep through the gap. So in case of esophageal tumor, there is more difficulty swallowing solids as compared to liquid. But in Achalasia cardia, this is what happens. The solid food is able to push through the sphincter and enter the stomach. Due to the size of the solid food, it can create enough pressure to push against the resistance, push against the closed lower esophageal sphincter. But liquid, on the other hand, it does not have the capability to create that much force. So it is much more difficult to swallow liquid as compared to solid. Got it? All right. Second, difficulty belching. When you eat food, along with food, what enters the stomach is also air. And this air has two ways to go, up and down. When it goes up, what happens? Burping takes place. Dhaka, right? The medical term for burping is belching. But remember, burping is usually associated with the production of sound as well. But belching does not necessarily mean that there has to be sound. Belching simply means air coming out of the stomach through your mouth. All right. Now, since the lower esophageal sphincter is closed, how will air come out? It won't come out. So air will remain trapped within the stomach. So there is difficulty belching. Third is chest pain. Since there is accumulation of food in the esophagus dilates, the esophagus is present behind the chest. So there is chest congestion and pain. Diagnosis. Number 1, barium swallow. When you perform a barium swallow, you will be able to notice the dilated esophagus that eventually terminates with a tapering end. Why a tapering end? Because there is contraction of the lower esophageal sphincter. Since there is contraction of the lower esophageal sphincter, all the barium remains within the esophagus. It does not enter the stomach. The barium will not enter the stomach. The lower esophageal sphincter is closed. I said that it is much more difficult to swallow liquid. So barium, it's even much more difficult for it to enter the stomach. So all the barium remains within the esophagus and not enter the stomach. So there is accumulation of barium within the esophagus. So there is dilated esophagus with tapering end. Due to dilated esophagus, it looks like a cucumber, and the tapering end, it looks like a beak of a bird or the tail of a rat. So it is also called bird beak appearance or rat tail appearance. Next is endoscopy. You fit a camera in a tube and then you insert the tube through the esophagus and then look at the distal end of the esophagus. You will see that the lower esophageal sphincter is permanently closed, giving rosette appearance. Third, and this is the gold standard. What you do is enter a tube which has a manometer, throughout it. The manometer will detect the pressure exerted on it. Now see, this is the lower esophageal sphincter which is completely closed. You push in a manometer. What is gonna happen? The high tonicity of the lower esophageal sphincter, the contracted lower esophageal sphincter will contract on this manometer as well. It will compress the manometer. It is compressing the manometer. It is tightly compressing the manometer. So the reading will come high as well. So an increased tone of lower esophageal sphincter is detected with the help of high resolution manometer. As for treatment, so there are two. First, the surgical treatment. Remove the extra muscle due to the hypertrophy. Cut it, remove it. This is Heller's myotomy. Another is drug therapy. In drug therapy, see, you can either increase nitric oxide because that will cause the relaxation of the sphincter. So you can give nitric oxide releasing drugs like nitrates, or you could stop acetylcholine, because acetylcholine secreted from stimulatory neurons cause the contraction of and closure of lower esophageal sphincter. So if you stop the activity of the acetylcholine, you stop acetylcholine, this will relax and open. So you can give botulinum toxin, which reduces acetylcholine, or you could simply give calcium channel blocker, which causes the relaxation of muscle. Calcium channel blocker causes the relaxation of the muscle, and eventually the lower esophageal sphincter will open. Risk. See, normally you might know that for esophagus, we have the upper 1/3, the middle 1/3, and the lower 1/3. The upper 1/3 usually shows squamous cell carcinoma. The middle 1/3 also shows squamous cell carcinoma, but the lower 1/3 of the esophagus shows adenocarcinoma. However, Achalasia cardia, which is a precancerous condition, is an exception. Achalasia cardia can cause in lower 1/3, lower part of the esophagus, distal part of esophagus, squamous cell carcinoma. Normally adenocarcinoma, but Achalasia cardia can cause squamous cell carcinoma. And with that, we are done with Achalasia cardia. One last revision. What is Achalasia cardia? Accumulation of food in distal esophagus due to permanent closure of lower esophageal sphincter, which is associated with the triad of three things. Number one, aperistalsis. Peristalsis in the esophagus does not take place. Number two, failure of relaxation of lower esophageal sphincter. The lower esophageal sphincter does not relax. And number three, increased tone of lower esophageal sphincter. Since the lower esophageal sphincter is continuously contracted, it is at a high tonicity. Etiology. Your primary Achalasia cardia due to congenital reason, and secondary Achalasia cardia due to infection, due to Chagas disease, diabetes mellitus, sarcoidosis, amyloidosis, systemic sclerosis, dorsal motor nuclei lesions, L group syndrome, Sjogren syndrome, and autoimmune thyroid disease. In L group syndrome, it's also called AAA disease because three different conditions are seen at once. A for Achalasia, another A for alacrimia, and another A for ACTH resistant adrenal insufficiency. This is caused due to AAA gene mutation. Pathogenesis. Primary cardiospasm due to congenital reason, that is, there is failure of migration of neural crest cells. As a result, inhibitory neurons are not formed. Secondary cardiospasm, there is Chagas disease, trypanosoma cruzi infection, destruction of inhibitory neurons, so decrease in inhibitory neurons. Overall, there is no neurotransmitter, nitric oxide, and vasoactive intestinal peptide. As a result, relaxation does not take place. Gross. So there is continuous and permanent contraction of lower esophageal sphincter, accumulation of food in the distal esophagus, so there is dilation of the esophagus, and since the wall is continuously contracting, there might be hypertrophy and a thickening of the wall, but if there is too much dilation due to stretch of the wall, thinning of the wall might take place. Clinical feature, there is dysphagia, difficulty swallowing because the lower esophageal sphincter is closed, so the food can't pass from esophagus to stomach. It is more difficult swallowing liquid as compared to solid, because solid can at least push against the resistance, but liquid can't do that. Difficulty belching or removing air from the stomach through the mouth, and there is chest pain. Diagnosis, barium swallow shows cucumber-like esophagus with bird beak or rat tail appearance of the tapering end. Endoscopy shows closed lower esophageal sphincter with rosette appearance. Esophageal manometry shows high tone of the lower esophageal sphincter, and this is the gold standard. Treatment, either perform surgery called Heller's myotomy, or give drugs like nitric oxide releasers or acetylcholine reducers or calcium channel blockers. Risk, it is precancerous and can develop into squamous cell carcinoma in the lower part of the esophagus. Yeah, we are done with Achalasia cardia, both pathology as well as physiology. This is a question for pathology as well as physiology, so you are good for both of them. In the previous video, we learned about a pathology where the lower esophageal sphincter did not want to open. In this video, we are going to look at a pathology where the lower esophageal sphincter remains open and does not want to close. So the topic is GERD, or gastroesophageal reflux disease. See, normally when you are not swallowing any food, the lower esophageal sphincter, it remains closed. Why does it remain closed? It remains closed to prevent the acidic gastric content from the stomach to enter the esophagus. What will happen if it does enter the esophagus? See, the acidic content of the stomach, which is rich in HCl, has a very low pH, so it is highly corrosive, so it can easily damage the wall of gastrointestinal tract. However, the wall of stomach is lined by a thick layer of mucus and bicarbonate, which protects the wall of the stomach from the harmful activity of HCl. But the wall of the esophagus is lined by non-keratinized stratified squamous epithelium. Due to stratification of the epithelium, it provides resistance to abrasion, but it is sensitive to HCl. So if this acidic gastric content enters inside the esophagus, it is going to damage the wall of the esophagus. Why? Because the wall of the esophagus, it is not lined by mucus. That's why. Alright, so that is exactly why normally when you are not swallowing any food, the lower esophageal sphincter, it remains closed. But let's say due to any etiological reasons, due to any pathological reasons, there is opening of the lower esophageal sphincter even when you are not swallowing any food. What will happen? The gastric content, the acidic gastric content with low pH will enter the lower part of the esophagus, will reflux, regurgitate, come back into the lower part of the esophagus and burn the esophagus or damage the esophagus. This is gastroesophageal reflux disease. First definition. So the name tells itself. It's a pathological condition. So a disease which is associated with reflux or coming back or regurgitation of what? Acidic gastric content from stomach to esophagus. From stomach, referring to gastro, to esophagus, referring to esophageal. So gastroesophageal reflux disease, regurgitation of acidic gastric content from stomach back into the esophagus due to transient opening of lower esophageal sphincter, due to transient relaxation or opening of lower esophageal sphincter, which brings the most important question to which the answer you need to know. That is, why is it that lower esophageal sphincter in gastroesophageal reflux disease is transiently open even when you are not swallowing? So these are the reasons why. First, due to increase in intra-abdominal pressure. For example, when you cough, okay, I don't know how I coughed right now, but when you normally cough, there is increase in intra-abdominal pressure. As a result, the lower esophageal sphincter, it temporarily opens, allowing for gastric content to regurgitate back. Similarly, other reasons could be straining or bending, then aging, smoking, alcohol abuse, use of drugs like nitric oxide releasers, and anticholinergic. They reduce the tone of lower esophageal sphincter. Normally, the tone of lower esophageal sphincter is 10 to 30 mm of Hg. But if the tone becomes less than 10 mm of Hg, the lower esophageal sphincter, it is going to relax and remain open. So with increase in age, the tone decreases. With smoking, the tone decreases. With alcohol abuse, the tone decreases. With use of drugs like nitric oxide releasers like nitrates. See, what is nitric oxide? Naturally, it is present in your body as a neurotransmitter. And nitric oxide is responsible for opening of lower esophageal sphincter. Naturally. Now you are giving nitric oxide supplement from outside as well. So there is addition of nitric oxide. That means the lower esophageal sphincter is going to open for an even longer period of time. Similarly, anticholinergics, that also reduces the tone of lower esophageal sphincter. Third, hiatal hernia. The thoracic part of the esophagus enters the abdomen and connects with the stomach by passing through the diaphragm, through an opening in the diaphragm, which is called esophageal hiatus. Again, there is thoracic part of the esophagus within the thorax, and the abdominal part of the esophagus within the abdomen, which meets with the stomach. The esophagus, it pierces through the diaphragm and passes through an opening in the diaphragm, which is called the esophageal hiatus. The gastroesophageal sphincter or the lower esophageal sphincter is present right here, that is below the diaphragm at junction of abdominal part and the stomach itself. In hernia, pulling out takes place or pulling back takes place. In hiatal hernia, pulling back of structure from esophageal hiatus takes place. So the abdominal esophagus along with the lower esophageal sphincter and part of stomach gets pulled back from abdomen into the thorax. You can see right here, part of stomach, the esophagus and the lower esophageal sphincter has been pulled back from the abdomen into the thorax. As a result, the lower esophageal sphincter, the lower esophageal sphincter remains open. Alright, clinical features. See, due to reflux of acidic content from the stomach into the esophagus, into the lower part of the esophagus, the burning of esophagus takes place. The lower part of esophagus is present right in the location where the heart is present. So burning of the lower part of the esophagus feels as if your heart is burning. Next, due to continuous trauma to your lower part of the esophagus, there is presence of formation of ring in the lower part of the esophagus, which makes it difficult in swallowing food. So there is dysphagia. Third, since the pain is in the lower part of the esophagus, which is present at the region where the heart is present, so due to GERD, when chest pain is experienced, it is often confused with angina seen in ischemic heart disease. However, this is not angina. This is chest pain, which is also accompanied by burning sensation in GERD. Diagnosis. So the gold standard for diagnosis is 24 hours ambulatory pH monitoring. Here, a catheter is introduced through your nostril into the esophagus and then it is pushed till the lower part of the esophagus. And then it is connected with a monitor. It detects the pH in the lower part of the esophagus. Let's say this person has GERD. As a result, the acidic content from the stomach, it regurgitates in the lower part of the esophagus. As a result, the pH in the lower part of the esophagus, it decreases. And this is detected by the monitor. And this is how the GERD is diagnosed. GERD has 4 major complications: reflux esophagitis, Barrett esophagus, adenocarcinoma, and Sjogren's ring. All 4 of them are important topics that are gonna have their own individual lectures. Alright, done? Revision. First, definition. Gastroesophageal reflux disease. There is a reflux of acidic gastric content from the stomach to the lower part of the esophagus due to transient relaxation of lower esophageal sphincter. The reasons behind transient relaxation of lower esophageal sphincter are: number 1, increase in intra-abdominal pressure due to straining, coughing, bending; decrease in tone of lower esophageal sphincter due to aging, smoking, alcohols and drugs; and hiatal hernia. It can lead to clinical features like heartburn, dysphagia due to ring formation in lower part of esophagus, and chest pain like that seen in ischemic heart disease. Diagnosis. The gold standard is 24 hours ambulatory pH monitoring. Complications: reflux esophagitis, Barrett esophagus, adenocarcinoma, and Sjogren's ring. So we are starting off with reflux esophagitis or esophagitis. Esophagitis. Inflammation of esophagus is esophagitis. Reasons behind inflammation of esophagus. So you can remember it as @price. P-R-I-C-E. P for pills. Very important, bisphosphonate. Bisphosphonate is orally given drug that is given for osteoporosis, drug therapy for osteoporosis. After you take bisphosphonate, you are supposed to walk or stay erect for at least 30 minutes. You are not supposed to lie down. Because if you lie down, the bisphosphonate drug particle, it is going to stick on the wall of the esophagus and cause inflammation of esophagus. Second, reflux. Like gastroesophageal reflux disease, there is a reflux of gastric acidic content from stomach into the esophagus, causing the burning of esophagus and the inflammation of esophagus. Infection. So there is a famous triad of infection that causes esophagitis, which contains two viruses, herpes simplex virus and cytomegalovirus. They cause viral esophagitis. And the third is a fungus, which is Candida, which causes fungal esophagitis. Another important thing to know is that these infection is there in an immunocompromised patient. For example, the patient has HIV, so he's HIV positive. As a result, the immunity is low. In such patient, there is frequent infection of herpes simplex virus, cytomegalovirus, and Candida. But there is one exception. That is, herpes simplex virus infection is seen even in immunocompetent patient. All right. C4, caustic. That is upon eating, drinking acid or base. For example, children in house can accidentally drink chemical substances found in bottles. Or adults might drink acid and base as a method to end their life. Eosinophilic. All right, so there's lots of eosinophil, and then eosinophil is seen during allergy. So it is related with atopy. So the etiology is at the rate PRICE, price. P for pills, like bisphosphonate. R for reflux, like in case of gastroesophageal reflux disease. I for infection. There are two viruses, herpes simplex virus and cytomegalovirus, and one fungus, Candida. C for caustic, like acid and base. And E for eosinophilic, seen in allergy. Out of all these, this eosinophilic esophagitis, infectious esophagitis, and reflux esophagitis is important, and you need to know them in more detail. Starting off with infectious esophagitis, again the triad. So in immunocompromised patient, the infection of fungus like Candida and virus like cytomegalovirus and herpes simplex virus can cause infectious esophagitis. Remember, herpes simplex virus can affect individuals that are immunocompetent as well. Alright, so we are dividing infectious esophagitis into fungal esophagitis and viral esophagitis. Under fungal esophagitis, we have candidal esophagitis. So in candidal esophagitis, upon carrying out endoscopy, you will see this on the wall of the esophagus. So there is curdy white pseudomembranous lesion. You can see right here, they look like curd and they are present in the form of pseudomembrane, curdy white pseudomembranous lesion. See, you might have learned fungus in microbiology, and under classification of fungus on the basis of morphology, you have yeast-like, mold, and dimorphic. Yeast-like refers to those having pseudohyphae, and the example of which is Candida. So Candida, it is yeast-like fungus with presence of pseudohyphae. So under microscopy, you're going to see the pseudohyphae of Candida. As simple as that. Okay. Next, viral esophagitis, under which we have infection due to two viruses, cytomegalovirus and herpes simplex virus. I'm going to compare both of them. First, the morphology. So C for cytomegalovirus. So C for sallow. So in cytomegalovirus, there is sallow ulcer on the wall of the esophagus. Herpes simplex virus, you will find punched out ulcer. In cytomegalovirus, sallow ulcer. In herpes simplex virus, punched out ulcers. In cytomegalovirus, see, generally what happens, there's your virus which causes infection, and inside the cell, it forms various bodies which is known as inclusion bodies. In case of cytomegalovirus, the type of cell it infects is either the endothelial cell of capillaries, or the stromal cell. And the inclusion bodies that it forms are either within the nucleus of the endothelial cell or stromal cell, so nuclear inclusion bodies, or within the cytoplasm of the endothelial cell or stromal cell, or the cytoplasmic inclusion bodies. Due to the nuclear inclusion bodies that cytomegaloviruses are found as inside the cells, it gives off owl eye appearance. Second is herpes simplex virus. Again, you have the virus which is present within the cell in the form of inclusion body. Now the cell herpes simplex virus is affecting is the epithelial cell, the squamous cell, the squamous cell of esophagus, and the inclusion bodies are nuclear inclusion body. It is present within the nucleus. As a result, the squamous cell, they are multinucleated. Next, eosinophilic esophagitis. E is which alphabet? A, B, C, D, E. It is the fifth alphabet. So the interleukin that is responsible for causing eosinophilic esophagitis is interleukin 5. Next, eosinophilic, that is there is love for eosinophils. That means there are a lot of eosinophils, and eosinophils are seen during allergy. That means it is associated with atopic triad. In atopic triad, you are able to see number 1, allergy, number 2, atopic dermatitis, number 3, atopic rhinitis, and there may or may not be asthma. Grossly, if you look at the endoscope of the esophagus, you will see esophagus present as stripes of a cat tail. So stripes of cat tail. That's why it's called feline esophagus. Microscopy. Microscopically, eosinophilic esophagitis can be distinguished from reflux esophagitis easily on the basis of number of eosinophils. So in reflux esophagitis, the number of eosinophil is normal, but in eosinophilic esophagitis, there is increase in number of eosinophil. It is more than equals to 15 per high power filled. So lots of eosinophil. Third, reflux esophagitis. You can see erosion of the esophagus. So first there is gastroesophageal reflux disease. As a result, the acidic content from the stomach, it regurgitates in the lower part of the esophagus. As a result, the lower part of the esophagus is affected and there is inflammation of the lower part of the esophagus, and this is called reflux esophagitis. But reflux esophagitis can worsen into Barrett esophagus, which is a topic of its own. That's it. All right, one last revision. Esophagitis. Inflammation of esophagus is called esophagitis. Causes for esophagitis. Remember it as PRICE. P for pills. Most important, bisphosphonate. You are not supposed to lie down after taking bisphosphonate. Stand erect or walk for at least 30 seconds. Because if you lie down, the particles of the bisphosphonate will stick on the wall of the esophagus, causing esophagitis. R for reflux. Reflux esophagitis. When there is gastroesophageal reflux disease, there is reflux of acidic content from stomach into the esophagus, causing burning of the lower part of the esophagus and inflammation of the lower part of the esophagus, called reflux esophagitis. I for infection. So there is famous triad of 2 viruses, herpes simplex virus and cytomegalovirus, and 1 fungus, candida. The infection is seen in immunocompromised patient with exception of herpes simplex virus, which can even infect immunocompetent patient. C for caustic. So let's say children in house will drink acid or base, or adult drinks acid or base to kill himself. That causes esophagitis. E for eosinophilic, that is due to allergy because there is increase in number of eosinophils. First, infectious esophagitis. We have fungal esophagitis and viral esophagitis. In fungal esophagitis, we have due to candida, so candidal esophagitis. Grossly, in endoscopy, you will be able to see gaudy white pseudomembranous lesion. Microscopically, since candida, it is fungi, it is yeast-like, so there is presence of pseudo-hyphae. Viral esophagitis due to 2 viruses, cytomegalovirus or herpes simplex virus. Cytomegalovirus results in sallow ulcer. Herpes simplex virus results in punched out ulcer. Cytomegalovirus, microscopically, it is found in the form of nuclear and cytoplasmic inclusion bodies inside which cells? Inside either the endothelial cells of capillary or the stromal cell, resulting in owl eye appearance of the cell. The owl eye appearance is due to nuclear inclusions, particularly herpes simplex virus. It is found within the epithelial cell, which the squamous epithelial cells lining the wall of the esophagus. Which type of inclusion bodies are there? Nuclear inclusion bodies are there. As a result, what happens? Multinucleated squamous cells are present. Eosinophilic esophagitis. E is A, B, C, D, E. So it's the fifth interleukin that causes eosinophilic esophagitis, which is associated with allergy, and endoscopy shows feline esophagus because the esophagus looks like that of a striped cat tail. Microscopically, there is at least 15 eosinophils per high-power field. Then reflux esophagitis, there is gastroesophageal reflux disease, which results in reflux esophagitis, which worsens into Barrett esophagus, which is the topic for the next lecture. In a patient with gastroesophageal reflux disease, the acidic gastric content from the stomach regurgitates into the esophagus and damages the wall of lower esophagus. But why not the wall of stomach? See, the wall of stomach, it is lined by columnar epithelium with goblet cells. And these goblet cells, they produce a large amount of mucus. So there's a thick layer of mucus protecting the wall of the stomach from the harmful act of HCl. But the wall of the esophagus, it is lined by stratified squamous, non-keratinized stratified squamous epithelium. This is resistant to abrasion but sensitive to HCl. Why is it sensitive to HCl? Because unlike stomach, the wall of the esophagus, it is not protected by mucus. So if HCl from the stomach, it will enter the esophagus, there is no mucus to protect esophagus. So the wall of the esophagus will get damaged. Okay. When there is continuous damage by HCl due to frequent regurgitation, like in case of chronic GERD, that is gastroesophageal reflux disease, for a long period of time. Since the patient has GERD for a long period of time, there is frequent regurgitation of HCl. So there is damage by HCl for a long period of time. When there is continuous damage, what will happen? The lower esophagus will eventually show adaptation to protect itself from the harmful act of HCl. What kind of adaptation? See, the stomach was lined by columnar epithelium with goblet cells that could produce mucus, and this protected the wall of the stomach. Similar type of cells are formed in lower esophagus as well. Wait, what? But the lower esophagus is lined by squamous epithelium. How will it form columnar epithelium? It forms columnar epithelium by a process where the stem cells, the basal cells, the stem cell responsible for producing new cells in the esophagus, it gets reprogrammed. So initially it was programmed to form squamous epithelium. Now it gets reprogrammed to form columnar epithelium. As a result, new cells that get formed in the lower part of the esophagus are no longer squamous epithelium. They are now columnar epithelium, and this is called columnar metaplasia. Since these columnar epithelium represent the columnar epithelium lining the intestine, it is also called intestinal metaplasia. What's the importance? What's the benefit? See, after there is intestinal metaplasia, it contains mucus cells. The mucus cells can produce mucus. The goblet cells can produce mucus. So if HCl from the stomach regurgitates into the esophagus, even if it regurgitates, there is mucus protecting the esophagus. That's the benefit. Mucus is protecting the esophagus from the harmful act of HCl. And this part of the esophagus, I repeat, the part of the lower esophagus where columnar metaplasia has taken place in response to chronic gastroesophageal reflux disease is called Barrett's esophagus. It is not the whole esophagus, it is only the part of the lower esophagus that shows columnar metaplasia as adaptation in response to GERD. That is Barrett's esophagus. So what change takes place due to formation of Barrett esophagus? This is what happens. See, initially, when everything is normal, the junction between squamous epithelium and columnar epithelium is present between esophagus and stomach. Because esophagus, it is completely lined by squamous epithelium, and stomach, it is completely lined by columnar epithelium. So the junction is also present in between esophagus and stomach. But after the formation of Barrett esophagus, the junction which was present right here, it shifts upward. The junction, it shifts upward. So the junction is now present within the esophagus. The junction is present within the esophagus. See, so there is squamous epithelium and there is columnar epithelium, and the junction is present within the esophagus in between the normal esophagus with squamous epithelium and Barrett's esophagus with columnar epithelium. So at the end of the day, what is Barrett's esophagus? Barrett's esophagus is the part of the lower esophagus that has gone through columnar metaplasia or intestinal metaplasia due to continuous stress from HCl due to chronic gastroesophageal reflux disease. Alright, pathogenesis. First, there is chronic GERD. Chronic GERD. As a result, there is continuous reflux of HCl. So there is continuous damage to the lower part of the esophagus. In response to it, the basal cells or the stem cells, they go through reprogramming. And instead of making squamous cells, they start making columnar cells. No longer squamous cells, now columnar cells. And these columnar cells, they are able to produce mucus, which protects the lower part of the esophagus from the harmful act of HCl. So there is adaptation, protective adaptation. And this change from squamous epithelium to columnar epithelium, like the one lining the intestine, is called columnar metaplasia or intestinal metaplasia. That is the pathogenesis. First, there is chronic gastroesophageal reflux disease. As a result, there is continuous stress by acid. So the stem cell shows reprogramming. Now it forms columnar epithelium instead of squamous epithelium, which represents that of the epithelium lining the intestine. So it is called columnar metaplasia or intestinal metaplasia. As a result, the junction present right here shifts upward. There is upward shifting of the squamo-columnar junction. The junction is present within the esophagus in between normal esophagus and Barrett esophagus, and all of this is taking place as an adaptive protection against the harmful act of HCl in esophagus due to reflux. That's pathogenesis. Now, complication. First, you have the normal esophagus, which is lined by non-keratinized stratified squamous epithelium. Now, in chronic gastroesophageal reflux disease due to continuous stress by HCl, 10% of the patient, they end up developing Barrett's esophagus. Barrett's esophagus is the part of the lower esophagus where columnar metaplasia results in conversion of squamous epithelium to simple columnar epithelium. Now, once the stress is removed, that is, the gastroesophageal reflux disease is healed, there is no longer stress by HCl, the Barrett's esophagus will reverse back to normal esophagus. Okay? But if the gastroesophageal reflux disease is not healed, there is continuation of the stress by HCl, it will eventually become dysplastic, and this dysplasia will lead to adenocarcinoma. So one of the most common risk factor for adenocarcinoma of lower 1/3 of esophagus is Barrett's esophagus. Remember this, Barrett's esophagus is the most common risk factor responsible for causing adenocarcinoma of lower 1/3 of esophagus. Gross. So normally there is proper demarcation between stomach and esophagus. The esophagus, the wall of the esophagus, it looks pale and pink. But once there is formation of Barrett's esophagus, this demarcation is lost because there is continuation in the mucosa. See right here, I said earlier, initially the junction is present right here in between esophagus and stomach. So there is clear demarcation between stomach and esophagus. But eventually what will happen, this demarcation is lost. The squamous epithelium is no longer there. There is continuation in the epithelium. There is continuation in the columnar epithelium. The same thing is seen grossly. So normally there is proper demarcation between esophagus and stomach. But once there is formation of Barrett esophagus, this demarcation is lost. There is continuation in the mucosa. See, so this is the gastroesophageal junction. This is Barrett's esophagus, and this whole thing from here onwards, that's the normal esophagus. So the normal esophagus, it is pale, it is pink, but the Barrett's esophagus, it is red, velvety, salmon-like. You can see right here, the normal esophagus, it is pale, it is pink, but then the Barrett's esophagus, it is red, velvety. Here is the gastroesophageal junction, which is lost. You can't see the gastroesophageal junction here. The gastroesophageal junction is not well demarcated. It is continuous with the esophagus. Now, another important concept that you need to know. Depending on the length of the Barrett esophagus, it is of two types. You have short segment Barrett esophagus and long segment Barrett esophagus. If the length of the Barrett esophagus is less than 3 cm, then that is short segment Barrett esophagus. But if the length of the Barrett esophagus is at least 3 cm or more, then that is long segment Barrett esophagus. Remember, long segment Barrett esophagus has a much higher chance of becoming dysplastic and eventually converting into adenocarcinoma. So long segment Barrett esophagus has a higher risk of developing adenocarcinoma as compared to short segment Barrett esophagus. Microscopy. So here's the biopsy of esophagus, or the microscopy of esophagus. The whole thing is the microscopy of esophagus. This is downward and then that's the upward. So normally if you were to look at the microscopy of esophagus, the complete lining epithelium would be what? It would be non-keratinized stratified squamous epithelium. But do you see non-keratinized stratified squamous epithelium lining the whole thing? No, you don't. The lower part, the right part, it is lined by columnar epithelium with lots of goblet cells, This much part of the esophagus, which is lined by the columnar epithelium with goblet cell, is the Barrett esophagus. And here onward, this junction onward, the part of the esophagus lined by non-keratinized stratified squamous epithelium is normal. That's the normal esophagus. So here's the demarcation between the normal esophagus with NKSS and Barrett's esophagus with columnar epithelium with goblet cells. Since Barrett esophagus contains goblet cells, these goblet cells, they contain acidic mucin. And acidic mucin gives Alcian blue stain positive. And this is the diagnostic feature of Barrett's esophagus. So if you look at a microscopy of esophagus, and if you see that the lining epithelium is not a non-keratinized stratified squamous epithelium, instead it is columnar epithelium with goblet cells, and if you apply Alcian blue stain and it comes out to be positive, Alcian blue stain positive, then that's Barrett's esophagus. The presence of goblet cells in the lining epithelium of esophagus is the diagnostic feature of Barrett's esophagus. So Barrett's esophagus, it eventually becomes dysplastic. Dysplasia, it is of two types, low-grade dysplasia and high-grade dysplasia. In low-grade dysplasia, you can see there is clear demarcation in between NKSS and columnar epithelium. And within columnar epithelium, there is nuclear stratification. That is, you will find nuclei in multiple layers. And if you look at a single nuclei, it is densely stained. It is strongly stained due to hyperchromatism. But in high-grade dysplasia, you have appearance cribriform pattern. Cribriform pattern means glands within gland-like pattern. It seems as if there are multiple glands within a large gland. So yeah, that's it for Barrett's esophagus. One last revision. Number one, what is Barrett esophagus? It is the part of the lower esophagus that shows columnar or intestinal metaplasia due to continuous stress by hydrochloric acid due to chronic gastroesophageal reflux disease as an adaptive feature to protect itself from the harmful activity of HCl. Then, what are the complications? So, Barrett's esophagus is one of the most common risk factor for the formation of adenocarcinoma in lower 1/3 of esophagus. Grossly, you can see that the demarcation in between stomach and esophagus is lost. It seems as if the stomach is continuous with esophagus. Now, depending on the length of the Barrett esophagus, it is of two types. If the length is less than 3 cm, it is short segment Barrett esophagus. If it is at least 3 cm or more, it is long segment Barrett esophagus, which has a much higher risk of developing into adenocarcinoma. Microscopically, you'll see that Barrett esophagus is lined by columnar epithelium with lots of goblet cells. And since these goblet cells, they contain acidic mucin, it shows Alcian blue stain positive, and it is the diagnostic feature of Barrett's esophagus. Barrett's esophagus eventually becomes dysplastic that then develops into adenocarcinoma. Dysplasia is of two types, low-grade dysplasia and high-grade dysplasia. In low-grade dysplasia, you can see nuclear stratification as well as hyperchromatism. In high-grade dysplasia, you can see cribriform pattern. Esophageal lacerations refer to any sort of cut or tear on the wall of the esophagus. Now, the most common reason behind esophageal lacerations is frequent vomiting or forceful retching. What is retching? Retching is the act of vomiting without the expulsion of vomitus. That's retching. No, I'm not going to do it again. Alright, so due to frequent vomiting or forceful retching, there is cut and tear on the wall of the esophagus. How? See, in vomiting reflex, there is development of intra-abdominal pressure. Due to increase in intra-abdominal pressure, the lower esophageal sphincter, it opens and the food from within the stomach gets expelled out of the mouth. But since there is frequent vomiting for many times, what happens is that the lower esophageal sphincter gets used to all this vomiting. So even when there is development of intra-abdominal pressure, even when there is development of pressure within the stomach, the lower esophageal sphincter, it does not open. It remains closed. As a result, there is development of pressure within the esophagus. Due to development of pressure within the esophagus, there is pressure trauma on the wall of the esophagus, resulting in cuts and tears and lacerations. Another thing that can happen is that, see, there is development of pressure within the stomach, but the lower esophageal sphincter is closed. Now, due to this increased pressure, the food is trying to come out. But then the food has no way to come out. So it pushes or traumatizes the wall of the esophagus, bringing about esophageal lacerations. Another question. What are the various etiologies or conditions that result in frequent vomiting or forceful retching? You can remember it as A, B, C, F, H. A for alcoholism. B for bulimia nervosa. Bulimia nervosa is an eating disorder where the cycle contains first eating lot of food. So the patient first eats lots of food, but patient now fears in gaining weight. So he or she starts forcefully vomiting, forcefully retching because he or she does not want to gain any weight. He or she eats lots of food but does not want to gain weight. So as a compensation, starts to vomit forcefully, starts to retch forcefully. C for coughing, F for food poisoning, and H for hiatal hernia. There are two types of esophageal lacerations that you need to know: Mallory-Weiss tear and Boerhaave syndrome. So I've compared both of them in a tabular pattern, but once I'm done with it, I'll show all the points in this diagram and everything will be crystal clear. So for now, just hear me out. First, the type of tear. Mallory-Weiss tear is a longitudinal tear. If this is the wall of the esophagus, the tear, it runs along the wall of the esophagus. Boerhaave syndrome has transverse tear. If it is the wall of the esophagus, the tear is a transverse and perforates the wall of the esophagus. Extent. Mallory Weiss tear, it is a superficial tear. That is, it only involves mucosa and sometimes submucosa. Boerhaave syndrome, on the other hand, is transmural. That is, it involves the full thickness of the esophagus. The complete wall of the esophagus gets ruptured or perforated. Location. Mallory Weiss tear is present at gastroesophageal junction. So if this is the esophagus and the stomach, the tear is present around this area. So the tear is present around this area. As a result, the lower part of the esophagus is involved, and sometimes the cardia of the stomach is involved as well. Boerhaave syndrome is around, let me show you. So if this is the gastroesophageal junction, it is around 2.5 centimeter above the gastroesophageal junction. So here's the Boerhaave syndrome perforation. Mallory Weiss tear, it is more common but less severe. So it requires no surgical intervention. See, it is a superficial longitudinal tear. So it will heal on its own. But Boerhaave syndrome, there's a complete perforation through the wall of esophagus taking place. The esophagus is completely perforated. So stuff from inside the esophagus like food and air can leak out of the esophagus and come in the cavity of the chest. So this is less common, more severe, and surgical intervention is required. All right, now focus right here. The two diagrams, it will make everything crystal clear. You have Mallory Weiss tear and Boerhaave syndrome. Number one, type of tear. Mallory Weiss tear, it is a longitudinal tear. So it is along the wall of the esophagus. Boerhaave tear, it is a transverse tear. So it perforates through the wall of the esophagus. You can see right here, you can see the other side or a gap present on the wall of the esophagus. Second, location. So Mallory Weiss tear, it is present at gastroesophageal junction. That is why you can see it extending in the lower esophagus as well as within certain part of the cardia of the stomach. Boerhaave syndrome is present around 2.5 centimeter above the gastroesophageal junction. Number three, extent. So Mallory Weiss tear, it involves the mucosa, but sometimes submucosa as well. So there is tear through the mucosa and sometimes through the submucosa as well. Boerhaave syndrome, the complete thickness of the wall is involved. There is complete thickness, transmural involvement. So there is completely perforation. You can see the inlet and the outlet. Number four, Mallory Weiss tear, it is more common but less severe, and it can heal on its own. It's a superficial longitudinal tear involving only mucosa and submucosa, so it can heal on its own. But Boerhaave syndrome, it is less common, more severe, and requires surgical intervention. It's a tear around 2.5 centimeter above the gastroesophageal junction involving the complete thickness. So there is total perforation. Things from within the esophagus can come out. So it does require surgical intervention. All right. Now Boerhaave syndrome can result in three major complications. Let's see what they are. There are blood vessels within submucosa, right? And if with tear of submucosa, the rupture of blood vessel takes place, there is bleeding. Since in Boerhaave syndrome, there is complete thickness involvement, full thickness involvement, bleeding is to take place for sure. So there will be bleeding. There's gonna be bleeding, 100% bleeding. And all this blood, where will it go? It will come out during vomiting. So there is blood in vomitus, which is called hematemesis. And the act of vomiting is painful. So there is painful hematemesis. Second, there is perforation on the wall of the esophagus. So whatever is present within the esophagus will come in the chest cavity. So there is food will come in the chest cavity. This will result in infection, and that will result in inflammation. There is inflammation of the mediastinum, which is called mediastinitis, and it is painful. So you will experience chest pain. Second, there is air comes out. The mediastinum is filled with air, and this is called pneumomediastinum. This air will accumulate under the skin of the chest, so-called subcutaneous emphysema, that is accumulation of air under the skin of the chest. So this you can hear by auscultating. Upon auscultation, crackling sound is heard, and this is called Haman's sign positive. So 3 complications. There is painful hematemesis, there is chest pain due to infection and inflammation, and there is subcutaneous emphysema, which is accompanied with Haman's sign on auscultation. So that's it. One last revision. So esophageal lacerations refer to cut and tear on the wall of the esophagus. The most common reason behind it is frequent vomiting or forceful retching, which can be due to alcoholism, bulimia nervosa, coughing, food poisoning, and hiatal hernia. There are 2 major types of esophageal lacerations. They are Mallory-Weiss tear and Boerhaave syndrome. In Mallory-Weiss tear, what you see are longitudinal tears. In Boerhaave syndrome, what you see is transverse tear. The Mallory-Weiss tear, it is present at gastroesophageal junction, so there is involvement of lower part of esophagus as well as certain part of cardia of stomach. Boerhaave syndrome is present around 2.5 centimeter above the gastroesophageal junction. Mallory-Weiss tear, it involves the mucosa and sometimes the submucosa as well. Boerhaave syndrome, it involves the complete thickness, that is, there is transmural perforation. Mallory-Weiss tear, it is more common, less severe, and requires no surgical intervention because it can heal on its own because it is simply superficial. Boerhaave syndrome, it is less common, more severe, and it does require surgical intervention because there is complete perforation of the wall of the esophagus. Boerhaave syndrome results in 3 major complications. Number 1, painful hematemesis, that is, there is vomiting where vomitus is seen along there, where blood is seen in vomitus, and the act of vomiting is painful. Chest pain, because since there is perforation, stuff from inside can come out within the chest cavity, leading to infection and mediastinitis accompanied with chest pain. And then subcutaneous emphysema, because air from inside the esophagus leaks in the thoracic cavity, resulting in pneumomediastinum, and then this air will go and collect under the skin of the chest, resulting in subcutaneous emphysema, which can be heard upon auscultation as crackling sound, which is called Haman's sign positive. Esophageal tumors, it's of 2 types. You have benign esophageal tumor and malignant esophageal tumor. The most common benign esophageal tumor is leiomyoma, which is the benign tumor of the smooth muscle lining the wall of the esophagus. And 2 very common malignant esophageal tumors are squamous cell carcinoma and adenocarcinoma. Now the question is, out of squamous cell carcinoma and adenocarcinoma, which is more common? See, the wall of the esophagus is lined by non-keratinized stratified squamous epithelium. So if there were for a carcinoma to originate from the wall of the esophagus, which would most commonly originate? Obviously, the one originating from the squamous cell, because it is lined by squamous epithelium. So obviously, squamous cell carcinoma is more common. So the most common malignant esophageal tumor is squamous cell carcinoma. Now, squamous cell carcinoma and adenocarcinoma have their different location within the esophagus. For that, let's divide the complete esophagus into 3 parts: the upper 1/3, the middle 1/3, and the lower 1/3. In upper 1/3, you see squamous cell carcinoma. In middle 1/3, you see squamous cell carcinoma. In lower 1/3, you see adenocarcinoma. So in simple words, squamous cell carcinoma is mostly seen in upper and middle 1/3 of the esophagus, but adenocarcinoma is mostly seen in lower 1/3 of the esophagus. However, there's an exception, and the exception is Achalasia cardia. I've already mentioned it under the topic of Achalasia cardia, that Achalasia cardia is an exception. It shows squamous cell carcinoma in lower 1/3 of the esophagus, where mostly adenocarcinoma is seen. So that's an exception. Now, let's look at the 2 esophageal carcinoma, the squamous cell carcinoma and adenocarcinoma, one by one. Starting off with squamous cell carcinoma. So squamous cell carcinoma, risk factors, you can remember them as A, B, C, D, E, F, and triple P's or PPPS. A for alcohol, Achalasia cardia. Achalasia cardia results in squamous cell carcinoma of the lower 1/3 of esophagus. B for hot beverages. C for celiac disease. What is celiac disease? So if a patient has celiac disease, he or she is unable to eat gluten containing food cause the body shows autoimmune reaction to gluten. D for drugs as well as radiation. Radiation exposure to wherever esophagus is present, that is the chest or the mediastinum. Then E for epidermolysis bullosa. F for fermented milk. So in Kenya, fermented milk is commonly drank, which is called mursik. And while preparing this fermented milk, charcoal is used. And the charcoal, it contains carcinogenic acetaldehyde. So when you are drinking mursik, you are also drinking charcoal, and with charcoal, you are also taking carcinogenic acetaldehyde, which can cause esophageal carcinoma or squamous cell carcinoma. And then you have the 3 P's. First P, human papilloma virus. Another P, Tylosis palmaris et plantaris, that is hyperkeratosis. There is hyperkeratosis of the palm and the sole of the foot. So you can see thick palm and thick sole of the foot. You can see thick layer of keratin on the sole of the foot and the palm. Then Plummer-Vinson syndrome and SOX2 mutation. That's ABCDEF triple P's. As for adenocarcinoma, the most common risk factor is Barrett's esophagus. I've already mentioned the whole thing under the topic of Barrett's esophagus. So what's that? In Barrett's esophagus, see, firstly you have normal esophagus. The normal esophagus is lined by non-keratinized stratified squamous epithelium. But let's say the person has chronic gastroesophageal reflux disease. As a result, 10% of the person with chronic gastroesophageal reflux disease ends up developing Barrett's esophagus. This Barrett's esophagus then can worsen into dysplasia, and then dysplasia results in adenocarcinoma. In Barrett's esophagus, what happens? This non-keratinized stratified squamous epithelium gets converted into columnar epithelium or intestinal epithelium. This is called columnar or intestinal metaplasia. So obviously, what type of carcinoma is gonna come? Squamous carcinoma from columnar epithelium? No, adenocarcinoma from columnar epithelium. Makes sense. As for mutation, TP53 and CDKN2A mutation are common. In Robbins, it's said that H. pylori has a protective action against adenocarcinoma, and the logic is that H. pylori results in destruction of acid producing cells. So there is decrease in acid within the stomach. So there is decreased chance of development of Barrett's esophagus. So there is decreased chance of Barrett's esophagus worsening into adenocarcinoma. Microscopy in adenocarcinoma, it's glandular carcinoma. So you're going to see lots of gland. There's a gland, 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 lots of gland in esophagus. Squamous cell carcinoma, you're going to see nests of tumor cell, along with what is very popular, keratin pearls in squamous cell carcinoma. So you're going to see keratin pearls as well. Grossly, it can either be polyploid, fungating, or ulcerating, or diffusely infiltrating. Grossly, so in case of adenocarcinoma, since it is seen in the lower part of the esophagus, it can infiltrate the cardia of the stomach as well. See, it is seen in the lower part of the esophagus, so it can infiltrate the cardia of the stomach as well. So there is involvement of gastric cardia seen as well. In case of squamous cell carcinoma, there is transverse mucosal fold formation takes place, which results in formation of strictures. As a result, there is difficulty swallowing or dysphagia. And yeah, that's it. One last revision. So esophageal tumor, the most common benign esophageal tumor is leiomyoma. Malignant tumor, there are two, squamous cell carcinoma and adenocarcinoma, very famous. The most common malignant esophageal tumor is squamous cell carcinoma. As per location, in upper 1/3 and middle 1/3 of the esophagus, you have squamous cell carcinoma. In lower 1/3 of the esophagus, you have adenocarcinoma. Exception in Achalasia cardia, squamous cell carcinoma in lower 1/3 of the esophagus. Now, esophageal carcinoma. First, squamous cell carcinoma. Risk factors: alcohol, Achalasia cardia, hot beverages, celiac disease, drugs, radiation to chest, epidermolysis bullosa, MRSA, human papilloma virus, hyperkeratosis, Plummer-Vinson syndrome, and SOX2 mutation. As for adenocarcinoma, the most common risk factor is Barrett's esophagus. Mutations such as TP53 and CDKN2A mutations are also seen. It is said that Helicobacter pylori has protective action against adenocarcinoma. Microscopically, in adenocarcinoma, you will see glands. In squamous cell carcinoma, you will see nests of tumor cells along with keratin pulse. Grossly, in adenocarcinoma, you can see the involvement of the cardia of the stomach as well. In squamous cell carcinoma, you will see formation of strictures resulting in dysphagia. There are 3 types: polyploid fungating type, ulcerating type, and the diffuse infiltrating type. And we are done. This is a very important video. In this video, I won't be talking about any gastric pathology, nothing about gastritis, nothing about peptic ulcer disease. But all the concepts within this video are very much necessary for you to understand those topics. If you get the hang of the topics taught in this video, I assure you, learning pathogenesis of gastritis and peptic ulcer disease will be a cakewalk. So I want you right now to put your attention in this video, because if you understand this video, the coming videos are going to be much easier. With that being said, what are we going to talk about in this video is about the condition of the wall of your stomach. See, the wall of your stomach is under continuous stress. However, this stress is overcome by protective factors present within the stomach. See, the wall of your stomach is made up of 4 major layers. There's your mucosa, submucosa, muscularis propria, and serosa. Mucosa contains 3 further layers. There's epithelial mucosa, lamina propria, and muscularis mucosa. The epithelial mucosa is composed of simple columnar epithelium. The simple columnar epithelium contains mucus secreting cells as well. Mucus secreting cells and enzyme secreting cells. Mucus secreting cells plus enzyme secreting cells. Okay, that's basic histology that you most probably know. Now, what I'm talking about is the condition of the wall of the stomach along with all these 4 layers: mucosa, submucosa, muscularis propria, and adventitia. The condition of these layers within the stomach wall. The condition of these layers within the stomach wall, or shall I say, the condition of the stomach wall itself, is determined by 2 factors. They are your damaging factors and protective factors. Very easy. Damaging factors are the factors that are continuously trying to damage your stomach. Protective factors are those factors that are continuously protecting the wall of the stomach from damaging factors. All right? Simple thing. Damaging factors trying to damage the wall of the stomach. Protective factors protecting the wall of the stomach from being damaged. Now, simple logic. If damaging factor is more, or let's say protecting factor is less, what is going to happen? The wall of the stomach is going to get damaged. So before understanding about the damage or the injury, you need to understand about what is happening normally in your stomach. Normally, in your stomach, there are factors that are continuously trying to damage the wall of the stomach. And then there are factors that are continuously preventing this damage from occurring. So what are these factors? First, the damaging factors. Within the lumen of the stomach, there are 2 major things. Number 1, hydrochloric acid, and number 2, peptic enzymes. Hydrochloric acid, it has a very low pH of around 1 to 2. So it is highly corrosive. It can easily damage the wall of the stomach. Peptic enzymes, on the other hand, it has the ability to digest Protein. Is the wall of the stomach made up of protein? Obviously, it contains protein. So it can digest the wall of the stomach as well. Acid with very low pH, highly corrosive. Peptic enzyme can digest protein and subsequently can digest the wall of the stomach. That will eventually lead to what? Perforations in the stomach. Perforations in the stomach. But normally, let's take scenario of my stomach, which is normal right now. I don't have any gastritis. I don't have peptic ulcer disease. So normally talking, are there perforations in my stomach? Is the wall of my stomach ruptured? I mean, if it was, I wouldn't be here right now. I would be dead. But anyway, I'm not dead. That's because my stomach is normal. But this doesn't mean inside my stomach there is no acid or peptic enzyme. There is acid and peptic enzyme. There is acid and peptic enzyme. There are damaging factors. But working against these damaging factors are the protective factors. Right? So these are the protective factors present from inside to outside. This green layer that you see right here is nothing but mucus. Mucus is secreted by the surface epithelial cells, also known as the foveolar cells, lining the wall of the stomach. So the foveolar cells or the surface epithelial cells lining the wall of the stomach produces mucus. And this thick layer of mucus, what does it do? Within the lumen, there is HCl, there is HCl, there is HCl, there is HCl. This HCl will not touch the wall of the stomach because there is a physical barrier in between HCl and the wall of the stomach. And that physical barrier is this thick green layer right here, and that is mucus. Next, bicarbonate. The same foveolar cells, they also produce bicarbonate. The bicarbonate is also present along with mucus right here, bicarbonate. The function of which is, so the acid present near the wall of the stomach will get neutralized by the bicarbonate. Neutralized by the bicarbonate. So basically they are no longer corrosive. Next, let's say somehow the H plus from the lumen of the stomach passes through the mucus and the bicarbonate and reaches the epithelium. It is unable to enter inside or leak inside. Why? Because in between epithelial cells, there is presence of tight junction. So tight junction prevents the leakage of H plus ions inside lamina propria. Fourth, epithelial regeneration. The good thing about the epithelium lining stomach is that even if it does get destroyed or maybe it gets old, the thing is they get regenerated really fast. So there is new epithelium forming very quickly. Next, mucosal blood flow. Now, good supply of blood to mucosa means good supply of oxygen and nutrients to mucosa. That means the repair of epithelium can take place very quickly. Lastly, prostaglandin. So specific prostaglandin like prostaglandin E2 has many functions, or shall I say it is involved in almost all of these functions. Like it is responsible for increasing mucus, thickening mucus. It is responsible for epithelial regeneration. It is responsible for increasing mucosal blood flow as well. When there is more blood flow, there is easy repair. But most importantly, it inhibits the secretion of HCl. Within stomach, what takes place? The secretion of HCl takes place. The secretion of this HCl is inhibited by prostaglandin E2. So when there is less HCl, that means there is less damaging factor. Normally, there's lots of protective factors. They easily overwhelm or overcome the damaging factor. That is why normally your stomach is all right. It's fine. Now let's talk about injury. In injury, see, either there is an increase in damaging factors or there's a decrease or impairment of protective factors. Damaging factor can be more. It will damage the wall of the stomach. Or protective factors can be impaired, so it can't protect the wall of the stomach, eventually leading to damage of the wall of the stomach. What can lead to increasing damaging factors? They are NSAIDs. So non-steroidal anti-inflammatory drugs they are COX inhibitor or cyclooxygenase inhibitor. As a result, there will be no COX pathway, and COX pathway is responsible for formation of prostaglandin. So there will be no prostaglandin. If there will be no prostaglandin, there will be increase in level of HCl. Why? Because HCl is inhibited by prostaglandin. But if there is no prostaglandin, there is no inhibition of HCl. That means there will be increase in HCl. Good. Next, Helicobacter pylori. Helicobacter pylori infection. So Helicobacter pylori is urease positive. It can produce urease. Urease will break urea into ammonia, and when there is increased amount of ammonia, what happens? This ammonia, it inhibits bicarbonate transporter. So there is no longer bicarbonate in the mucus lining. Plus, Helicobacter pylori is also responsible for hypersecretion of acid. So it increases the secretion of acid as well, further damaging the wall of the stomach. Another, alcohol, tobacco, radiation, chemotherapy, they have direct damage. That is, they directly go and damage the cells lining the wall of the stomach. Then duodenal gastric reflux. Basically, the content from within the duodenum will reflux or regurgitate back into the stomach, return back into the stomach. And what is present in duodenum? Only two things, bile from liver and pancreatic juices from pancreas. This alkaline fluid, it produces stress on the wall, damages the wall of stomach. That is increase in damaging factors. So NSAIDs increased damaging factor by increasing HCl. Helicobacter pylori increased damaging factor by inhibiting bicarbonate transporter and increasing HCl. Alcohol, tobacco, radiation, chemotherapy increased damaging factor by directly damaging the epithelial lining. Duodenal gastric reflux increased damaging factor by increasing alkaline fluid to putting stress on the wall of the stomach. Now, how can decrease in protective factors take place? Ischemia. When there is ischemia, there is decrease in mucosal blood flow. That means there is decrease in oxygen and nutrients. That means injury takes place, necrosis of cells takes place. Second, shock. Shock eventually leads to ischemia. NSAID. NSAID, it inhibits COX pathway, it inhibits prostaglandin. Prostaglandin is not just responsible for inhibiting the secretion of HCl, it is also responsible for increasing the secretion of mucus and bicarbonate, that is protecting the wall of the stomach. But since prostaglandin is inhibited, there is decrease in mucus, there is decrease in bicarbonate. This is how there is decrease in protective factor. With ischemia, there is decrease in mucosal blood flow, decrease in protective factor. With shock also, there is decrease in mucosal blood flow, decrease in protective factor. NSAID also leads to decrease in mucus and bicarbonate, decrease in protective factor. So be it an increase in damaging factor, that is increase in HCl or decrease in bicarbonate, or be it decrease in protective factor, eventually what happens is that the damaging factor will overcome the protective factor, and this leads to injury. Now, normally the damaging factor is balanced or overcome by, is overcome by the protective factors. Protective factors overwhelm the damaging factors. But in case of injury, there is either an increase in damaging factors which lead to destruction of wall of stomach, or a decrease in protective factor which leads to damage in wall of stomach. Be it an increase in damaging factor or decrease in protective factor, overall damaging factor becomes more than protective factor. And when there is injury, pathologies occur. There are two types of pathology. If there is damage of the wall of stomach without inflammation, that is gastropathy. But if there is damage to wall of stomach with inflammation, that is gastritis. All right, gastritis, if it is for a short period of time, acute gastritis; for a long period of time, chronic gastritis. And gastritis, it can worsen and eventually lead to formation of ulcers. And ulcers, that means there is peptic ulcer disease. What are the signs and symptoms? See, since there is damage in the wall of the stomach, obviously pain is gonna occur in the area where the stomach is present. So epigastric pain with nausea and vomiting. As for signs, mucosal erosion. Mucosal erosion is where part of the mucosa gets ripped off or slowed off. Ulceration. Ulceration is much more deeper. It involves mucosa as well as submucosa. So two terms, mucosal erosion and ulceration. You know that you need to know the difference. First, mucosal erosion, where the mucosa gets ripped off, right? Ulceration, where mucosa is affected plus submucosa is also affected. Hemorrhage. Obviously, since parts are getting slowed up, ripped up, damaged, blood vessels are gonna burst and blood is gonna come out. That is hemorrhage. So within stomach, now there is blood. This blood has two ways to come out, either from here or from here. So if it comes from up here, from the mouth, it can come along with vomitus, and this is called hematemesis. Emesis means vomiting, hemat means present blood, so there is presence of blood in vomit. Second is melena, that is blood in stool. Due to the presence of hemoglobin in stool, the stool becomes dark black in color. Those are the signs and symptoms. All right, one last revision. So there are two factors that determine the condition of the wall of your stomach. Damaging factors, continuously trying to destroy or damage your stomach wall, and protective factors, continuously working to protect the wall of the stomach from damaging factors. Normally, damaging factors include acid and peptic enzymes. So acid within the stomach is trying to burn the wall of the stomach. Peptic enzyme in the stomach is trying to digest the wall of the stomach. But is your stomach digested? Is your stomach burnt? No, it is not. Because of the presence of protective factors working against it. And they are the mucus lining the wall of the stomach that forms a physical barrier between HCl and the wall of the stomach. Bicarbonate within the mucus, which neutralizes the acid near the wall of the stomach. Tight junction in between the epithelial cells of epithelium, right, which prevents the leakage of acid within the wall of the stomach. Epithelial regeneration, as a result, new epithelium gets formed pretty quickly. Mucosal blood flow that provides enough oxygen and nutrients for repair to take place. Prostaglandin like prostaglandin E2, which inhibits the secretion of HCl and regulates HCl secretion, plus increases mucus secretion and bicarbonate secretion. So all these protective factors, normally they overcome the damaging factors, and that's a good thing. Your stomach is healthy and fine. But when there is injury can take place either due to increase in damaging factors or impairment in protective factors. Increase in damaging factors can take place how? For example, intake of NSAIDs that lead to inhibition of COX pathway. As a result, there is decrease in prostaglandin. As a result, there is increased secretion of HCl because HCl is inhibited by prostaglandin E2, but there is no longer prostaglandin E2. That means there is gonna be much more HCl in the stomach. Second, H. pylori infection. It is urease producing bacteria that converts urea to ammonia, and ammonia, it inhibits bicarbonate transporter. As a result, there is no bicarbonate. Decrease in protective factor plus increase in damaging factor, because H. pylori also increases HCl. Then alcohol, tobacco, radiation, chemotherapy, they have direct damage. They directly go and destroy the wall of the stomach. Then duodenal gastric reflux, content from within the duodenum regurgitates or comes back in the stomach. What is in the duodenum? Bile is in the duodenum. Pancreatic juice is in the duodenum. Alkaline fluid, it damages the wall of the stomach. Then decrease in protective factors like ischemia. If there is ischemia, that means there is no mucosal blood flow. That means there is no oxygen and nutrient. That means more injury takes place. That means necrosis of the cell takes place. Damage of the wall takes place. Then shock eventually leads to ischemia and everything that I just mentioned. And then NSAIDs, COX inhibitor, prostaglandin inhibitor. That means there is decrease in mucus, decrease in bicarbonate, because prostaglandin doesn't just inhibit HCl secretion, it also increases mucus and bicarbonate. Since prostaglandin is getting inhibited, that means there is decrease in mucus, decrease in bicarbonate. Overall, be it due to increase in damaging factors or impairment in protective factors, the damaging factor wins, and I mean, that's not a good thing. Why am I cheering up? But that leads to injury and the wall gets damaged. Now, this damage eventually leads to either gastropathy, where there is no inflammation, or gastritis, where there is inflammation. Gastritis can worsen and lead to formation of ulcers. This is called peptic ulcer disease. A small recap of what we have learned previously. So, the condition of the wall of your stomach, more specifically, the condition of gastric mucosa, is determined by two factors. Number one, damaging factors, and number two, protective factors. Damaging factors are those factors that are continuously trying to damage the wall of the stomach. Protective factors are those factors that are continuously trying to protect it from being damaged. Now, normally, the protective factors, they easily overcome or overwhelm the damaging factors. That's why the gastric mucosa is all right. It's fine. It's not injured. However, in case of an injury, now this injury can be due to one out of two reasons. Either due to an increase in damaging factor, all right, or due to impairment of protective factor. So either due to increase in damaging factor or due to impairment in protective factors, what happens? The damaging factors win over the protective factors. The damaging factors, they overwhelm or overcome the protective factors. When damaging factors win, damage is going to occur. So there is going to be mucosal damage. What is there going to be? There's going to be mucosal damage. If this mucosal damage is not accompanied by inflammation, we call it gastropathy. If this mucosal damage is accompanied by inflammation, we call it gastritis. Now, certain gastritis can worsen over a period of time and result in formation of ulcer. Ulcer is much deeper. That is, it is going to go through mucosa and then involve submucosa and sometimes may even perforate the wall of the stomach. How does ulcer formation take place? This formation takes place. See, within the stomach, there is hydrochloric acid. Protecting the wall of the stomach from hydrochloric acid are the protective factors. These protective factors majorly include three things: mucus, thick layer of mucus, bicarbonate, and blood, mucosal blood flow. So either due to an increase in HCl or due to decrease in mucus, bicarbonate, blood, the damage to the wall of the stomach takes place, or the burning of the wall of the stomach by HCl takes place, leading to first gastritis and then eventually ulcer. And when you do have ulcer, this is called peptic ulcer disease. But remember, not all gastritis result in ulcer. Only those gastritis where the HCl burns the wall of the stomach, that leads to ulcer. Only those gastritis that burn the wall of the stomach lead to ulcer, peptic ulcer disease. Again, one last time. Gastritis can lead to peptic ulcer disease, but not all gastritis lead to peptic ulcer disease. Only those gastritis that result in damage to the wall of the stomach by the touching of the HCl leads to peptic ulcer disease eventually when it worsens too much. Okay. Now, the topic for this lecture is gastritis. What is gastritis? It is the inflammation of gastric mucosa. How many types of inflammation do we have? We have two types of inflammation: acute inflammation and chronic inflammation. What is acute inflammation? Short-term inflammation that is accompanied with neutrophilic infiltration. What is chronic inflammation? Long-term or recurrent inflammation that is accompanied with lymphocytic infiltration. So if inflammation is of two types, gastritis is also of two types. You have acute gastritis, where you are going to see what throughout the gastric mucosa? You are going to see neutrophils throughout the gastric mucosa. And you have chronic gastritis, where you're going to see what throughout the gastric mucosa? You are going to see lymphocytes throughout the gastric mucosa. First, acute gastritis. So we have talked about lots of damaging factors already under the topic of damaging factor versus protective factor. Was that out before getting into this video? Because if you don't understand that topic, you are not going to understand the pathogenesis of gastritis and peptic ulcer disease. So you need to know the concept of damaging factor versus protective factor. I already have a lecture on it. You can either watch that lecture or read it from your book, whatever be your choice. But for now, acute gastritis can be caused by any of the damaging factors that I have mentioned, the list of damaging factors, right? At the end of the day, injury to gastric mucosa must take place. If this injury to gastric mucosa results in mucosal damage with inflammation, well, there you go, acute gastritis, where you can see what? Neutrophils in gastric mucosa. Now, out of all these damaging factors, the most common damaging factor is NSAID, or non-steroidal anti-inflammatory drug. What's the mechanism? So non-steroidal anti-inflammatory drug, it inhibits a cyclooxygenase pathway responsible for the formation of prostaglandin. So if there is inhibition of cyclooxygenase pathway, there is also inhibition of formation of prostaglandin. Prostaglandin E2 is responsible for inhibiting the production of HCl to regulate its synthesis and production. Since there is inhibition of prostaglandin E2, that is prostaglandin E2 is not being made, that means there is no one to stop the production of HCl. There's going to be lots of HCl in the stomach. Lots of HCl means what? It is going to go and damage the wall, the mucosa of the stomach, damage it, leading to acute gastritis. Okay. Next, chronic gastritis. Chronic gastritis, I'm going to refer to it as metaplastic atrophic gastritis. And here's why. Gastritis, because there is inflammation of gastric mucosa. There is gastric inflammation, so gastritis. Atrophic, because there is destruction of the wall of the stomach. More specifically, destruction of parietal cells, so loss of parietal cell. So throughout the wall of the stomach or epithelial lining of the stomach, there are bunch of secretory cells. Out of them, one of the most important secretory cells are the parietal cell. The parietal cell. These cells, they are responsible for production of hydrochloric acid and intrinsic factor. There is destruction of these parietal cells, resulting in loss of this parietal cell, resulting in gastric atrophy. So atrophic. Metaplastic, because following gastric atrophy, there is intestinal metaplasia. That's why metaplastic atrophic gastritis. Again, gastritis because there is inflammation of gastric mucosa. Atrophic because there is gastric atrophy due to destruction of parietal cell or loss of parietal cell. Metaplastic because gastric atrophy is followed by intestinal metaplasia. So metaplastic atrophic gastritis. Remember, metaplastic atrophic gastritis. Now, depending on the cause behind the destruction of parietal cell leading to gastric inflammation and followed by intestinal metaplasia. Again, depending on the etiology or the cause behind the destruction of parietal cells leading to gastric inflammation and followed by intestinal metaplasia, we have two types of chronic gastritis. Type A chronic gastritis and type B chronic gastritis. Remember, A for A or autoimmune, B for nothing, just Helicobacter pylori. So A for A or autoimmune. In autoimmune chronic gastritis, the destruction of parietal cells or the loss of parietal cells take place due to autoimmune disorder. That is autoantibodies. That is your own body starts to make antibodies against parietal cells in your stomach. In type B gastritis, it is Helicobacter pylori infection that leads to destruction of parietal cells. Right. Another thing that you need to remember, A is to B and B is to A. What is this mantra? See, type A is to B and type B is to A. That means in type A chronic gastritis, it is the body of the stomach that is mostly affected. In type B chronic gastritis, it is the antrum of the stomach that is mostly affected initially. Later, the complete stomach is affected. Again, what? A for B, B for A. In type A chronic gastritis, body of the stomach is affected. In type B chronic gastritis, antrum of the stomach is affected initially, and later on the complete stomach is affected. But at the end of the day, the concept is, be it type A chronic gastritis or type B chronic gastritis, be it autoimmune chronic gastritis or Helicobacter pylori chronic gastritis, what is taking place? Number one, gastritis is taking place due to gastric inflammation or inflammation of gastric mucosa. Number two, atrophy is taking place due to destruction of parietal cells, and metaplasia is taking place due to intestinal metaplasia. So, they are referred as metaplastic atrophic gastritis. But before you get further confused, I want to make one thing clear. This is something that has been written in Robbins, all right? So in Robbins, if you go through the pathogenesis of type A and type B chronic gastritis, this is what is written. In case of type A chronic gastritis or autoimmune chronic gastritis, it has been referred to as autoimmune metaplastic atrophic gastritis. All right, good. You have autoimmune chronic gastritis, which is also referred to as autoimmune metaplastic atrophic gastritis. I've already explained why. However, in case of type B chronic gastritis, that is Helicobacter pylori chronic gastritis, it has not been referred to as metaplastic atrophic gastritis, but the end result is the same. At the end of the day, it also results in atrophic gastritis with intestinal metaplasia. It's just that this particular term, autoimmune metaplastic atrophic gastritis, has not been written in a separate line, but both of them result in the same thing. That is, both of them result in gastritis due to inflammation of gastric mucosa, atrophy due to destruction of parietal cell, and metaplasia due to intestinal metaplasia. All right, so this was everything in short, but you need to know the mechanism of individual chronic gastritis in detail. So let's look at them. First, type A chronic gastritis or autoimmune chronic gastritis. Here, I have already said that the reason behind gastritis or the reason behind atrophy, that is destruction of parietal cells, is antibodies against these parietal cells prepared by our own body. So there are antibodies against parietal cells prepared by our own body that lead to autoimmune, because there's antibodies against our own cells, gastritis, because there is inflammation of gastric mucosa, atrophic due to destruction of parietal cell, metaplastic due to intestinal metaplasia following destruction of parietal cell. The parietal cell present in your stomach is present to produce hydrochloric acid or intrinsic factor. So if you have antibodies destroying these parietal cell, there's no longer hydrochloric acid and intrinsic factor in your stomach, which results in achlorhydria, absence of hydrochloric acid. Hydrochloric acid is absent. So this is what is going to happen. In your stomach, now there is either no or reduced HCl. Okay, this triggers your body to produce more HCl. There is decrease in HCl. Your body requires HCl for digestion, so body tries to increase the production of HCl. Now, who is responsible for producing HCl? Which hormone is responsible for producing more HCl? It is gastrin hormone. Gastrin hormone. So the body starts producing more gastrin to trigger more production of HCl. Now, which cells are responsible for the production of gastrin hormone? It's the G cells. So the body increases the number of G cells. So there is hyperplasia of G cells. Arey bhai, inside your stomach, the HCl level has gone down because the parietal cells have been destroyed by the antibodies made by your own body. Okay, achlorhydria, there is no HCl or there is decreased HCl, whatever be the case. You require HCl or not? Your stomach requires it, you require it, HCl to digest protein and stuff, you require it or not? So your body now, in presence of decreased HCl, tries to increase HCl. How? By increasing the hormone responsible for production of HCl, and that hormone is gastrin. So the body tries to increase the level of gastrin. How will it do it? It will do it by increasing the number of cells that are responsible for production of gastrin. Cell ही बढ़ा दिया तो gastrin भी बढ़ जाएगा भाई. So increase the number of gastrin, then increase gastrin. So there is achlorhydria, that is no HCl. So the body tries to compensate for it by increasing the number of G cells, hyperplasia of G cells, that eventually lead to increase in level of gastrin in blood serum called hypergastrinemia. So if you test the blood of this particular patient, you are going to find elevated gastrin level. There is hypergastrinemia. Second, decrease in intrinsic factor. Intrinsic factor is responsible for absorption of vitamin B12. So if there is decrease in intrinsic factor, that means there is going to be less absorption or no absorption of vitamin B12, leading to vitamin B12 deficiency in the body. Vitamin B12 is required for the maturation of red blood cell. Folic acid and vitamin B12 is required. So if there is no vitamin B12, maturation of RBC won't take place, leading to anemia. And the type of anemia is a megaloblastic anemia because there is deficiency of vitamin B12. Since there is deficiency of vitamin B12 due to an autoimmune reason, antibodies against the parietal cell, this special type of megaloblastic anemia is called pernicious anemia. Third, since parietal cells are being destroyed, there is continuous stress on the wall of the stomach, stress on mucosa, there is mucosal damage, leading to gastric atrophy because there is loss of parietal cell. So gastric atrophy, and gastric atrophy is followed by intestinal metaplasia. That's why given the name of autoimmune due to antibodies prepared by our own body, metaplastic because there is intestinal metaplasia, atrophic because there is gastric atrophy, gastritis because there is mucosal damage along with inflammatory cells. All right, now I'm going to show you all the histopath that you need to know. First from Robbins and then from Hirschsprung. First from Robbins. So what's the name of the gastritis? It is autoimmune. So you won't have to ratamar anything, just follow me. Autoimmune metaplastic atrophic chronic gastritis. Is this the name or not? It's autoimmune metaplastic atrophic chronic gastritis. Now let's break it down. Chronic gastritis, that means throughout gastric mucosa you can see lymphocytes, so search for lymphocytes. Second, atrophic, so there is going to be gastric atrophy, so you can search for gastric atrophy as well. Third, metaplastic, there is intestinal metaplasia, that means you can search for intestinal you need to search for intestinal metaplasia as well. So search for lymphocytes in gastric mucosa, gastric atrophy and intestinal metaplasia. Let's look at both the histopath. Throughout the gastric mucosa, all these blue dots that you see, they are lymphocytes. They are there due to chronic gastritis. All these bunch of destroyed glands that you see are the atrophic glands. Third, you can see goblet cells right here. Goblet cells are present where? In intestine. But now they are present where? In stomach. That means there is intestinal metaplasia. Whatever was supposed to be in intestine is now in stomach. There is intestinal metaplasia. Here's a small concept for you. The wall of the stomach is also lined by mucus. The wall of the intestine is also lined by mucus. Good. But the mucus secreting cells in the stomach are different than the mucus secreting cells present in the intestine. The mucus secreting cell in the stomach are the surface mucus cell and the neck mucus cell, where the surface mucus cell are referred to as foveolar cells. The mucus secreting cells in intestine are goblet cells. Here, right now, since the epithelium of the stomach shows intestinal metaplasia, that is why along with foveolar cells, the gastric surface mucus cells, along with foveolar cell, you can also see goblet cells. So there are goblet cells in between the foveolar cells. Another concept that you need to know. I hope you remember Barrett esophagus. I have a complete video made on it, crystal clear, everything that you need to know from Viva, MCQ and university exam point of view. In Barrett esophagus, I said that the patient first has chronic gastroesophageal reflux disease. Due to chronic gastroesophageal reflux disease, there is continuous stress by HCl on the lower part of the esophagus, leading to intestinal metaplasia and formation of Barrett esophagus, right? Barrett esophagus. So normally the wall of the esophagus is lined by non-keratinized stratified squamous epithelium, but after intestinal metaplasia, it is lined by simple columnar epithelium along with goblet cell. So the characteristic finding or the diagnostic finding of Barrett esophagus, or the diagnostic feature of Barrett esophagus, is goblet cell. And the way to diagnose it is to use a special stain called Alcian blue stain. The Alcian blue stain stains the Barrett esophagus blue. But why? Here's why. The goblet cells, they produce mucus, and the mucus that they produce is acidic. And Alcian blue stain, it stains the acidic mucus blue in color. That is why the Barrett's esophagus is Alcian blue stain positive. Similarly, the wall of the stomach as well. Initially, normally, it does not contain goblet cell. It contains foveolar cells. Foveolar cell produces mucus. Foveolar cell produces mucus, but this mucus is neutral, so it does not take Alcian blue stain. But after intestinal metaplasia in the stomach, I repeat, just like esophagus, after intestinal metaplasia, there were goblet cells. Similarly, in stomach as well, after intestinal metaplasia, now they are goblet cells. These goblet cells, they contain acidic mucus and they get stained by Alcian blue stain, and they appear Alcian blue stain positive. That's it. So in single line, if I have to say, the wall of the stomach, the Alcian blue stain is negative in case of normal epithelium of stomach, but after intestinal metaplasia, due to the presence of goblet cells, the epithelium of the stomach becomes Alcian blue stain positive. Fine. Now, hormone. This is the mucosa of normal stomach. It contains the mucosal folding, the epithelium, the epithelial mucosa, then it contains the epithelial mucosa, the lamina propria, and the muscularis mucosa with inner circular and outer longitudinal. This is basic knowledge. Now let's break down the word. What do we have? We have autoimmune metaplastic atrophic chronic gastritis. Since there is chronic gastritis throughout mucosa, you are gonna see lymphocytes. There are so many lymphocytes that they end up forming aggregates and forming lymphoid nodules with germinal center. Then atrophic, there is atrophy of the mucosa. Then metaplastic, there is intestinal metaplasia. So now along with foveolar cells, there are also goblet cells. This is what you are going to draw in exam. First, draw the atrophy that has taken place. This is the atrophy. Then throughout the mucosa, there are lots of what? Lymphocytes, because it is chronic inflammation. There are so many lymphocytes that they end up forming aggregates. They end up forming lymphoid nodules. As for lining, so there are your foveolar cells, and then in between goblet cells. Again, foveolar cells with goblet cells. Foveolar cell and goblet cells together. There is obviously the muscularis mucosa with inner circular and outer longitudinal. All right. With blood vessel here and lymphatics there. Good. One last time. All right. So there is chronic gastritis. So there are lymphocytes throughout the mucosa. So many lymphocytes that they end up forming lymphoid nodules, lymphoid follicles with germinal center. Atrophic gastritis, so there is atrophy that has taken place. There is loss of mucosal foldings. Metaplastic gastritis, so there is intestinal metaplasia or presence of goblet cells. Done. Next, Type B chronic gastritis or Helicobacter pylori gastritis. So this is what takes place. The gastritis is divided into two phases. So there is an early stage, and there's a late stage. Fine, early stage and a late stage. In early stage, there is increase in hydrochloric acid. In late stage, there is decrease in hydrochloric acid. In early stage, the part of the stomach that is mostly affected is antrum. Remember the formula, A for B and B for A. In type A, it's the body that is affected, and in type B, it's the antrum that is affected initially, and then later on the whole body, the whole stomach. So initially, in early stage, it's the antrum that is affected, and then later on, it's the complete stomach that gets affected. Now, what we need to know, how is it that in early stage, there is increase in HCl, and then in late stage it's exactly opposite, there's decrease in HCl? How come? So this is how. In early stage, again, it's the antrum of the stomach that is mostly affected. So antrum predominant gastritis. Here, H. pylori infection causes inflammation. Inflammation is followed by an increase in gastrin. Gastrin is responsible for the production of HCl. So there is increase in HCl production. I said earlier, under peptic ulcer disease, that peptic ulcer disease takes place from such gastritis where there is either an increase in HCl or decrease in protection from HCl. At the end of the day, burning of the wall by HCl. Is there increase in HCl? There is increase in HCl. That means this results in increased risk of peptic ulcer disease. There is increased risk of peptic ulcer disease. Here in autoimmune gastritis, there is achlorhydria. There is no or a decreased HCl. That means it will not lead to peptic ulcer disease. Autoimmune gastritis has no risk of peptic ulcer disease because HCl is less. It is not going to burn the wall of the stomach. Ulcer formation will not take place. Okay. Then this is the early stage. Now for late stage. In late stage, the complete stomach is affected. So there is pan-gastritis. Pan means complete. So complete stomach inflammation. Here, there is loss of parietal cell. That means atrophy. There is loss or destruction of parietal cell by Helicobacter pylori. So there is atrophy. Since there is loss of parietal cell, there is decrease in HCl, decrease in hydrochloric acid. So the same as autoimmune gastritis, in Helicobacter pylori gastritis as well, there is no risk of peptic ulcer disease. There is no risk of peptic ulcer disease. Plus, it is protective against esophageal adenocarcinoma as well. How? Again, I have mentioned about this under the topic of esophageal cancers. So watch that out as well if you can. With that being said, in short, here's the esophagus and here's your stomach. Here's the HCl. The person has chronic gastroesophageal reflux disease. As a result, there is stress from HCl continuously, resulting in intestinal metaplasia and formation of Barrett's esophagus. Barrett's esophagus increases the risk of adenocarcinoma. Esophageal adenocarcinoma. But at the end of the day, what is the factor behind it? If you trace it back, it's HCl. HCl is the one that is responsible for causing intestinal metaplasia and then Barrett esophagus and then adenocarcinoma of esophagus. So if there is decrease in HCl, even if the lower esophageal sphincter is open, decrease in HCl, intestinal metaplasia won't take place, Barrett esophagus won't form, and adenocarcinoma of esophagus won't take place. That is how this decrease in HCl is protective against esophageal carcinoma, or Helicobacter pylori gastritis in its late stage is protective against esophageal adenocarcinoma. Since number one, there is destruction of parietal cells, it's atrophic. Since there is inflammation of gastric mucosa, it's gastritis. Since the atrophy is followed by intestinal metaplasia, it's metaplastic. And this intestinal metaplasia increases the risk of adenocarcinoma. Again, let's stress back to esophagus. Under esophagus, I just told you the story of chronic gastroesophageal reflux disease, where the HCl in the stomach continuously burns the lower part of the esophagus, resulting in intestinal metaplasia, which forms Barrett's esophagus and then adenocarcinoma of esophagus, right? So there is intestinal metaplasia, eventually leading to esophageal adenocarcinoma. So intestinal metaplasia is increasing the risk of esophageal adenocarcinoma in esophagus. Similarly, the intestinal metaplasia in stomach also increases the risk of adenocarcinoma. I can't make it more relatable than this. I can't relate the two topics more than this. So, well, this is it, whatever. Now, pictures. So I have from Robbins, this is from internet, and then this is from Horsemohan. First, Warthin starry silver stain. Now, if you know your microbiology, you must know that silver stain is particularly used as an impregnation stain. What is impregnation stain? So it is used for thin structures like flagella and thin bacteria like spirally coiled bacteria. What silver stain does is that it wraps around the bacteria or that thin structure and then fattens it up. This fat structure is now visible under the microscope as black structures. So there's your thin spiral bacteria. The silver stain, it wraps around this bacteria, impregnates the bacteria and then fattens it up. This fat strand is now visible black in color under microscope. So all these fat strand, black strand that you see, these are all Helicobacter pylori that has been stained black due to Warthin starry silver stain. Next is Giemsa stain. Then it is chronic gastritis. So you are going to see lots of lymphocytes throughout the mucosa. Again, so Giemsa stain, H&E stain, diagram to draw in exam. So there's your gastric mucosa with mucosal folding, lined by simple columnar epithelium with thick layer of mucus protecting it from outside. However, now you need to remember 2 points. You have chronic gastritis, right? Chronic gastritis due to Helicobacter pylori. So Helicobacter pylori chronic gastritis. Since there is chronic gastritis, what are you going to see? You are going to see lymphocytes. So these are all the lymphocytes. The complete mucosa contains lots and lots of lymphocytes. There are so much lymphocytes that they end up forming lymphocyte follicles with germinal center. Helicobacter pylori infection. So you're going to see Helicobacter pylori as well. You saw in these histopath as well, there were Helicobacter pylori that you saw with Warthin starry silver stain, Helicobacter pylori with Warthin starry silver stain, Helicobacter pylori with Giemsa stain, Helicobacter pylori with Giemsa stain, Helicobacter pylori with H&E stain. Similarly, lymphocytes, lots of lymphocytes. As for drawing in exam, this is what you are going to draw in exam. So there's the mucosal folding lined by the gastric epithelium, right? And then outside are Helicobacter pylori. So these are Helicobacter pylori. Since it is chronic inflammation, there's going to be lots and lots of lymphocytes throughout the mucosa. There are so many lymphocytes that they end up forming lymphoid follicles with germinal center. Obviously, since it is lamina propria, you're going to draw blood vessel, and then you're going to draw some lymphatics, and then you're going to draw the inner circular muscle and then outer longitudinal muscle. This is the diagram for you to draw in exam. With that, we are done with the gastritis. One last revision. This was a little complicated topic, but I hope you understand now. So this is the final revision. Gastritis, it is the inflammation of gastric mucosa. It is of two types: acute gastritis, which is mostly due to non-steroidal anti-inflammatory drug, and chronic gastritis, which is also referred to as metaplastic atrophic gastritis. Gastritis because there is inflammation of gastric mucosa, atrophic because there is gastric atrophy due to destruction of parietal cells, and metaplastic cause gastric atrophy is followed by intestinal metaplasia. Depending on the cause behind atrophy and gastritis eventually leading to metaplasia, we have two types of chronic gastritis. Type A, which is autoimmune chronic gastritis, where antibodies against parietal cell made by our own body are responsible for metaplastic atrophic gastritis, and type B, where Helicobacter pylori infection is responsible for destruction of parietal cell leading to gastric inflammation followed by intestinal metaplasia, or what we call as metaplastic atrophic gastritis. First, type A chronic gastritis or autoimmune gastritis. Here you have antibodies against the parietal cell, so there is destruction of parietal cell leading to atrophic gastritis, which is followed by metaplasia, intestinal metaplasia. So metaplastic atrophic gastritis, since it is chronic, it is metaplastic atrophic chronic gastritis, since it is due to antibodies made by our own body, it is autoimmune metaplastic atrophic chronic gastritis. Here three things take place. Since parietal cells are destroyed, there is decrease or no HCl, so achlorhydria leading to hypergastrinemia. Since parietal cells are destroyed, there is no intrinsic factor leading to pernicious anemia. Since parietal cells are destroyed, there is damage to gastric mucosa, injury to gastric mucosa, gastric atrophy followed by intestinal metaplasia. Under histopath, you can see all of those features. You can see lymphocytes due to chronic inflammation, chronic gastritis, atrophic glands due to atrophic gastritis, and intestinal metaplasia due to metaplastic gastritis. Intestinal metaplasia is characterized by the presence of goblet cells, which gives alpha-synuclein positive. In Hirschsprung as well, the diagram for you to draw in exam has been given. There is atrophy taking place, lymphocytic aggregation that has taken place, as well as goblet cells due to intestinal metaplasia. Then you have type B chronic gastritis, which is due to Helicobacter pylori, divided into two stages. There's early stage and late stage. Early stage, you have antrum dominant. Late stage, it is the complete stomach involved, so pan gastritis. Early stage, there is increase in HCl. Late stage, there is decrease in HCl. Early stage, there is increase in HCl due to inflammation followed by increase in gastrin, which results in increase in HCl. When there is too much HCl in the stomach, it can go and burn the wall of the stomach, leading to formation of ulcer and eventually peptic ulcer disease. However, in late stage, since there is destruction of parietal cell, there is decrease in HCl, which does not put any risk in development of peptic ulcer disease. No HCl means how ulcer means how peptic ulcer disease. No risk of peptic ulcer disease. Plus, decrease in HCl also acts protective against esophageal adenocarcinoma, which I have already explained, finally leading to Helicobacter pylori metaplastic atrophic chronic gastritis. Again, chronic gastritis because there is lymphocytic infiltration in gastric inflammation, atrophic because there is destruction of parietal cell leading to gastric atrophy, metaplastic because this loss of parietal cell or gastric atrophy is followed by intestinal metaplasia. Since there is intestinal metaplasia, there is also an increased risk of adenocarcinoma. Since everything is happening due to H. pylori, we call it H. pylori or Helicobacter pylori metaplastic atrophic chronic gastritis. This is what you can see in Robbins. So there's your lots and lots of Helicobacter pylori present and stained black by Warthin starry silver stain. Giemsa stain can also be used. These are lymphocytes because there is chronic gastritis. You can see the Giemsa stain and then H&E stain, and this is what you need to draw in exam. You need to show that there are the spiral bacteria or Helicobacter pylori along the wall of the stomach or the epithelium of the stomach, and within the mucosa there are lots of lymphocytes because there is chronic gastritis, and these lymphocytes end up forming lymphoid follicles with germinal center. So the topic is peptic ulcer disease. What is ulcer? Ulcer is a breach in mucosa that grows deeper into submucosa and may even perforate the wall. See, there's a clear difference between mucosal abrasion and ulceration, for which you need to know the layers of wall of GIT, and from inside to outside they are mucosa, submucosa, muscularis propria, serosa or adventitia. Within mucosa, there are three layers from inside to outside: epithelial mucosa, lamina propria, and muscularis mucosa. Mucosal abrasion is a discontinuity in mucosa. Ulceration is also a discontinuity in mucosa. But the difference lies in how much part of the mucosa is involved. That is, in mucosal abrasion, the discontinuity is limited till epithelial mucosa. That is, only epithelial mucosa is a discontinuous. A part of the epithelial mucosa is slawed off or ripped off. Okay. However, in case of ulceration, the complete thickness of the mucosa is discontinuous or involved. That is, there is involvement of epithelial mucosa, then lamina propria, then muscularis mucosa, and then it grows deeper into submucosa and may even perforate the complete wall. So that's the difference between mucosal abrasion and ulceration. What is mucosal abrasion? Discontinuity in the epithelial mucosa. What is ulceration? There is breach in complete mucosa which can grow deeper into submucosa. If this ulcer that I am talking about is present in stomach or duodenum, we call it peptic ulcer disease. So peptic ulcer disease is not just ulcer in stomach. It refers to ulcer either in stomach or duodenum. That is, both gastric ulcer and duodenal ulcer are referred to as peptic ulcers. Etiopathogenesis. I have talked about this a lot of time. Damaging factor, protective factor. So the condition of the wall of the GIT is determined by two factors. Damaging factors continuously trying to damage the wall and protective factors continuously protecting it from that damage. If damaging factors are more than protective factor, or damaging factor win over protective factor, damaging factor overcome the protective factor, this leads to initially in stomach, talking about stomach, gastritis. And few of these gastritis over a long period of time can result into peptic ulcer disease. However, not just any gastritis results in peptic ulcer disease. Those gastritis that result in either increase in hydrochloric acid or decrease in protection from hydrochloric acid will result in peptic ulcer disease. So the important thing you need to know is that it's hydrochloric acid burning the wall of the stomach, burning the wall of the duodenum that result in ulceration of the stomach and duodenum. I know very well we are quite a procrastinators. With that being said, a small revision of damaging factor and protective factor under peptic ulcer disease. So within your stomach, there's hydrochloric acid, which is continuously trying to burn the wall of the stomach, because hydrochloric acid with pH of around 1 and 2 is highly corrosive. But the wall is well protected from HCl by a thick layer of mucus, bicarbonate within the mucus which neutralizes the hydrochloric acid near the wall of the stomach, mucosal blood flow that helps in repair and provides oxygen and nutrients to the mucosa, tightly adherent epithelium lining the wall of the stomach. It is due to the presence of tight junction in between the epithelial cell, and prostaglandin E2 which decreases HCl or inhibits the production of HCl. So the wall of the stomach is damaged either when there is increase in hydrochloric acid or when there is decrease in protection from the hydrochloric acid, or there's a third thing. So either increase in hydrochloric acid will result in hydrochloric acid easily piercing through the protection and ulcerating the wall of the stomach. Decrease in protection from hydrochloric acid will result in hydrochloric acid burning the wall of the stomach and causing ulcer. Or there are certain agents that can directly go and damage the wall of the stomach, causing ulcer. So what are these agents that can increase HCl or decrease protection or directly damage the wall of the stomach? They are: first, increase HCl. NSAIDs increases HCl because it is cyclooxygenase pathway inhibitor, so inhibits prostaglandin E2, which will result in increase in HCl. Helicobacter pylori early stage will result in increased secretion of HCl. I have already taught this under the topic of chronic gastritis. Helicobacter pylori early stage inflammation leads to increased secretion of gastrin, which results in increased secretion of HCl. Stress, psychological stress can also result in increased HCl in the stomach. Zollinger-Ellison syndrome is nothing but gastrinoma, and gastrinoma results in increased secretion of gastrin, and increased gastrin results in increased HCl. as for decrease in protection. So decrease in mucus lining, decrease in bicarbonate, decrease in prostaglandin E2, and even decrease in mucosal blood flow is brought about by NSAIDs. Decrease in mucosal blood flow takes place due to ischemia or shock or cocaine. Direct damage to the wall of the stomach is brought about by infection like cytomegalovirus in immunocompromised patient or herpes simplex virus. Alcohol, tobacco, radiation, and chemotherapy can also go and directly damage the wall of the stomach. All these cases are resulting in what? Ulceration of the wall of stomach. Ulceration of the wall of stomach. So that's the pathogenesis. Now, location of ulcer, depending on their frequency. So the most frequently, peptic ulcer is present in duodenum. More specifically, first part of the duodenum. More specifically, the anterior wall of first part of duodenum. Second most commonly, the ulcer is present in pyloric antrum. More specifically, the lesser curvature of pyloric antrum. More specifically, the posterior wall of lesser curvature of pyloric antrum. Then, in case of gastroesophageal reflux disease, when HCl can regurgitate or reflux into cardia of the stomach, then ulcer can be present in cardia of the stomach as well. After surgery, the ulcer might be present in margin of gastrojejunostomy. It can also develop in Meckel's diverticulum. With that being said, the most common site of peptic ulcer is the anterior wall of first part of duodenum, and the second most common site of peptic ulcer is the posterior wall of lesser curvature of pyloric antrum of stomach. All right. Now, gross. Ulcers, they are of two types, benign ulcer and malignant ulcer. Benign ulcer is due to peptic ulcer disease. Malignant ulcer, as the name says, is due to a malignancy, that is a cancer. For example, in case of gastric adenocarcinoma, there is ulcer in the stomach, that's a malignant ulcer. And there's a clear difference in gross in between benign ulcer and malignant ulcer, and this was the question asked to me during pathology viva. How can you differentiate between benign ulcer and malignant ulcer? For that, you need to look at certain characteristics of the ulcer. Number one, being the border of the ulcer. Number two, the base of the ulcer. And number three, the size of the ulcer. What did I say? The border of the ulcer, so the margin of the ulcer, the margin of the ulcer, the base of the ulcer, and the size of the ulcer. All right. First, margin of the ulcer. In a benign ulcer, the margin is regular. The margin is regular and it is punched out. It is punched out. In malignant ulcer, the margin is irregular. It's irregular and it's rolled out or heaped up. Base. In benign ulcer, the base is clean. It's clean. In case of malignant ulcer, the base is dirty and friable due to malignancy. Size. Benign ulcer is usually small, usually less than 2 cm. Malignant ulcer is large and usually larger than 2 cm. Here's the microscopy of benign ulcer due to peptic ulcer disease. So see, you can see complete discontinuity in complete thickness of mucosa, and ulcer grows and affects submucosa as well, as I said earlier. So there are 4 major layers of benign ulcer, which you can remember as @NIGS NIGS. First is the necrotic layer. Necrosis is accompanied with inflammation. So there is inflammatory layer. Then there's granulation layer. And finally, there is healing by fibrosis, which results in scar formation. So scar layer. Again, NIGS. Necrotic layer, inflammatory layer, granulation layer, and the scar layer. The same is shown in Hirschsprung as well. Necrotic layer, inflammatory layer, granulation layer, and scar layer. Forming the base of the ulcer is also either the necrotic layer or the granulation layer. Now, ulcer can be due to stress as well. And no, I'm not talking about psychological stress. Yes, psychological stress can result in increase in HCl in the stomach and eventually gastritis and then ulcer. But I'm talking about physical stress like burn and intracranial pressure. So there are 2 ulcers that you need to know: Curling ulcer and Cushing ulcer. Quarreling ulcer takes place due to burning, that is burns. Cushing ulcer takes place due to tension, that is increase in intracranial pressure. How? See, burns result in dehydration, which results in decrease in blood volume, which results in ischemia and decreased mucosal blood flow. Decreased mucosal blood flow means there is no decrease in protection from HCl. That means HCl can harm the wall of the stomach, resulting in gastritis and ulcer. Cushing ulcer due to increased intracranial pressure. Increase in intracranial pressure will eventually compress the vagus nerve, which will stimulate parasympathetic nervous system, which results in increase in HCl secretion, and more HCl means more burning of the stomach and ulcer formation. Quarreling ulcer is superficial ulcer. Cushing ulcer is pushing, that is it grows deeper, pushes deeper, so it is deep ulcer. Quarreling ulcer is seen usually in duodenum. Cushing ulcer with S is seen in stomach and even duodenum. With that, we are done with ulcer. So final revision of everything that I have said till now. Peptic ulcer disease. What is ulcer? It is a breach in mucosa that eventually affects submucosa as well and can even grow deeper and perforate the wall. There is clear demarcation between ulcer and mucosal abrasion. Mucosal abrasion, there is discontinuity in epithelial mucosa only. In ulceration, the complete thickness of the mucosa is involved. That is, there is discontinuity in mucosa and there is affected part, the submucosa is affected as well, and then perforation throughout the whole thickness can even take place. If ulceration is present in stomach or duodenum, that is gastric ulcer or a duodenal ulcer, then that is peptic ulcer, and the disease is peptic ulcer disease. Etiopathogenesis, damaging factor wins over protective factor. It will damage the wall of the stomach, damage the wall of the duodenum. If we are talking about stomach, will lead to gastritis, and certain gastritis will result in peptic ulcer disease. Those gastritis where there is either increase in HCl or decrease in protection from HCl, that will result in peptic ulcer disease. Sometimes there are certain factors that can directly go and damage the wall of the stomach, that can result in ulceration as well. So increase in HCl is brought about by NSAIDs, Helicobacter pylori, psychological stress, and Zollinger-Ellison syndrome. Decrease in protection from HCl is brought about by NSAIDs, ischemia, shock, and cocaine. Direct damage can be brought about by infection like cytomegalovirus that goes and infects immunocompromised patient, or herpes simplex virus, or alcohol, tobacco, radiation, chemotherapy can also go and directly damage the wall of the stomach, causing ulcer in the stomach. Locations of the ulcer. So the most common location of peptic ulcer is the anterior wall of first part of duodenum, and the second most common location of peptic ulcer is the posterior wall of lesser curvature pyloric antrum of stomach. Talking about gross, there are two types of ulcer: benign ulcer and malignant ulcer. Benign ulcer is the one that is seen in case of peptic ulcer disease. Malignant ulcer is the one that is seen in case of malignancy like cancer, for example Gastric Adenocarcinoma. How can you differentiate between the two? Benign ulcer has a regular margin which is punched out. Malignant ulcer has irregular margin which is rolled out or heaved up. The base, it is clean in benign ulcer. The base, it is dirty and friable in a malignant ulcer. The size, it is small in benign ulcer, usually less than 2 cm. The size, it is large in malignant ulcer, usually greater than 2 cm. Microscopically, talking about peptic ulcer disease, Bala ulcer, that is benign ulcer, it has 4 layers: NIGS, that's the necrotic layer, the inflammatory layer, the granulation layer, and the scar layer due to fibrosis. Talking about stress ulcer, there are two types: curling ulcer and Cushing ulcer. Curling is due to burning, that is burns, and Cushing is due to tension, that is increase in intercranial pressure. Burn will result in dehydration, eventually decrease in blood volume level, and ischemia and decrease in mucosal blood flow. That means HCl in the stomach can easily harm the wall of the stomach. In case of increased intracranial pressure, it will compress the vagus and then result in PNS stimulation and increase in HCl secretion. Curling ulcer is superficial ulcer. Cushing is pushing, that is, it is a deep ulcer. Curling ulcer affects the duodenum. Cushing ulcer, as it is seen in stomach or even duodenum. Hypertrophic gastropathy. It is a well-known topic for not being a well-known pathology. That is, it is a highly uncommon pathology. With that being said, the theory. Gastropathy. So it is a pathology of your stomach. Hypertrophic, that means it is such a pathology of stomach that results in enlargement in size of stomach. All right, there is increase in size of stomach. Now, the reason behind the increment in size of stomach is epithelial hyperplasia. Now I know you are gonna say, shouldn't we have just called it hyperplastic gastropathy instead? But it's clearly mentioned in the Robbins that hypertrophic gastropathy occurs due to epithelial hyperplasia, so deal with it. All right, now a very small concept that you must have already known. Here's a gland which is lined by glandular epithelium. Okay, let's say there is hyperplasia, glandular hyperplasia. That means there is increase in number of cells in glandular epithelium. In order to accommodate the increase in number of cells, what happens in the gland? Papillary infolding develops in the gland. There is development of papillary infolding within the gland. Why? In order to increase the surface area so that the increased number of cell can easily accommodate within the same gland. Okay, so the gland has glandular epithelium. When there is glandular hyperplasia, there is development of papillary infolding in order to increase the surface area to accommodate the increased number of glandular cells. Good. Now let's think of something bigger like our stomach. The stomach already contains such papillary folding, but macroscopically, that is grossly. And these are called as rugae, gastric rugae, and the folds are known as rugal folds. So these are your rugal folds. Now, the line of the wall of the stomach is also lined by epithelial mucosa, simple columnar epithelium. Now, let's say there is epithelial hyperplasia. There is hyperplasia of the epithelial mucosa. That is, there is increase in number of epithelial cells. The stomach needs to accommodate the increased number of cells. What is going to happen? The rugal fold is going to exaggerate. The rugal fold is going to exaggerate. Why? In order to increase the surface area to accommodate the increased number of epithelial cells. And that is why grossly exaggerated rugal folds are visible. What I did was I took a stomach. This stomach has hypertrophic gastropathy. About the greater curvature, I made an incision and then opened the stomach like a book. And this is what I got. You can see that this part is flat and this is the antrum. So antrum of the stomach in hypertrophic gastropathy is paired. There is no rugal folding, but this is the fundus, and then this whole thing is the body. The fundus and the body goes through epithelial hyperplasia, resulting in exaggerated rugal folding. And this exaggerated rugal folding is visible like what? Like your cerebrum. So it is called cerebriform pattern as well. All right. So let's go through the flowchart. Simple thing. There is hyperplasia. That means there is increase in number of cells. A cell divides by going through the process of mitosis. And for increased number of cells, there has to be increase in mitosis. Mitosis takes place only when the receptor on the cell receives a growth factor. There's the growth factor. There's the growth factor receptor. The growth factor binds with the growth factor receptor, and then the mitosis of the cell takes place, and then it divides into two. So when there is increase in number of cells, abnormal increase in number of cells, that means there is abnormal increment in mitosis as well. When there is abnormal increment in mitosis, that means there has to be abnormal increment in growth factor as well. So there is indeed increase in growth factor. As a result, there is increased mitosis or increased division of cell, resulting in increase in number of cells. This is hyperplasia. And the hyperplasia of which cells take place? The epithelial cell, resulting in epithelial hyperplasia. When there is increase in number of epithelial cells within the stomach, in order to accommodate the increased number of cells, what happens? The rugal folding, it becomes exaggerated or more. There is more rugal folding, exaggerated rugal folding, which looks like your cerebrum, so-called cerebriform pattern. As a result, there is increment in the size of the stomach, so enlargement of stomach. So hypertrophic gastropathy, pathology of stomach where there is increase in size of the stomach. Got it? one last revision, because I know all this jhamela is banging your head right now. So again, it is hypertrophic gastropathy. It is a pathology of stomach which results in increment in size of the stomach. The increment in size of the stomach takes place due to epithelial hyperplasia. The wall of the stomach is lined by mucosal epithelium. You know your basic histology, right? So there is epithelial hyperplasia resulting in increment in size of the stomach. For epithelial hyperplasia to take place, that means there is increase in number of epithelial cell. That means there is increased mitosis of epithelial cell. That means the epithelial cell is receiving more growth factor, so more mitosis is taking place now. So there is increase in growth factor. So there is increase in growth factor, so there is increase in number of cells. Now since there is increase in number of cells, the same stomach, you're not going to have a new larger stomach, right? The same stomach has to accommodate that increased number of cells. So the stomach needs to increase its surface area to accommodate the increased number of cells. So whatever rugal folding was initially present becomes more. It becomes more and exaggerated in order to increase the surface area to accommodate the increased number of cells. As a result, when you cut this stomach and then open it up, it looks like your cerebrum, giving cerebriform pattern. This is called cerebriform enlargement of the stomach. So hypertrophic gastropathy. All right. Under hypertrophic gastropathy, there are two that you need to know in detail, more in detail, right? There are many, but two in detail: Menentriers disease and Zollinger-Ellison syndrome. Now, the good news is that for both, the flowchart is the same. The same thing takes place, right? And the end result is also almost the same. But the difference lies in which growth factor is it for which the release has increased, which growth factor has released, right? Second, which cell goes through hyperplasia? I said epithelium goes through hyperplasia, but which epithelial cell in particular goes through hyperplasia? Starting off with Menentrier disease. Okay, so the first question, increment in which growth factor takes place? And that is transforming growth factor alpha, TGF alpha, transforming growth factor alpha. Second question, hyperplasia of which epithelial cell takes place? It is the foveolar cell. From your physiology, you must know what foveolar cell is, right? It is the mucus secreting surface mucus cells lining the wall of the stomach. Stomach is lined by a thick layer of mucus. Now that mucus is produced by the foveolar cell lining the wall of the stomach. Okay, that's the foveolar cell. This is the foveolar cell. This is the growth factor. This is the receptor, the transmembrane receptor for the growth factor. The receptor is present through the plasma membrane. This is the plasma membrane, and then here's the receptor. Okay, so the growth factor is transforming growth factor alpha or TGF alpha. It goes and binds with its receptor, which is EGFR. It's nothing, it's epidermal growth factor receptor. Epidermal growth factor receptor. So once TGF alpha binds with EGFR, tyrosine kinase activity takes place, which results in increased mitosis and increased number of foveolar cell or foveolar epithelial hyperplasia. And the same thing is visible microscopically as well. Microscopy, we see there are elongated glands, large elongated glands. And when you study pathology, most of the time what you can see is that the microscopy usually they follow the macroscopy. Like here as well, you can see that due to increased elongated dilated glands, it seems as if the microscopy has a rugal folding of its own, right? It looks like the rugal folding of the stomach. Like there are folds developed within the microscopy of the stomach, but then these are not rugal foldings, all right? So these are just your elongated dilated glands that have developed due to foveolar epithelial hyperplasia. So now you know your growth factor. Now you know your hyperplasia of the cell. What else you need to know? You need to know that Menentrier's disease is also called protein-losing gastropathy. It is such a pathology of stomach, such a disease of stomach that results in loss of protein from your body. How? When there is meningitis disease, from the blood vessel supplying your stomach, protein leaks into the stomach from the blood. So there is leakage of protein from blood into the stomach. All right. As a result, there is a decrease in protein level in the blood, resulting in hypoproteinemia. More specifically, there is decrease in albumin level in blood. Clinical feature. Now, within stomach, what has leaked? Protein has leaked. Within stomach, hyperplasia of which cell has occurred? Foveolar cell, which is responsible for production of what? Mucus. So there is increment in what? Mucus. So there's too much protein and mucus within the stomach, which has to go out, and this results in diarrhea. That's why a person with meningitis disease has intense diarrhea. Second, there is decrease in albumin in blood, right? So albumin decrease results in decrease in oncotic pressure, which results in peripheral edema. And that's it for meningitis disease. One last revision. So the topic is hypertrophic gastropathy. It is such a pathology of stomach that results in enlargement of the size of the stomach. Hypertrophy takes place, enlargement in size of the stomach takes place due to epithelial hyperplasia. So initially, there is increase in growth factor. As a result, there is increased mitosis. As a result, there is increase in number of epithelial cell, resulting in epithelial hyperplasia. To accommodate the increased number of epithelial cell, the rugal folding within the stomach becomes exaggerated rugal folding. As a result, when you cut the stomach and open it up, it looks like your cerebrum, so-called cerebriform appearance, and there is enlargement of the stomach because it's a hypertrophic pathology. So there is cerebriform enlargement of the stomach. There are two that you need to know: meningitis disease and Zollinger-Ellison syndrome. Meningitis disease, so there is increment in which growth factor? Transforming growth factor alpha, TGF alpha. It binds with its receptor in which cell? Foveolar cell. As a result, what happens? Foveolar epithelial hyperplasia takes place. So two questions answered. There is increased release of which growth factor in meningitis disease? TGF alpha. There is hyperplasia of which epithelial cell? The foveolar cell. Plus, it is a protein losing gastropathy, because when there is meningitis disease, there is leakage of protein from blood into the stomach. As a result, there is a decrease in protein in the blood, hypoproteinemia, decrease in albumin blood. Clinical feature: since there is too much protein in the stomach due to the leakage of protein from blood into the stomach, plus there is too much mucus in the stomach because of increase in number of foveolar cell, the person has diarrhea. Second, since there is decrease in albumin level in the blood, there is decrease in oncotic pressure, which results in peripheral edema. Previously, we learned about meningitis disease, which is a hypertrophic gastropathy. Now we are going to learn about Zollinger-Ellison syndrome, which is also a hypertrophic gastropathy. See, be it meningitis disease or Zollinger-Ellison syndrome, at the end of the day, what are they? They are hypertrophic gastropathologies. So if you know what hypertrophic gastropathy is and how it occurs and what it results in, studying meningitis disease and Zollinger-Ellison syndrome becomes much simpler, because after that you are done with 90% of the concept. That's the reason why under meningitis disease, I have spent majority of the time explaining about hypertrophic gastropathy, but since I know that you are quite ulci prani, I'm going to repeat it once again, but in much shorter. This is going to be a shorter version of the previous explanation. Okay, hypertrophic gastropathy. It is a pathology of stomach. What kind of pathology? Hypertrophic pathology, because there is increment in size of the stomach, enlargement of the stomach. And the reason behind the enlargement of the stomach is epithelial hyperplasia. Okay, small concept. This is a gland which is lined by glandular epithelium. Okay, let's say this gland goes through glandular hyperplasia. As a result, there is increment in the number of cells in the glandular epithelium. Now, in order to accommodate this increased number of cells, what should the gland do? It must somehow increase its surface area, so that if there is more area within the same gland, more cells can accommodate, and it does so by bringing about a papillary infoldings. Now there is increment in the surface area, so the increased number of cells can easily accommodate within the same gland. Okay, now let's talk about stomach. This is your stomach. The stomach, the wall of the stomach, the inner wall of the stomach, it contains something called gastrirugi, which are your rugal foldings. It increases surface area as well for the glandular epithelium. But let's say there is increment in the number of cells in the glandular epithelium, in the lining epithelium of the stomach. Then what will happen? Then these rugal foldings will get exaggerated, highly folded. Why? In order to increase surface area, in order to accommodate the increased number of cells. Previously, while talking about gland, we are talking about microscopy, how it brought about papillary infolding to accommodate the increased number of cells. While talking about stomach, we are talking about gross or macroscopy. There is already rugal folding, but this rugal folding becomes even more exaggerated. It is even more prominent. Why? Because there is increment in the number of cells lining the inner wall of the stomach. The increment in the number of cells of epithelial mucosa. That is why the rugal folding becomes more exaggerated to accommodate that increased number of cells. All right, this concept is clear. Okay, now listen to this story. We have an epithelial cell lining the wall of the stomach within the epithelial mucosa of stomach. This epithelial cell goes through the process of mitosis and then divides into two. Good. For mitosis to occur, the cell needs to be triggered either by a growth factor or some kind of hormone. Some kind of hormone or growth factor triggers this cell, mitosis occurs, and then it divides. Let's say there is abnormal increment in this growth factor or abnormal increment in the hormone that will trigger mitosis. As a result, there is abnormal increment in mitosis, resulting in abnormal increment in the number of cells. The cell divides, right? The division of the cell is controlled by hormone and growth factor, right? If hormone and growth factor more, cell division more. If cell division more cells. Okay. This is called hyperplasia. Which cell is going through hyperplasia? Epithelial cell. So what kind of hyperplasia it is? It is epithelial hyperplasia. Okay, that part also done. Now listen to me. There is epithelial hyperplasia due to increased release of growth factor or maybe certain kind of hormone. So there is increased release of growth factor or certain kind of hormone, resulting in increased number of epithelial cell. As a result, there is epithelial hyperplasia. There is more cells within the stomach, Now, in order to accommodate these increased number of cells within the stomach, what happens? Already I said, the rugal folding gets exaggerated, too much rugal folding. And what you get? You get hypertrophic gastropathy. Means there is increase in the size of the stomach due to epithelial hyperplasia with exaggerated rugal folding. And the reason behind epithelial hyperplasia is either due to increased release of growth factor or certain hormone. Now, let's say I have this stomach right here. This stomach has that exaggerated rugal folding, or this stomach has gone through hypertrophic gastropathy, right? It has increased in size and it has lots of rugal folding. What I do is that I make an incision along the greater curvature. Okay, then I open this stomach like a book. This is what I'm gonna get. This is the antrum of the stomach, and you can see that the antrum is flat. So antrum of the stomach is spared. There is no exaggerated rugal folding in the antrum of the stomach in hypertrophic gastropathy. The antrum of the stomach is spared. But look at the fundus of the stomach. Look at the body of the stomach. The fundus and the body shows that exaggerated rugal folding. So much rugal folding. See, the rugal folding is so highly exaggerated. As a result, it looks like what? It looks like your cerebrum. and that is why it's called cerebrum appearance of the stomach. And since due to this rugal folding and due to increased number of cells, the stomach has increased in size, it is called cerebriform enlargement of stomach. That's why hypertrophic gastropathy, pathology of stomach that results in increased size of the stomach. All right. Under hypertrophic gastropathy, we have many diseases, but among those, the important ones are Many-Triers disease and Zollinger-Ellison syndrome. Now, what distinguishes between the two are two things. Number one, increase of what leads to epithelial hyperplasia. Okay. Number two, what type of epithelial cell within epithelial mucosa of stomach shows hyperplasia. Two things. Number one, increase of what results in hyperplasia, and number two, what goes through hyperplasia. Under Many-Triers disease, we have already learned that there is increase in transforming growth factor alpha, TGF alpha, which results in increment or hyperplasia of which cell? The foveolar cell lining the wall of the stomach, TGF alpha and foveolar cell. But now, Zollinger-Ellison syndrome. In Zollinger-Ellison syndrome, this is the story. So, within the lining mucosa of the stomach, within the epithelial mucosa of stomach, you have parietal cell, right? Parietal cell is responsible for secretion of hydrochloric acid. On the surface of the parietal cell, there's a G protein coupled receptor. This receptor is for gastrin hormone. What? Gastrin hormone. And this particular G protein coupled receptor for gastrin hormone is cholecystokinin B receptor. So gastrin hormone, it binds with cholecystokinin B or G protein coupled receptor and triggers the release of HCl from parietal cell as well as division of parietal cell. Two things, okay? So gastrin, which is a local hormone, gastrin, a hormone, it binds with G protein coupled receptor present on the surface of the parietal cell and triggers the parietal cell to go through two things. Number one, secrete HCl, and number two, divide. Now let's say there is somehow an abnormal increment in gastrin. Then what happens? There is abnormal triggering of this G protein coupled receptor, increased stimulation of G protein coupled receptor. That means the end result is also going to increase. There is going to be increased release of HCl from the parietal cell as well as increased number of parietal cell due to increased division, and this is parietal cell hyperplasia. So once more, in Many-Triers disease, there was increment in TGF alpha which resulted in foveolar cell hyperplasia. In Zollinger-Ellison syndrome, there is abnormal increment in gastrin hormone that results in parietal cell hyperplasia. Okay. Now, second thing, how is it that there is an abnormal increment in gastrin hormone? That takes place due to a tumor which is gastrinoma. I mean, the name says it all. Gastrinoma, it's a gastrin secreting tumor. What type? Neuroendocrine tumor. So gastrinoma is a gastrin secreting neuroendocrine tumor. See, at the end of the name there is oma. However, it is a misnomer. That is, gastrinoma is not necessarily benign. 60 to 90% of gastrinoma, they are actually malignant. If you see gastrinoma, it is most likely gonna be malignant. So simply, gastrinoma is malignant. However, at the end there is oma. So it's a misnomer. All right. Second thing, where are you going to see this gastrinoma? Where is this tumor going to be? Location of the tumor. And that is given by something called gastrinoma triangle. Gastrinoma triangle will tell you which are the most common locations for development of gastrinoma. And they are, number one, the junction between cystic duct and the common bile duct. Number two, the junction between head of the pancreas and the neck of the pancreas. And number three, the junction between the second part of the duodenum and the third part of the duodenum. Again, what are they? The junction between the cystic duct and the common bile duct, the junction between the head of the pancreas and the neck of the pancreas, and third, the junction between the second part of the duodenum and the third part of the duodenum. If you can't remember this much, at least remember gastrinoma mostly develops in duodenum and pancreas. I hope you can remember that, right? Okay. Now, more about the tumor gastrinoma. Let's say there are 100% of the gastrinoma cases are presented to you. 100% of the gastrinoma cases are presented to you. Out of 100% of the cases, 75% of them are going to be sporadic and single. The remaining 25% is most probably going to be familial, that is associated with genetic mutation, and the genetic mutation is MEN1 mutation, multiple endocrine neoplasia 1 mutation. Right, multiple endocrine neoplasia 1 mutation, quite easy to remember. See, MEN1 mutation resulting in familial gastrinoma will result in multiple tumors, right? See, 100% of the cases, 75% is S for sporadic, S for single, and 25% of the cases is due to M for MEN1 mutation and M for multiple. MEN, full form MEN, multiple, E for endocrine, N for neoplasia, 1 mutation. Are there multiple tumors? Yes. So multiple. Is it an endocrine tumor? Yes, it is an endocrine tumor. So endocrine. Is it a tumor? So neoplasia. So multiple endocrine neoplasia 1 mutation. All right. What are the clinical features? See, first, it's peptic ulcer disease, and nothing to be shocked about. I mean, there is an increment in HCl secretion. There's too much HCl in the stomach. It will result in ulcer eventually. And most commonly, it's duodenal ulcer. Remember that duodenal ulcer, Zollinger-Ellison syndrome, is associated with duodenal ulcer. See, let's say a patient has peptic ulcer disease, right? And then you took the history of the patient. There is no chronic use of NSAIDs, number one. Then you performed lab diagnosis of the patient, and Helicobacter pylori infection was not seen. So probable cause could be Zollinger-Ellison syndrome. Okay. Second is diarrhea. How diarrhea? There's too much acid within the stomach. This too much acid within the stomach is going to enter the duodenum. Inside the duodenum, alkaline medium is required for the digestion of fat. But since there is too much acid in the stomach, and this too much acid in the stomach enters the duodenum, that alkaline medium is not maintained. That means fat digestion will not take place, and undigested fat is pooped out, leading to diarrhea. And fat-specific diarrhea is called steatorrhea. So there is steatorrhea as well. All right, done. That's Zollinger-Ellison syndrome. One last revision. So what was the cause behind hyperplasia? Increment in which hormone? Gastrin hormone, which led to hyperplasia of which epithelial cell lining the wall of the stomach? Parietal cell. As a result, there was increased HCl secretion, which led to clinical features like peptic ulcer disease and diarrhea. The reason behind abnormally increased amount of gastrin was the tumor gastrinoma, which is a gastrin secreting neuroendocrine tumor. Even though it has oma at the end, is it benign or malignant? 90% of the time it is malignant. The most common areas where gastrinoma develop is given by the gastrinoma triangle, which is composed of the junction between cystic duct and the common bile duct, the junction between the head of the pancreas and the neck of the pancreas, and the junction between the second part of the duodenum and the third part of the duodenum. Out of 100% of the cases of gastrinoma, 75% are S for sporadic and S for single, while 25% of the cases are familial, that is due to MEN1 mutation, M for MEN1 mutation, and M for multiple. And with that, we are done with hypertrophic gastropathy, both Many-Triads disease and Zollinger-Ellison syndrome. This is the one video that you require for the topic of gastric tumor. Let me assure you, by the end of this video, there won't be a single concept. There won't be a single thing to mug up that will be left behind. Everything that has been mentioned in Robbins will become crystal clear to you. Nothing will be left behind. All you have to do is listen to everything I have to say. Jot down every point that I am saying. And if you are too lazy to make a note of your own, you can use this note, and this note will be provided to you in my Telegram channel, the link for which will be either in the description or in the comment section. All right. So the topic is gastric tumor. I have divided the topic into multiple subtopics, starting with introduction. then risk factors, then etiopathogenesis, then site, then Lauren classification, and finally other types of gastric tumors. Starting off with introduction. Like any other tumors, gastric tumors are of two types as well. There's your benign gastric tumor and malignant gastric tumor. Malignant tumors are also referred to as cancer. So malignant gastric tumors are your stomach cancers or gastric cancer. Now, very important question. The most common gastric cancer or the most common malignant gastric tumor is gastric adenocarcinoma. And it makes perfect sense because the inner wall of the stomach is lined by glandular epithelium, simple columnar epithelium, right? So if a cancer were to arise from this epithelium, from glandular epithelium, it is most probably going to be glandular type, and glandular type cancer arising from epithelium is adeno-glandular type carcinoma arising from epithelium, adenocarcinoma. So most common malignant gastric tumor is gastric adenocarcinoma. Second, most common malignant mesenchymal gastric tumor is, the question has been changed, right? Previously it was most common malignant gastric tumor. Overall, it's gastric adenocarcinoma, but gastric adenocarcinoma is arising from epithelium. But now the question is asking mesenchymal in origin. So the most common malignant gastric tumor, which is mesenchymal in origin, is GEST, gastrointestinal stromal tumor. Okay, 90% of stomach cancers or gastric cancers or malignant gastric tumor, they are gastric adenocarcinoma. So it is very important for you to know gastric adenocarcinoma. So first we are going to look at gastric adenocarcinoma in detail, then gastrointestinal stromal tumor, then gastric lymphoma. Starting off with gastric adenocarcinoma. So when someone refers to stomach cancer, they are most probably referring to gastric adenocarcinoma because 90% of the cases are gastric adenocarcinoma. Risk factors. I've divided the risk factors under three subtopics: food and drinks, the 3 A's that you need to remember, and infections. Under food and drinks, alcohol and smoking, you can't leave them under risk factor of any cancer of gastrointestinal tract. They are risk factor for any GIT tumors, okay? Alcohol and smoking. Hot beverage, it is risk factor for esophageal cancer as well as stomach cancer. Smoked and salted food. See, previously, years ago, gastric adenocarcinoma was endemic to Japan. That is, it was found only in Japan due to their food habit or food culture, which composed mainly of smoked and salted food, which is a risk factor for gastric adenocarcinoma. So under food and drink, we have alcohol, smoking, hot beverages, smoked and salted food. Then 3 A's. A for adenocarcinoma, A for anemia. Which anemia? Pernicious anemia. A for adenomatous polyposis. A for blood group A. These 3 are the risk factors for gastric adenocarcinoma. Infections, Helicobacter pylori and Epstein-Barr virus. Out of all these risk factors, the most common risk factor is Helicobacter pylori infection. Okay. Now, etiopathogenesis. Now, what we are going to do is take few of these risk factors, pick them, and then see how exactly do these risk factors they cause gastric adenocarcinoma. Starting up with the most common risk factor itself, that is Helicobacter pylori. All right, Helicobacter pylori infection. If Helicobacter pylori infection of the stomach in a patient is left untreated for a long period of time, what does it cause? It causes chronic metaplastic atrophic gastritis type B. And no, I'm not going to explain this terminology because I have explained it in detail and beautifully under my video of gastritis. So watch that out. But all you need to know for this lecture is that Helicobacter pylori infection over a long period of time causes chronic gastritis, which eventually leads to metaplasia. So metaplastic chronic gastritis. Which metaplasia? Intestinal metaplasia of the stomach. Metaplasia worsens into dysplasia, and dysplasia worsens into cancer. Here, gastric adenocarcinoma. Now, a small concept, a small thing that you need to remember, okay? Just for now, gastric adenocarcinoma, as per Lauren classification, is of two types. I will explain Lauren classification in detail again, but for now, just remember, gastric adenocarcinoma, as per Lauren classification, is of two types. There is intestinal type of gastric adenocarcinoma and diffuse type of gastric adenocarcinoma. Good. The name makes complete sense. See, intestinal gastric adenocarcinoma, the tumor cells, they are arranged in glands. They are present like glands, like the ones present in intestine. In diffuse type of gastric adenocarcinoma, the cells are diffusely present. They are diffusely present. Just that. See, since this gastric adenocarcinoma has developed from intestinal metaplasia, so which type is it gonna be? It is obviously going to be intestinal type of gastric adenocarcinoma. Got it? Okay. So there's a stomach. This stomach has Helicobacter pylori infection. The person does not rate the stomach. Over a long period of time, the person develops chronic gastritis, which eventually results in intestinal metaplasia of the stomach. The intestinal metaplasia worsens into dysplasia because the Helicobacter pylori infection is left untreated. The dysplasia, it worsens into gastric cancer of the stomach or gastric adenocarcinoma. Since this gastric adenocarcinoma has developed from intestinal metaplasia, there has to do something with intestine form, right? So there is intestinal type of gastric adenocarcinoma. Second, pernicious anemia. So we did Helicobacter pylori. Now let's look at pernicious anemia. Pernicious anemia. What happens in pernicious anemia? Your stomach contains special cells called parietal cells that are responsible for secreting hydrochloric acid and intrinsic factor. In pernicious anemia, your own body makes antibodies against these parietal cells. Antibodies against these parietal cells. So the parietal cells, they get destroyed, and this also leads to chronic gastritis, which is called autoimmune chronic metaplastic atrophic gastritis type A. And no, I'm not gonna explain what that is because I have already beautifully explained it under my video gastritis. Watch it out. But for this lecture, all you need to know is that this is a chronic gastritis that also eventually leads to metaplasia. So it is chronic metaplastic gastritis. What type of metaplasia? Intestinal metaplasia, which worsens into dysplasia, which results in gastric adenocarcinoma. Gastric adenocarcinoma is of two types as per Lauren classification, intestinal type and diffuse type. Here, gastric adenocarcinoma is due to intestinal metaplasia. So which type is going to develop? Intestinal type is going to develop. Right? Completely conceptual. There's nothing you have to mog up. One thing you might have noticed, in first case, also it is due to chronic gastritis. In second case, also it is due to chronic gastritis. So can I merge both the etiopathogenesis together? Let me show you the merged version. So the person has chronic gastritis. Okay. So the person has chronic gastritis. Now this can either be type A chronic gastritis or type B chronic gastritis. If it is type A chronic gastritis, it is autoimmune chronic gastritis with pernicious anemia. If it is type B chronic gastritis, it is Helicobacter pylori infection chronic gastritis. Both of them eventually cause intestinal metaplasia of the stomach. They cause intestinal metaplasia of the stomach. Metaplasia worsens into dysplasia, and this causes gastric adenocarcinoma. Since gastric adenocarcinoma is due to intestinal metaplasia, the type is intestinal type of gastric adenocarcinoma, and that's it. Okay, so we saw Helicobacter pylori, the most common cause, which causes chronic gastritis type B. We saw pernicious anemia, which is associated with autoimmune chronic gastritis type A. Now let's look at adenomatous polyposis. Adenomatous polyposis. You have to understand this term right here, FAP. See, even if you don't understand it right now, it is a topic of intestine. But briefly, okay, briefly. FAP, familial adenomatous polyposis. FAP is something that is mostly seen in intestine. It is seen in intestine. FAP is seen in intestine. It's familial adenomatous polyposis. There are more than 100 polyps that develop if a person has familial adenomatous polyposis in intestine. Okay, and this is due to mutation in which gene? See, this is familial adenomatous polyposis. Let's cross out F and add C at the end. So it is due to APC gene mutation. Where is APC gene present? Which letter have I eliminated? F, right? F for 5. So it is present in chromosome number 5. So APC gene mutation in chromosome number 5 leads to familial adenomatous polyposis of the intestine, where more than 100 polyps are seen in the intestine. All right. So whatever be the story, all you have to know is that familial adenomatous polyposis is mostly seen in intestine. It is seen in intestine. But sometimes familial adenomatous polyposis might develop in stomach as well. Rarely. Okay, rarely. Now, if a person has FAP, the bad thing about FAP is that it has 100% chance of becoming cancer. Very bad thing about familial adenomatous polyposis. Very bad thing. So if the person has familial adenomatous polyposis of the colon, the intestine, then it is going to develop into intestinal cancer for sure, if not surgically removed. Similarly, if familial adenomatous polyposis is present in stomach, it is for sure going to develop into gastric adenocarcinoma. Which type? FAP is mostly developing in intestine. Now something that is mostly developing in intestine is now developing in stomach. So it is going to be of intestinal type. Something that is mostly associated with intestine, it will result in intestinal type of gastric adenocarcinoma. Okay. So under gastric adenocarcinoma, we learned about intestinal gastric adenocarcinoma causes, 3 of them. First, chronic gastritis due to Helicobacter pylori and pernicious anemia, and familial adenomatous polyposis. But what about diffuse type? See, cells, they are adherent with one another with the help of cell junction, namely E-cadherence. Okay. When there is CDH1 mutation, very important mutation, mock this up. Keep this in your mind because this is going to repeat in breast cancer as well. The same logic applies in breast cancer as well. So when there is CDH1 mutation, there is loss of E-cadherence in between the cell. When there is loss of cell junction, the 2 cells are not adherent with one another anymore. They become free, they become loose and free. So the cells, they become free from one another and they are diffusely arranged. This results in diffuse type of gastric adenocarcinoma. So there is first CDH1 mutation, which results in loss of E-cadherence, loss of E-cadherence between the 2 cells, As a result, the 2 cells are no longer adherent with one another. They are free from one another. There is no cell adhesion, resulting in diffuse type of gastric adenocarcinoma. Okay. Now, site. Anatomically, stomach has 2 curvatures, the lesser curvature and the greater curvature. The lesser curvature is where gastric adenocarcinoma is more frequently seen. Anatomically, the stomach is divided into various parts. So there's the fundus of the stomach, the body of the stomach, the pyloric antrum of the stomach, and the pyloric canal of the stomach. In which part of the stomach is gastric adenocarcinoma most commonly seen? And that most common site in stomach for gastric adenocarcinoma is antrum. And no, you don't have to mock this up as well. There's a clear logic behind it. See, the most common cause of gastric adenocarcinoma is what? It is Helicobacter pylori, right? It is Helicobacter pylori. Helicobacter pylori causes what? It causes chronic gastritis. Type B. And under gastritis, I had asked you to remember a formula, that is A is to B and B is to A. What does this mean? This means type A is to B and type B is to A. What does this mean? In type A, chronic gastritis, that is autoimmune chronic gastritis. It is the body and the fundus, B for body and the fundus of the stomach that is mostly affected. In type B chronic gastritis, that is Helicobacter associated chronic gastritis, B for A, it is the antrum of the stomach that is mostly affected. So type A is for B, means autoimmune is for body and fundus. Type B is for A, that is Helicobacter for antrum. So which part of the stomach is going to get affected? Antrum is going to get affected. So if Helicobacter associated chronic gastritis develops into gastric cancer or gastric adenocarcinoma, where is it going to be? It is going to be in the antrum. Since Helicobacter pylori is the most common cause, the most common site is antrum. Second, most common site in pernicious anemia. Now the risk factor has been specified. We are talking about pernicious anemia. Pernicious anemia leads to what? It leads to autoimmune chronic gastritis, autoimmune chronic gastritis type A, and A is associated with B for body and fundus. Remember fundus. So the most commonly affected part is fundus. If autoimmune chronic gastritis type A develops into gastric adenocarcinoma, where is it gonna be? It is gonna be in the fundus. So most common site in pernicious anemia is fundus. Most common site is antrum. Most common site in pernicious anemia is fundus. Lauren classification, the huge thing that you really need to remember, very, very important, VVVVI. Okay. Take a deep breath in. Take a deep breath and listen to me very carefully. According to Lauren classification, gastric adenocarcinoma is of two types, intestinal type and diffuse type. Intestinal type, as the name suggests, microscopically, you're going to see stuff that is present in intestine, that is glands. In diffuse type, microscopically, you are going to say cells that are present diffusely arranged. They are free from one another. Again, in intestinal type, the tumor cells or the neoplastic cells, they are present in a glandular pattern. In diffuse type, the neoplastic cell or the tumor cells, they are diffusely present. Let's see the microscopy. So you can see lots of glands. All of these are glands present in intestinal type of gastric adenocarcinoma. If I pick an individual cell out of this there is apical mucin vacuole, that is a mucin vacuole present at the apex of the cell. In diffuse type, the microscopy, the cells, they are diffusely arranged, they are not adherent to one another, and the cause is, I've already explained it right here, but let me repeat. Normally, the cells, they are adherent with one another with the help of EC adherence. Okay. After CDH1 mutation, there is loss of EC adherence. As a result, the two cells are no longer adherent with one another, and they become free. And they are diffusely arranged. If I take an individual cell out of this, so there's a large mucin vacuole. In intestinal type, the individual cell had apical mucin vacuole. In diffuse type, the individual cell has large mucin vacuole which pushes nucleus and cytoplasm to the periphery. As a result, the cell looks like a signet ring. See, the nucleus is pushed to the periphery and this is the margin of the cell. Does it not look like a ring? So this is signet ring cell. Here's the nucleus with the margin of the cell. The nucleus pushed to the periphery and the cytoplasm pushed to the periphery with the margin of the cell. It looks like a signet ring. Okay. Now the gross. Once let's again compare the microscopy. So what did you draw in exam? In intestinal type of gastric adenocarcinoma, you are going to draw lots of glands. And in individual cell, draw nucleus and then apical mucin vacuole, nucleus apical mucin vacuole, nucleus apical mucin vacuole, nucleus apical mucin vacuole, nucleus apical mucin vacuole. In diffuse type, draw cells that are diffusely arranged, and a large mucin vacuole that pushes nucleus to the periphery. Nucleus and cytoplasm to the periphery. Nucleus and cytoplasm to the periphery. Nucleus and cytoplasm to the periphery, giving it signet ring structure or signet ring cell. This is what you need to draw in your theory exam. Now, gross. In intestinal type, grossly, the tumor is bulky. It is bulky. There's bulky tumor, which is either exophytic or ulcerative. In exophytic, this is the inner wall of the stomach, and the tumor grows something like this. In ulcerative, this is the inner wall of the stomach and it has a breach or ulcer. You know what an ulcer is, right? It is a breach in the mucosa that can grow deeper into submucosa and may even perforate the complete wall. Now, talking about ulcer. Under the topic of peptic ulcer disease, for which I have a complete video, I have explained ulcer in detail. There I said that ulcers, they are of two types. You have benign ulcer and malignant ulcer. Benign ulcer is the one that you see in peptic ulcer disease. Malignant ulcer is the one that you see in case of malignancy or cancer, like in case of gastric adenocarcinoma. And an ulcer is defined grossly by three characteristics: the margin of the ulcer, the base of the ulcer, and the size of the ulcer. The margin of the ulcer, the base of the ulcer, and the size of the ulcer. First, let's look at malignant ulcer. Margin of the ulcer, it is irregular. And the margin, it's punched out. Or heaped up. The base, it is dirty and friable. The base is dirty and friable due to malignancy. And the size of malignant ulcer or the ulcer in gastric adenocarcinoma is greater than the size of ulcer in peptic ulcer disease or benign ulcer. It is usually greater than 2 cm. So that's the gross. Under diffuse type, the wall of the stomach is rigid, stiff, and thick. The wall of the stomach is rigid, thick, and stiff. And yes, there is a logic behind it as well. See, the neoplastic cell or the tumor cell, due to CDH1 mutation and loss of EC adherence, they are diffusely present, right? They are diffusely present. These are neoplastic cells. They are diffusely present. They are not adherent or connected with one another. So they can easily permeate or enter the wall of the stomach. These diffusely present neoplastic cells, tumor cells, they can easily permeate or enter the wall of the stomach. Once these tumor cells enter the wall of the stomach, they bring about desmoplastic reaction. What is desmoplastic reaction? What is desmoplasia? Babu, fibers, lots of fibers. So there's going to be lots of fibers in the wall of the stomach. It is going to be filled with fibers. Lots of fibers. Due to desmoplastic reaction, full of fibers in the wall of the stomach becomes rigid, thick. And this grossly is called lenitis plastica or leather bottle appearance, because the stomach looks like a leather bottle. So grossly, in intestinal type, the tumor is bulky, which is either exophytic or ulcerative. If it is ulcerative, it is obviously a malignant ulcer, which is characterized by irregular margin with punched out margin with dirty and friable base, and a large ulcer usually greater than 2 cm. In case of diffuse type, the wall of the stomach is thick, rigid, and stiff because of desmoplastic reaction brought about within the wall of the stomach by the tumor cell, which gives it a leather bottle appearance, which is called lenitis plastica. With that, we are done with gastric adenocarcinoma, which is the most common type of stomach cancer. 90% of the stomach cancer is gastric adenocarcinoma. Let's revise it once before getting into gastrointestinal stromal tumor, okay? So, gastric tumor, gastric adenocarcinoma, risk factors, food and drinks, 3 A's, and infection. Food and drinks. Don't miss out on alcohol and smoking. It is a risk factor for almost all the tumors in GIT. Then hot beverages. It causes cancer of esophagus as well as cancer of stomach, that is gastric adenocarcinoma. Smoked and salted food. Smoked and salted food is the reason why gastric adenocarcinoma was years ago endemic in Japan due to their culture of eating lots of smoked and salted food. 3 A's: pernicious anemia, adenomatous polyposis, and blood group A. Infection: Helicobacter pylori and Epstein-Barr virus. Helicobacter pylori. So Helicobacter pylori causes chronic gastritis, which eventually leads to intestinal metaplasia, which worsens into gastric adenocarcinoma. Which type? Intestinal type. Pernicious anemia. It is associated with autoimmune chronic gastritis, which eventually results in intestinal metaplasia, which worsens into gastric adenocarcinoma. Which type? Intestinal type. Familial adenomatous polyposis, which is mostly seen in intestine but might sometimes rarely be seen in stomach as well. It is 100% risk of developing into cancer. So cancer development in stomach as well. There is gastric adenocarcinoma. Which type? Intestinal type. Then CDH1 mutation. As a result, there is loss of E-cadherin and the cells become diffusely arranged, resulting in diffuse type of gastric adenocarcinoma. Site: lesser curvature has more gastric adenocarcinoma as compared to greater curvature. Most common part of the stomach where this tumor occurs, where the cancer occurs, is antrum, and the most common part of the stomach in pernicious anemia, cause has been specified. Pernicious anemia is fundus. Lauren classification: intestinal type and diffuse type. In intestinal type, microscopically, what you draw in exam, you draw lots of glands, and inside gland, individual cell has apical mucin vacuole. In diffuse type, what do you draw? You draw diffusely arranged tumor cells. This diffusely arranged tumor cell looks like a signet ring. The reason being there's a large vacuole inside which pushes the nucleus and cytoplasm to the periphery. Grossly, in intestinal type, the tumor is bulky, which is either exophytic or ulcerative. If ulcerative, the ulcer has irregular margin with hipped up or punched out margin, and the base is dirty and friable, and the size is larger than benign ulcer, usually greater than 2 cm. In case of diffuse type, the wall of the stomach is thick due to desmoplastic reaction within the wall of the stomach by the tumor cell, which is called linitis plastica because it looks like a leather bottle. Okay, so we are done with gastric adenocarcinoma. Now, the second type of gastric tumor, the most common malignant mesenchymal gastric tumor, that is gastrointestinal stromal tumor or GEST. The cell of origin is cell of Cajal. What is cell of Cajal? I hope you know your physiology. It is the pacemaker cell of stomach. A small concept. If you know this concept, the rest of the thing that I have written right here will become very easy. This is a cell which goes through the process of mitosis and divides into 2. But mitosis does not take place abruptly. On the surface of the cell, there's a growth factor receptor which receives growth factor or ligand, and then signal transduction within the cell takes place, followed by mitosis. Okay, that is how mitosis is controlled. It is under the control of growth factor. Normally, there's your cell on the surface of which there is growth factor receptor to which binds the growth factor. Then only signal transduction within the cell takes place, and then mitosis of the cell takes place. The cell divides into 2. So the process of mitosis is under the control of growth factor. So here proliferation of the cell is taking place, but it is under control. This is controlled proliferation. In case of tumor cell, what happens? This is the tumor cell. Here's the growth factor receptor. Here's the growth factor. Even in absence of growth factor, even when growth factor is not bound with growth factor receptor, signal transduction still takes place. Mitosis still takes place, and the cell still divides. Now, is mitosis under the control of growth factor? No, it is not. So, is proliferation controlled? No, it is not. This is called uncontrolled proliferation of tumor cell. So, uncontrolled proliferation takes place. The same thing happens in gastrointestinal stromal tumor as well. All you need to know is which cell is it And which receptor are we talking about? In gastrointestinal stromal tumor, the cell that divides uncontrollably or proliferates uncontrollably is the cell of Cajal. So it's the cell of Cajal which eventually becomes neoplastic. Which receptor is it? It is the tyrosine kinase receptor which becomes mutated. The tyrosine kinase receptor becomes mutated and it shows its activity of proliferation even in absence of growth factor. Let's see that right here in the diagram. So this is the cell of Cajal. Here's the transmembrane receptor. What is transmembranous receptor? A part of it is present outside cell and a part of it is present within the cell. It is linked with tyrosine kinase. That is, this transmembranous receptor is tyrosine kinase activity showing receptor, tyrosine kinase receptor. Receptor, what is it? It's a protein. Protein is coded by what? It is coded by a part of the DNA or a gene. So there's the gene as well that codes for tyrosine kinase receptor, which is tyrosine kinase receptor gene. So the tyrosine kinase receptor gene codes for protein that make up the tyrosine kinase receptor. Now, let's say mutation occurs in the tyrosine kinase receptor gene. Mutation occurs. As a result, the receptor that is formed, the tyrosine kinase receptor, is also mutated. What type of mutation takes place? Such a mutation where there is gain in function of the receptor. Gain in function of the receptor. What does it mean? Previously, when the receptor was not mutated, only when ligand binded with the receptor did signal transduction take place and cell proliferation take place. But now, since the receptor is mutated, what kind of mutation? Gain in function type of mutation. So even when ligand does not bind with the receptor still shows a signal transduction and proliferation of the cell proliferation still take place. This is what happens after mutation, okay? So first, there is mutation in the tyrosine kinase receptor gene. There is mutation in the gene. As a result, there is a mutation in the receptor itself. The receptor is mutated. What kind of mutation? Such a mutation that there is gain in function of the receptor. There is gain in function of the receptor. As a result, the receptor is active even in absence of ligand. That even when ligand does not attach with the receptor, signal transduction still takes place. And there is uncontrolled proliferation. Now, all you have to remember, all you have to mog up is that which gene gets mutated and which tyrosine kinase receptor gets mutated. Fine, that's all that you have to remember. In 75% of the cases of GIST or gastrointestinal stromal tumor, it is GIT gene that gets mutated. GIT gene. As a result, which tyrosine kinase receptor gets mutated? KIT tyrosine kinase receptor gets mutated. KIT gene forms KIT receptor. So if there is mutation in KIT gene, it's the KIT receptor that's going to be mutated now. Now, more specifically, it is called CKIT or CD117. In 8% of the cases, the gene that gets mutated is platelet-derived growth factor receptor alpha gene. This gene codes for which receptor? Platelet-derived growth factor receptor alpha. So if the gene is mutated, the receptor is mutated. Other rare mutations are succinate dehydrogenase, loss of function in Krebs cycle. This is seen in pediatric GIST. So one last time. GIST, gastrointestinal stromal tumor. It is the most common mesenchymal malignant gastric tumor. Malignant gastric tumor of mesenchymal origin, most common. The cell that becomes neoplastic is the cell of Cajal, which are the pacemaker cells of your stomach. What happens? So cell of Cajal has a receptor, transmembranous receptor on its surface. This transmembranous receptor gets mutated. So what you get is a mutated receptor. As a result, the receptor works even in absence of growth factor, and the cell proliferates even when ligand or the growth factor does not attach with the receptor. So what are the mutated receptors? There's the c-KIT and CD117 in 75% of the cases that get mutated. In 8% of the cases, it is the platelet-derived growth factor receptor alpha that gets mutated. In rare mutation cases, you have succinate dehydrogenase loss of function, which is seen in pediatric GEST. Microscopically, if in case of gastrointestinal stromal tumor, the individual cells, they are spindle shaped with less cytoplasm, it is spindle type. If it is round with more cytoplasm, it is epithelioid type. Finally, gastric lymphoma. So lymphoma is a topic that you might have already studied under WBCs, under blood cancer. But if you don't know, just for this topic, just know this much. Lymphoma is of two types, Hodgkin's lymphoma and non-Hodgkin's lymphoma. The most common type of non-Hodgkin's lymphoma is diffuse large B-cell non-Hodgkin's lymphoma. Hodgkin's lymphoma, it mostly arises from lymph node. Non-Hodgkin's lymphoma, 1/3 of the time they arise from other than lymph node or extranodal in origin. In gastric lymphoma, there is lymphoma in which thing? Lymph node. Stomach is lymph node. No, stomach is not lymph node. So it is arising in stomach. So it is extranodal in origin. So gastric lymphoma is your extranodal, non-Hodgkin's, diffuse large B-cell lymphoma. It is extranodal, non-Hodgkin's, diffuse large B-cell lymphoma. Let's see how it occurs. So here's the stomach, which has Helicobacter pylori infection, which leads to chronic metaplastic atrophic gastritis type B. There is eventually metaplegia, which metaplegia? Intestinal metaplegia. As a result, there is presence of malt within the stomach. Now begs the question, what is malt? Malt is mucosa-associated lymphoid tissue. Lymphoid tissue present within the mucosa of the GIT, mucosa-associated lymphoid tissue. For example, Peyer's patches, you know, Peyer's patches? Peyer's patches within your intestine is a malt. It's mucosa-associated lymphoid tissue. Peyer's patches is present in intestine. So malt is mostly present in intestine. It is not generally present in stomach. Malt is not generally present in stomach if you know your histology. But since there is intestinal metaplegia, things in intestine is gonna start showing up in stomach. That is, whatever is in intestine is now present in stomach as well. So there is malt in stomach as well. So malt is made up of lymphoid cells like B cells, and these malt, they end up showing lymphoma. And lymphoma, which is associated with malt, is called maltoma. So at the end of the day, maltoma is nothing but extranodal non-Hodgkin's diffuse large B cell lymphoma of your stomach. Okay. Once more. So there's your stomach, which has Helicobacter pylori infection, which leads to chronic gastritis, which eventually leads to intestinal metaplegia. Due to intestinal metaplegia, the appearance of the stomach becomes like that of the intestine. In intestine, there are Peyer's patches. Peyer's patches are your mucosa-associated lymphoid tissue or malt. So malt is generally present in intestine, not in stomach. But due to intestinal metaplegia, now malt is present in stomach as well. Malt is composed of B cells, and lymphoma in malt is called maltoma. Maltoma is nothing but the extranodal non-Hodgkin's diffuse large B-cell lymphoma of your stomach. Alright. Now there are mutations associated with gastric lymphoma as well. Before understanding the mutation, get this concept, okay? Concept about translocation. You have two chromosomes. This is chromosome number 1, this is chromosome number 2. Chromosome number 1 has A gene, chromosome number 2 has B gene. Now translocation between chromosome number 1 and 2 takes place. As a result, the A gene from chromosome number 1 will translocate to chromosome number 2. As a result, the chromosome number 1 will become smaller in size. It no longer has A gene. Chromosome number 2 will become greater in size. Now it has A gene as well as B gene. This is translocation. This is translocation. So this was A gene and that's your B gene. Now here is A gene as well as B gene. This is written as translocation 1:2. That is, a part of chromosome number 1 has translocated to chromosome number 2. And the end result is what? It is AB chimeric or fusion gene. Basically two genes, they have fused together, AB chimeric gene or fusion gene. This is translocation. Now let's look at various translocations that end up causing gastric lymphoma. Chromosome number 11 with apoptosis inhibitor 2 gene and chromosome number 18 with MLT1 gene. Translocation of chromosome number 11 and 18 takes place. As a result, there is formation of apoptosis inhibitor 2 and MLT1 fusion gene, which forms the apoptosis inhibitor 2 MLT1 fusion protein. Gene forms protein, so there is formation of fusion protein from translocation 11-18. Second, between 1 and 14, translocation of 1 and 14 results in increase in BCL10. Third, between 14 and 18, translocation between 14 and 18 also results in increase in BCL10. There is increase in BCL10. All three cases, be it the fusion protein, that is apoptosis inhibitor 2 and MLT1, API2-MLT1 fusion protein, or BCL10 or BCL10, increase in BCL10, all of them lead to single thing, and that is activation of nuclear factor kappa beta. As a result, there is B cell proliferation, which leads to gastric lymphoma. 3 translocations: translocation 11-18, translocation 1-14, and translocation 14-18. Okay, easy to remember. Translocation 11-18, translocation 1-14, translocation 14-18. Okay, this leads to fusion protein, and these two lead to increase in BCL10. Both of them eventually lead to activation of nuclear factor kappa beta and B cell proliferation. This is the microscopy of gastric lymphoma. Since it's a lymphoma, which is a B cell tumor, what would you expect to see? The whole of lamina propria is filled with B cells. So there are lots and lots of B cells. Along with that, the most peculiar or characteristic feature of gastric lymphoma microscopically, which you gotta remember, is lymphoepithelial lesion. What is that? See, your gastric wall contains glands, and these glands, they are made up of epithelial cells or glandular epithelium. These epithelial glands, they are surrounded by lymphoid cells or B cells, and some of these B cells, they even invade the epithelium of the gland. So there's a lesion made by the lymphoid cell in the gland made up of epithelial cell. That's why a lymphoepithelial lesion. And with that, we are done with gastric lymphoma as well. That's all that you need to know about gastric tumor. The topic is inflammatory bowel disease. That means it's a pathology. Pathology of what? It is the pathology of your bowel, that is your intestine. It's the pathology of your intestine. What type of pathology of your intestine? It is an inflammatory pathology. That means it is associated with inflammation, plus there is also ulceration. So inflammatory bowel disease is a disease or pathology of your bowel or intestine that is associated with inflammation and ulceration. Again, inflammatory bowel disease of your bowel, pathology of your intestine that has inflammation and ulceration. Under inflammatory bowel disease, we are going to learn about 2 diseases: Crohn's disease and ulcerative colitis. So we are going to learn about Crohn's disease and ulcerative colitis. Both Crohn's disease and ulcerative colitis, they are inflammatory bowel disease. That's why, in order to make your life easier, what I'm gonna do is teach you both the diseases in a comparative fashion under similar headings. That will make mogging up points easier. But we know very well, mogging up several points, point after point, is really tough and tedious. So what I'm going to do is, after having taught you both the diseases in comparative fashion, I'm going to make a single diagram for both of them. And that single diagram is going to inculcate all the points that I'm going to teach you right now. And that will help you visualize or memorize very easy. Okay. With all that guff, let's begin the comparative study between the two inflammatory bowel disease. Those are the Crohn's disease and ulcerative colitis. Are we ready? All right. First, we will look at the gross, then we will look at the microscopy. First, gross of both the diseases. In Crohn's disease lesion, we have skip lesion. That is, a part of the intestine has lesion, then there is normal part of the intestine. Again, there is lesion, again normal part of the intestine, again lesion, and then normal part of the intestine. That means the lesion is skipping over normal part of the intestine. The lesion, it is not continuous. There is lesion and then normal, lesion and then normal. See, so here's the lesion and then normal intestine. Here's the lesion and then normal intestine. Here's the lesion again. Here's the normal intestine and then the lesion. Again, normal intestine and then the lesion. As you can see, the lesion, it is not continuous. It is skipping over a part of normal intestine. So there are skip lesions in Crohn's disease. Next, ulcerative colitis lesion. You can see that the lesion is continuous. It is continuously spreading. There is no normal part within the lesion. The complete involved part has the pathology. There is no normal and then lesion, normal and then lesion. Continuous. The lesion is continuous. Second, most common site. In Crohn's disease, the most common site of involvement are, the most common site of lesion are the terminal ileum, the ileocecal junction, and the cecum. Again, the terminal ileum, the ileocecal junction, and the cecum. In ulcerative colitis, the rectum is always involved. The rectum is always involved, and it is from rectum that the lesion starts to spread backward. All right. Next, spread. So in Crohn's disease, what did I say? The most common site of lesion are your terminal ileum, the ileocecal junction, and the cecum. Let's say the lesion begins at the ileocecal junction. Now from the ileocecal junction, the lesion spreads both forward and backward. That is both antegrade and retrograde spread. Antegrade from ileocecal junction, it's going to involve the large intestine, the colon. It is going to involve the large intestine. And retrograde, it is involving the small intestine. It is involving the small intestine. From small intestine, it can spread into stomach, and then it can go back into esophagus. So retrogradely from backward, by going backward from ileocecal junction, it can involve the ileum and then the stomach and then the esophagus, and it can involve the complete gastrointestinal tract. Okay. In ulcerative colitis, what did I say? I said that in ulcerative colitis, the lesion begins at rectum. And from the rectum, the lesion continuously, without skipping any region, spreads backward. See, it's going backward or retrograde fashion. Now, depending on how much part of the intestine is involved, it's of different type. So it begins at the rectum, we know that. And if only rectum is affected, that is proctitis. The lesion, it is within the rectum only, that is proctitis. Procto refers to rectum. If it involves the rectum and goes backward and spreads into the sigmoid colon as well, it is proctosigmoiditis. Procto referring to rectum and sigmoid referring to the sigmoid colon. If it spreads further involving rectum, sigmoid colon, and a descending colon, this is distal colitis because the complete distal part of the large intestine is involved. If it involves majority of the large intestine, that is the rectum, the sigmoid colon, the descending colon, as well as the transverse colon, there is extensive involvement. This is called extensive colitis. If it involves the complete large intestine, rectum, sigmoid colon, descending colon, transverse colon, as well as ascending colon. There is complete colonic involvement. So pancolitis, sometimes pancolitis can worsen and exaggerate and enter into the terminal part of the ileum. Since the spread takes place backward and this backward spread enters into the terminal ileum, this is called backwas ileitis. Alright, till now what have we seen? Crohn's disease, ulcerative colitis. In Crohn's disease, lesion, there are skip lesions. Lesion, normal. Ulcerative colitis, continuous lesion. There is no normal within the lesion. The lesion spreads continuously. In Crohn's disease, the most common site of lesions are the terminal ileum, ileocecal junction, and cecum. In ulcerative colitis, the most common site of lesion is the rectum. Not most common site, it always involves the rectum, and from rectum the spreading begins. Okay, in Crohn's disease the spread is, let's say it begins at the ileocecal junction, then it spreads both forward in antegrade fashion and involves the large intestine, and backward in retrograde fashion and involves the small intestine. It may even involve the stomach, esophagus, and the complete gastrointestinal tract by going backward. In ulcerative colitis, it begins at rectum and it can only go backward. It goes backward continuously without leaving a site, without skipping a site. So continuous lesion goes backward. If only colon is involved, that is proctitis. If colon and sigmoid colon is, if only rectum is involved, that's proctitis. If rectum and sigmoid colon is involved, that's proctosigmoiditis. If complete colon is involved, that's pancolitis. If from colon it enters the terminal ileum, that is backwas ileitis, because it is coming backward into the terminal ileum. So backwas ileitis. Okay, I hope this much has been mocked up in your brain. Okay, let's move on. So in ulcerative colitis, let's take one of them, proctosigmoiditis. You can see that the lesion, it spreads backward. So there is area of lesion and there is abrupt demarcation between lesion and normal mucosa. This much mucosa has lesion and this much is normal. So there is abrupt change from lesion to normal. So if I cut this much portion out, this is what it looks like in the cadaver. This is the lesion and this is normal, and there is abrupt demarcation between lesion and normal. In pancolitis, it is the complete colon that is involved. So if I take out this colon, this is what it looks like. The complete colon is involved, pancolitis. Okay, let's move on. Next, differentiating under the basis of ulcer. First, Crohn's disease. The very first lesion in Crohn's disease is aphthous ulcer. These aphthous ulcer, they grow and spread and connect with one another in snake-like pattern, which is now called serpentine ulcer. So these snake-like pattern forming ulcers are called serpentine ulcer. In between these serpentine ulcer, there is mucosa that is not involved. Bro, you know what ulcer is, right? You know ulcer, right? Ulcer is nothing but a breach in mucosa that can involve submucosa and may even perforate even inside, involving muscularis and creating complete perforation inside to outside. That's ulcer. Now, there are snake-like ulcer throughout, and in between these snake-like ulcer, there is mucosa that is not involved, that is spared. These spared mucosa, they swell up, and the spared swollen up mucosa along with serpentine ulcer gives cobblestone appearance. So these stones that you see, they look like the swollen mucosa, and in between them there is serpentine ulcer. Okay, here's the endoscopy. All these swollen thing that you see, these are the mucosa that is spared, the mucosa that is uninvolved, and in between them you have the serpentine ulcer. In ulcerative colitis, after ulcer, there are parts of mucosa that are regenerating And these regenerating mucosa, they look like polyp. So these are the regenerating mucosa that look like polyp. However, they are not true polyp, so they are referred to as pseudo polyp. So these are the regenerating mucosa that give a polyp-like appearance. Some of these pseudo polyp, they grow and fuse with one another, forming bridges. So you can see right here, a bridge 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 here. These bridges, they are connecting the pseudo polyps together. Okay. Next, Crohn's disease. We were talking about ulcer. In Crohn's disease, we have deep ulcer. Remember, in Crohn's disease, we have deep ulcer. Ulcer, normally, it involves mucosa. However, in case of Crohn's disease, it grows deeper into submucosa and even involves muscularis layer. See here, this is the Crohn's disease, lumen of the Crohn's disease, and this is the wall of the intestine with Crohn's disease. There is ulceration throughout mucosa, ulceration throughout submucosa, and even the muscular part is involved. And these deep ulcers that you see now, these are referred to as fissures. So there are deep ulcers referred to as fissures. Sometimes these ulcers grow so deep that they perforate through the whole wall. They perforate through the whole wall. As a result, the cavity inside communicates with cavity outside, and this pathologic connection between two cavities is known as fistula. See, there is perforation in the wall of the intestine right here, creating fistula. So there are, in Crohn's disease, deep ulcers, which are referred to as fissures, that can grow deeper and create perforation, which results in fistula. Okay. In ulcerative colitis, however, there are shallow ulcers. That is, only mucosa or submucosa is involved. It does not perforate. It does not perforate the muscular layer. It does not perforate the muscular layer. So there are no fissures. If there are no fissures, how can there be fistulas? So there are no fistulas. See, you can see right here as well. So there are these superficial ulcers in ulcerative colitis. In between them, there are these regenerating mucosa that give off polyp-like structure referred to as pseudopolyp. So these are pseudopolyp. All right. Once more, let's revise the ulcer of both of them. First, Crohn's disease. The very first lesion that you see in the wall of the intestine of Crohn's disease is aphthous ulcer. These aphthous ulcer, they grow and connect with one another in snake-like pattern. This is serpentine ulcer. In between these serpentine ulcer, there are parts of mucosa that have been left or spared, that is not involved. These mucosa that has been spared, they swell up, and then these swollen up spared mucosa along with serpentine ulcer give cobblestone appearance. The ulcer in Crohn's disease is deep or superficial. Which one? It is deep. These deep ulcer, they not just involve mucosa, not just submucosa, but also muscular layer, creating deep ulcers referred to as fissures. Sometimes these fissures grow so much that they create perforations in the wall of the intestine. As a result, the cavity inside the intestine communicates with cavity outside. This pathologic communication between two cavities is referred to as fistula. So there is fistula as well. In ulcerative colitis, there are deep or superficial ulcer. There are superficial ulcer. That means it does not involve the muscular layer. In between these superficial ulcer, there are regenerating mucosa that look like polyp but are not actually polyp, so-called pseudopolyp. These pseudopolyp, they grow and communicate with one another with the help of bridges. All right. In the next topic, you will be learning about intestinal polyps. Under there, you have neoplastic and non-neoplastic intestinal polyp. And under non-neoplastic intestinal polyp, you have the inflammatory non-neoplastic intestinal polyp. And the example of that is pseudopolyp, just for your knowledge. Okay. Next, the wall of the intestine. In Crohn's disease, there is transmural involvement. That means the complete thickness of the wall of the intestine is involved. Involved how? There is inflammation through the complete thickness of the wall. As a result, there is a repair and fibrosis through the complete thickness of the wall. See, this is the wall of the intestine with Crohn's disease. The complete thickness of the wall, goes through fibrosis. It goes through fibrosis. As a result, the wall becomes thick. The wall is thick, but the lumen is narrow. And this abnormal narrowing of the lumen is referred to as, in medicine, strictures. So there are strictures. This is how Crohn's disease has thick wall with narrow lumen or strictures due to transmural involvement, transmural fibrosis. Now, normally, this is your intestine. One of the borders of the intestine is the mesenteric border, and to this mesenteric border, the mesentery of the intestine is attached. On this mesentery, you have lots of fat. This is what normally we have. In case of Crohn's disease, as I said earlier, there is transmural involvement. That is, there is fibrosis throughout the complete thickness. That means outside also there is fibrosis now. So there is injury and fibrosis outside the intestine as well. What happens is that the fat present within the mesentery, it sticks on these fibrosis places, the places with fibrosis. At these injurious places, they stick and they spread over throughout the intestine. They creep over the intestine, and this is referred to as creeping fat. So this is creeping fat. Again, normally here's your intestine, and to the mesenteric border of the intestine, the mesentery is attached and the mesentery has fat. In Crohn's disease, since the outer wall of the intestine has gone through fibrosis, ulceration, injury, what happens is that the fat, it creeps over the outer surface of the intestine and attaches to these places and then creeps over it, called creeping fat. Covers the whole intestine from outside. Next, ulcerative colitis. In ulcerative colitis, there is no transmural involvement. As a result, there is no stricture. As a result, there is no creeping fat. But what you need to remember is that there is loss of hostrations. In ulcerative colitis, there is loss of hostration. So the feature, number one, the presence of stricture in Crohn's disease, and number two, the loss of hostration in ulcerative colitis. Both of them are appreciable under radiography. So what we did was we took a barium study of the intestine with Crohn's disease and ulcerative colitis, and saw the X-ray behind it. So this is what it looks like. First, the Crohn's disease. You can see right here, these feathery intestine. That is your jejunum. The smooth intestine, on the other hand, that's your ileum. At the end, the ileum has become very thin, right? This is the terminal ileum. And then terminal ileum, it ends in this funnel-shaped structure called the cecum. Okay. Now use your logic. In Crohn's disease, which part is most commonly affected? Terminal ileum. Second thing, in Crohn's disease, what happens? The wall becomes thin and the lumen becomes narrow. That is, there is stricture, narrow lumen, stricture. So if there is barium study, what is appreciated? Wall or the lumen? Obviously, the lumen is appreciated under X-ray. Under X-ray, what we are looking at all of this is the lumen of the intestine. Since there is thinning of the lumen, stricture, so stricture is present as well under barium study in the form of a string, dhago, string, and this is string sign. So string sign under barium study X-ray due to the presence of stricture in the terminal ileum as a result of Crohn's disease. Second, ulcerative colitis. In ulcerative colitis, the end result is loss of hostration. So can you see the loss of hostration? See, it begins at the rectum, then it spreads to the sigmoid colon, then the descending colon, then the transverse colon. Throughout this much, you can see that there is loss of hostration, and that is why it gives lead pipe appearance. It looks like a lead pipe due to loss of hostration. Okay, Now I'm going to make two separate diagrams for the two separate diseases, Crohn's disease and ulcerative colitis. And with the help of this diagram, I will be incorporating all the points that I have taught till now. Starting off with Crohn's disease. So what I'm going to do is ask you a question and then answer that question with the help of the diagram. Okay, Crohn's disease. First question. What is the most common site where the lesion is present in Crohn's disease? Terminal ileum, ileocecal junction, and cecum. So let's draw that. Terminal ileum, the ileocecal junction, and cecum. Okay. Next question. What type of lesion do we get to see? Skip lesion. That is, there is a part of the intestine that has the lesion and then a part of the intestine that does not. Again, a part of the intestine that has the lesion and then a part of the intestine that is normal. So let's say this much part has the lesion, the terminal part, okay? So here it is. This is the lesion. What kind of lesion do we have? We have skip lesion. That means if this much part has lesion, this is the uninvolved part. So that's normal. Third question. What kind of spread is seen? So the spread is both retrograde and antegrade. That means if lesion is present right here, it will spread forward throughout the large intestine as well as backward throughout the small intestine and eventually into stomach and esophagus, involving the complete GI tract. Okay. Fourth question. What is the morphology of ulcer that is seen? The very first ulcer that you get to see are the aphthous ulcer. So these are the first lesions of Crohn's disease, the aphthous ulcer. These aphthous ulcer, they grow and connect with one another in snake-like pattern. Referred to as serpentine ulcer. So these ulcers, they are referred to as serpentine ulcer. Now in between these serpentine ulcer, what can you see? You can see areas that are not involved or mucosa that is not involved. These mucosa that are not involved, they swell up. And these swollen uninvolved mucosa along with the serpentine ulcer give off cobblestone appearance. So let's write that. We have our serpentine ulcer, and then we have the swollen mucosa, the swollen spared mucosa, and both together give off the cobblestone appearance. Okay. Now, another thing about ulcer. Is it deep or superficial in case of Crohn's disease? It is deep. So ulcer is deep. That is, it involves mucosa, submucosa, as well as the muscular layer. These deep ulcers involving the muscular layer as well are referred to as fissures. These fissures, they grow deeper and convert into fistula. So let's make them. There's fissure and then there's your fistula. Fissures and fistula. Okay. Next question. Ulcer done. Next is wall. What kind of involvement is there in the wall? There is transmural involvement. That is complete thickness of the wall of the intestine where the lesion is seen is involved. There is fibrosis throughout the complete thickness. As a result, the wall is thick. There's thick wall. And the lumen is thin. This thin lumen is referred to as stricture. So we get to see thick wall and thin lumen. The thin lumen is referred to as stricture. Due to transmural involvement, fibrosis throughout the thickness of the wall takes place. That means there is ulcer and fibrosis outside wall, in the outer wall as well. As a result, the fat from the mesentery, it completely covers the intestine as it gets attached to the ulcer and fibrosis present on the outer wall. And this fat is referred to as the creeping fat. The creeping fat. And yeah, that's pretty much it for Crohn's disease. Next diagram for ulcerative colitis. Same questions. First, which is the most common site of lesion in ulcerative colitis? The rectum is always involved. So let's draw the rectum. There's the rectum. Okay. Second, what kind of lesion is present here? Continuous lesion is present here. That is, it starts from the rectum and then spreads continuously. What is the spread? It spreads the retrograde fashion, that is backward. It spreads continuously. Let's say this is an example of proctosigmoiditis. That is, there is inflammation of procto referring to rectum and the sigmoid colon. So I'm gonna take a piece of the wall of the sigmoid colon out to show you what is going on inside. Okay. There you go, there we go. Join the two together. Okay. So now we can see what is happening inside the colon itself. What kind of lesion is present? We have continuous lesion which starts at the rectum and spreads retrograde fashion. Okay. Next question. Something about ulcer. What type of ulcer do we have here? We have superficial ulcer. That is, it is only the mucosa and submucosa that is involved. The muscular layer is not breached. There is no breach in the muscular layer. So there are superficial ulcer. Then there are parts of mucosa that is regenerating. These regenerating parts of mucosa, they appear as polyps. And they are referred to as pseudopolyps. Some of these pseudopolyps, what happens to them? They connect with one another with the help of breaches. But first, let's fill the whole thing up because it is continuous, so you can't leave a part in the middle. I mean, if you left it, it would be skipped. You can't skip a part in the middle. And then let's draw some breaches here and there. Okay. There is first superficial ulcer. In between these superficial ulcer, there are regenerating mucosa that appear as polyp but are not true polyps, so pseudopolyp. These pseudopolyp, they grow and connect with one another with the help of breaches. Now, is the ulcer deep or superficial? I have already said it. It's superficial. That means, can you see fistulas and fissures? No, absolutely not. There are no fissures. There are no fistula. Next, wall. Is there transmural involvement? No, transmural involvement is not present. That means there is no creeping fat. That means there is no structure because the wall does not become thick and the lumen does not become thin. But what is present there is loss of hostration. There is loss of hostration. Wall also done. Okay? That's the diagram that you need to draw in your exam. With that, we are done with the gross. Now let's compare the microscopy of both of them. Crohn's disease, ulcerative colitis. In Crohn's disease, I said that there are ulcers. What type of ulcers? Deep ulcers. And these deep ulcers are referred to as fissures. So in microscopy, you can see fissures. Simple. There is mucosa and then there is deep ulcer involving muscular layer as well. Mucosa, breach in mucosa, submucosa and muscular layer. These are referred to as fissures. We have deep fissures. Second thing I said in Crohn's disease is that there is transmural involvement. Transmural involvement, that is the complete thickness is involved. Mucosa, submucosa, muscularis. What kind of involvement? First, inflammation is throughout, then fibrosis is throughout. So you can see inflammatory cell throughout the wall, throughout the thickness of the wall. So these are the inflammatory cells throughout the thickness of the wall. Even in muscular layer, you can see the inflammatory cells. And third, the distinguishing feature or the typical feature of Crohn's disease is the presence of non-caseating granuloma. There is non-caseating granuloma. Ulcerative colitis. In ulcerative colitis, I said that the ulcer, they are superficial. So in microscopy also you can see superficial ulcers. See, there is mucosa, and then a breach in mucosa. Is the breach in mucosa deep or superficial? It's superficial. So there is superficial ulceration. Second thing I said that in ulcerative colitis, there is no transmural involvement. Okay, that means it is not the complete thickness of the wall that shows inflammation. So you can see inflammatory cell because it is an inflammatory disease, but not in muscular layer. Unlike Crohn's disease, in muscular layer also there are inflammatory cell, but in ulcerative colitis, inflammatory cell are not in muscular layer. A typical feature of ulcerative colitis is the presence of crypt abscess. What is crypt abscess? Abscess is nothing but localized pus. If the pus is localized in the crypt of the intestine, that is crypt abscess. Simple. Again, three things: ulcer, wall, and the typical feature. In Crohn's disease, there are deep ulcers referred to as fissures. There is transmural involvement. So in complete thickness, there are inflammatory cell. Typical feature, presence of non-caseating granuloma. In ulcerative colitis, the ulcer, they are superficial. So there is superficial ulceration. Wall, there is no transmural involvement. So inflammatory cells are not present in muscular layer. Typical feature, presence of crypt abscess. That is pus localized within the crypt of the intestine. Now let's take these typical features and look at the histology shown in your Robbins. First, Crohn's disease. So first was ulcer. What kind of ulcer are there? Deep ulcer. So you can see the deep ulcer or fissure right here. Second, the typical feature is non-caseating granuloma. Here is the non-caseating granuloma. Third, there is transmural involvement, that is the complete thickness of the wall is involved. So there are non-caseating granuloma throughout the complete thickness, Next, ulcerative colitis. First, what kind of ulcer are there? Superficial ulcer. So you can see right here, there is superficial ulcer. Second, is there transmural involvement? No. So you can see only up to this much part of the wall is involved. Below that, there is no involvement. Third, what is the typical feature? Presence of crypt abscess. So here's the crypt abscess. What is crypt abscess? There is your crypt which is lined by glandular epithelium, and within the crypt there is localized pus. So localized pus within crypt is crypt abscess. And with that, we are done with Crohn's disease and ulcerative colitis, both gross and microscopy. So if in exam they ask you about Crohn's disease, draw this diagram for gross, draw this diagram for microscopy. If they ask you about ulcerative colitis, draw this diagram for gross, draw this diagram for microscopy. In microscopy, remember 3 points. First, the ulcer. Second, the wall. And third, the typical feature. Like in case of Crohn's disease, the ulcer is deep, referred to as fissures. In ulcerative colitis, the ulcer is superficial. In Crohn's disease, the wall, there is transmural involvement, so inflammation throughout. In ulcerative colitis, there is no transmural involvement, so there is no inflammation throughout. Number 3, typical feature. In Crohn's disease, there is presence of non-caseating granuloma, and in ulcerative colitis, there is presence of crypt abscess. Gastrointestinal polyps. They are mostly present in your large intestine, which includes colon and rectum. However, rarely the polyps might arise in small intestine, stomach, or esophagus. For example, under the etiopathogenesis of gastric adenocarcinoma, I had taught you that one of the ways gastric adenocarcinoma can develop in your stomach is via something called familial adenomatous polyposis. So in stomach, first there is familial adenomatous polyposis, and this eventually leads to gastric adenocarcinoma. What is familial adenomatous polyposis? That's lots of polyps in your stomach. So see, there's polyps in your stomach, right? However, the fact is that in gastrointestinal tract polyps, right, they are almost always present in your large intestine, that is your rectum and colon, but rarely they might also arise in small intestine, stomach and esophagus. So very important, keep it in your mind. Gastrointestinal tract polyps, they are present in colon, rectum, rectum. Grossly, polyps are of two types. If it is without a stalk, it is sessile. If it is with a stalk, it is pedunculated. Simple. Now the thing is that most of us find the topic of intestinal polyps to be one of the toughest under gastrointestinal tract or GI system. However, the fact is that it is the other way around. It is probably one of the easiest topics out there. The reason being, if you, even if you just know the name of the polyp, just the name of the polyp, that will be more than enough for you to describe every point you need to under that particular topic, under that particular polyp. And I will make sure that in this lecture, just by looking at the name of the polyp, you will be able to describe everything under it. So with that being said, let's carry on. Intestinal polyps. What are they? They are the polyps present in your intestine. Where are they mostly present? In large intestine, that is colon and rectum, but rarely they might arise in small intestine and then in stomach and esophagus. All right. Intestinal polyps, they are of two types. Non-neoplastic intestinal polyps, neoplastic intestinal polyps. Non-neoplastic polyps, they don't become cancer. That's why non-neoplastic. Simple. Neoplastic intestinal polyp, they may become cancer. That's why neoplastic intestinal polyp. Under non-neoplastic intestinal polyps, you have three major types. Number one, inflammatory polyp. Number two, hyperplastic polyp. Number three, hamartomatous polyp. Again, inflammatory polyps, hyperplastic polyps, and hamartomatous polyps. Under neoplastic polyps, you have adenomas. So all intestinal neoplastic polyps, not all, but almost all intestinal neoplastic polyps, they are nothing but intestinal adenomas. And intestinal adenomas, they eventually develop into adenocarcinoma. What is adenocarcinoma? It is a cancer. That's why it is neoplastic, because it can develop into a cancer. Okay, so individual polyps one by one. And I told you that just by knowing the name of the polyp, you will be able to answer everything that you need to. But just at least remember the name first. So there is intestinal polyp, which is of two types, non-neoplastic and neoplastic. Under non-neoplastic, you have three major types, inflammatory, hyperplastic, and hamartomatous. Under neoplastic, you have all the adenomas. So starting off with non-neoplastic intestinal polyps. The very first, inflammatory polyp. Inflammatory polyp is such a polyp that is as a result of inflammation. Simple. Where is the polyp present? In large intestine, that is rectum and colon. So where is the inflammation? In large intestine, rectum and colon. What is the inflammation of rectum and colon called? It's ulcerative colitis. I have already taught you this. I have already taught you the topic of ulcerative colitis. Go wash that out. And if you have knowledge about ulcerative colitis, you very well know that under ulcerative colitis, you have something called pseudopolyps. See, this is what happens in ulcerative colitis. There is inflammation of colon and rectum, and then within the inner wall, there is ulcer formation. In between these ulcer, there are regenerating mucosa. These regenerating mucosa, they look like polyps, but they are not actually polyp. They just look like polyps, so-called pseudo polyp. They are regenerating mucosa. And these pseudo polyps that are a result of ulcerative colitis, which is nothing but the inflammation of colon and rectum, is your inflammatory polyp. And if you are still confused about ulcerative colitis, that's because you haven't watched my video of ulcerative colitis. Do watch that out or read it on your own, whatever be the case. Second, hyperplastic polyp. The name says itself, the polyp is as a result of hyperplasia of cell. So there is too much cell coming, so they gather around together and form a polyp. Now the question is, which cells go through hyperplasia resulting in polyp? There is hyperplasia of the epithelial cell lining the inner wall of the intestine, the large intestine, and the epithelial cell forming epithelial mucosa, or the inner lining of large intestine are what? What cells are lining the large intestine? There are two cells on Nila. There is goblet cells that produce mucus, goblet cell, and then there is absorptive cell that are responsible for absorption, absorptive cell. So these two cells, they go through the process of hyperplasia. Now, okay, so goblet cell and absorptive cells, they go through hyperplasia, they increase in number, right? And they get collected at a place, forming a polyp, that is hyperplastic polyp. Now there are two sites where hyperplasia takes place, resulting in two different gross morphologies. Microscopy, resulting in two different microscopy. First, at the surface of the polyp, hyperplasia at the surface of the polyp. Second, hyperplasia within the polyp. First, at the surface of the polyp. When there is increment or hyperplasia of goblet cell and absorptive cell at the surface of the polyp, this results in formation of tufts. There is formation of tufts. If you zoom into one of these tufts, you can see there are lots of goblet cells, and in between these goblet cells, there are absorptive cells. Okay, so the increment in goblet cells and absorptive cells, they have resulted in formation of tuft. So on the surface of the polyp, there are tufts. Second, within the polyp, goblet cells and absorptive cells are present in the form of what? In the form of crypts. So if there is increment in the number of goblet cells and absorptive cell, there is also increment in the number of crypts. Simple logic. So there is increment in the number of crypts. Now what I'm going to do is take out one of these crypts. I'm going to take this crypt out. Okay. Within this crypt, there is increment in the number of epithelial cells, increment in the number of goblet cells and absorptive cells. As a result, the crypt becomes serrated. See, the margin, the inner margin, it is irregular or serrated. You get serrated crypt. But the important fact is that the serrated crypts are present only in the upper 1/3 of the polyp. See, there is the serrated crypt, 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 serrated crypt, serrated crypt, serrated crypt, serrated crypt. Then there's the serrated crypt, serrated crypt, serrated crypt, serrated crypt, serrated crypt. So in fact, it is present only in the upper 1/3 of the polyp. Good? All right. Let's revise both of them once. So you had intestinal polyp, under which you have non-neoplastic intestinal polyp and neoplastic intestinal polyp. Neoplastic intestinal polyps were intestinal adenomas. Under non-neoplastic intestinal polyp, you have three: inflammatory polyp, hyperplastic polyp, and hamartomatous polyp. Till now, we have seen inflammatory polyp and hyperplastic polyp. Inflammatory polyp. Inflammatory polyp. Inflammatory polyp is due to inflammation. Inflammation of what? Inflammation of rectum and colon, basically your large intestine, which is what? Which is ulcerative colitis, where what can you see? You can see pseudo polyps. What are pseudopolyps? They are regenerating mucosa in between ulcers. They are inflammatory polyp. Second, hyperplastic polyps. Hyperplastic polyps are as a result of what? Hyperplasia. Hyperplasia of what? The goblet cells and absorptive cells. The goblet cells and absorptive cells, which takes place as two levels at surface, resulting in formation of tufts within, resulting in increase in number of crypts, as well as serrated crypts, where in upper 1/3. Done. That's it. Third, Hamartomatous polyp. Under Hamartomatous polyp, you have lots of syndrome that you need to study. So let's begin with the first one. Juvenile rectal polyp. Again, name, everything is written in the name, brother. Juvenile rectal polyp. Juvenile, so it is found within children under the age of 5 years. Rectal, that means the polyp is present within the rectum, resulting in on and off rectal bleeding. That is, there is bleeding through rectum, which is there and then not there and then not there, on and off. Polyp, the typical microscopic feature of polyp is that there are cystically dilated glands within the polyp. See, here's the juvenile rectal polyp, and within it are the cystically dilated glands. The cystically dilated glands within the juvenile rectal polyp. Juvenile rectal polyp, there are two types. You have retention polyp and polyps of a syndrome, juvenile polyposis syndrome. Again, juvenile rectal polyp, there are of two types. They are either sporadic or syndromic. Sporadic polyp or syndromic polyp. Sporadic polyp, they are also referred to as retention polyp. They are single, solitary. So the sporadic polyp is solitary polyp, referred to as retention polyp. Syndromic polyp, see, the name says itself, it's syndromic. That is, there is some kind of syndrome. In syndrome, what do you have is, in syndrome, you have polyp plus some extra intestinal clinical manifestation. That is what you are going to see in manifestations in syndrome. So here you have juvenile polyposis syndrome. So there is polyp within the rectum, right? But these are not solitary polyp. There is not single polyp. There's 200 to 300 polyps. There are multiple polyps, right? And the involvement is a systemic because it is syndromic. That means there is involvement of multiple systems. There is polyp in the intestine, yes, but then there is also clinical manifestations in other systems of the body. It is inherited. Syndromes are inherited. There is genetic mutation carrying it through generations, and the genetic mutations are SMAD2, SMAD4, BMPR1A. And yes, juvenile polyposis syndrome has the risk of developing into cancer. It can develop into cancer. Retention polyp does not develop into cancer. Again, let me explain you. You have juvenile rectal polyp. Okay, juvenile, that means it is present in children under the age of 5. Rectum, that means the polyp is present within the rectum, resulting in on and off rectal bleeding. And the characteristic microscopic feature of polyp is that there are cystically dilated glands. So these are the stuff about polyp. Now juvenile rectal polyp, there are two types. It is either retention polyp, or it is juvenile polyposis syndrome. Retention polyp, it is sporadic. Juvenile polyposis syndrome is syndromic. Retention polyp is solitary. Juvenile polyposis, that means there are multiple polyps. That's why polyposis, 200 to 300 polyps in rectum. Retention polyp is not inherited. However, juvenile polyposis syndrome is inherited. So there are mutations. They are SMAD2 mutation, SMAD4 mutation, and BMPR1A mutation. Retention polyp, it is not systemic. That means there is polyp in the rectum and that's all. But juvenile polyposis syndrome, since it's a syndrome, there is polyp in the rectum, plus there is also systemic involvement, extraintestinal manifestation. It is systemic. Retention polyp, it does not develop into cancer. There is no risk of cancer. No risk of cancer. However, juvenile polyposis syndrome does have a risk of cancer. Risk of cancer. That's it. So that was the very first hamartomatous polyp, juvenile rectal polyp with juvenile polyposis syndrome. Second is Peutz-Jeghers syndrome. Very simple. Peutz-Jeghers syndrome. P for Peutz, P for polyp and pigmentation. That means, again, it's a syndrome. There is polyp. Yes, there is polyp. But along with that, there is also pigmentation. I'll explain you what kind of pigmentation, where pigmentation. J for jejunum. In juvenile rectal polyp, the polyp was present in the rectum. In Peutz-Jeghers syndrome, the polyp is present in the jejunum. Peutz-Jeghers syndrome loves the number 11. That is, it is present in 11 years of age. In juvenile rectal polyp, it was present in children under the age of 5. Peutz-Jeghers syndrome in 11 years of age. And it is due to STK11 mutation. Juvenile polyposis syndrome was due to SMAD2, SMAD4, BMPR1A. Peutz-Jeghers syndrome is due to STK11 mutation. I said it's a syndrome which shows polyps and pigmentation. First, polyps. So polyps, it's an arborizing polyp. That is, the polyp looks like a tree. See, there is the trunk of the polyp and then the branches of the polyp, and the whole thing looks like a tree. The trunk and the branches of the tree is made up of smooth muscle. Okay, here's the trunk and then inside are these branches. See, if you zoom into it, here are the branches, the red, whatever you see in red, these are all made up of smooth muscle. Pigmentation. There is blue to black macules. See, black macules. Blue to black macules that are present in lips, nostril, palm, and buccal mucosa. Okay, let's see. It's Peutz-Jeghers syndrome. P for Peutz, P for two things. There are polyps. What type of polyps do we have? Arborizing polyps. That is, they look like tree. Where what? Where the branches and the trunk of the tree is made up of? It's made up of smooth muscle. Second, P for pigmentation. Under pigmentation, you see what? Under pigmentation, you see blue to black macules. Where are these macules present? On lips, within nostril, on the palm, as well as buccal mucosa. J for Jeghers, J for jejunum. That means these polyps, they are present in jejunum and it loves the number 11. So it is found in 11 years of age and it is due to STK11 mutation. That's it, Peutz-Jeghers syndrome. Next. Okay, so these are not as important as those, but you need to know basic information, one-liners about each of these syndrome. Cowden syndrome, Den, N. So this is due to P10 mutation, which is present within chromosome number 10. Banayan-Ruvalcaba-Riley syndrome, or you can just call it BRR syndrome. Here again it's a syndrome, so there is polyps plus mental retardation. So there is CNS also affected, brain also affected. This is also due to P10 mutation present within chromosome 10. Then tuberous sclerosis, TSC mutation, TSC1 mutation and TSC2 mutation. TSC1 gene is responsible for the formation of hamartin protein, and TSC2 gene is responsible for the formation of tuberin protein. That means the mutated TSC1 and TSC2 also leads to mutated hamartin and tuberin. Then Crockett-Canada syndrome. This is non-hereditary. Out of all the Hamartomatous polyps that I have mentioned till now, Crockett-Canada syndrome is a non-hereditary. Again, syndrome, so there is polyp plus there is derma problems. Derma includes what? Skin, hair and nail. So skin pigmentation, hair, nail atrophy and hair loss. Again, we have Cowden syndrome and BRR syndrome. Both of them are due to P10 mutation, P10 mutation, which is present within chromosome number 10. Next, we have tuberous sclerosis. Tuberous sclerosis. It is due to TSC mutation. So there is TSC1 and TSC2 mutation. And finally, Crockett, Canada. Is it Canadian or Canada? Just Canada, okay. Canada syndrome. This is important because it is not inherited. It is not inherited. That means there is no genetic mutation associated with it. However, what you see is there are polyps plus derma problems, and derma includes skin, nail and hair. Skin shows pigmentation, nail shows atrophy and hair shows loss. That's it. And with that you are done with Hamartomatous polyp, and with that you are also done with non-neoplastic intestinal polyps. So let me mention all the Hamartomatous polyp in one place along with the genetic mutations for you. Hamartomatous polyps. So juvenile polyposis syndrome. Second is Peutz-Jeghers syndrome. Third is Cowden syndrome. Fourth is BRR syndrome. Fifth is tuberous sclerosis. And sixth is Crockett-Canada syndrome. As for mutations, juvenile rectal polyp is due to juvenile polyposis syndrome is due to SMAD2, SMAD4 and BMPR1A mutation. Peutz-Jeghers is due to it lost the number 11, so STK11. Cowden is due to N at the end, so P10. BRR is also due to P10. Tuberous sclerosis, take T from tuberous and SC from sclerosis, TSC1 and TSC2. And Crockett-Canada syndrome is not inherited. That means there are no mutations. All right, and I hope now you know about all of them. Inflammatory, due to inflammation, that is ulcerative colitis. Hyperplastic, there is hyperplasia of goblet cell and absorptive cell resulting in tufts at the surface and increment in crypts within. crypts, they are serrated only in the upper 1/3. Hamartomatous, juvenile polyposis syndrome, juvenile under the age of 5, polyposis, there are lots of polyp, 200 to 300 polyp within what? Rectum, Peutz-Jeghers syndrome, there is polyps plus pigmentation and present within the jejunum, J for Jeghers, J for jejunum. Cowden syndrome, N at the end, P10 mutation, BRR, P10 mutation, there are polyps plus mental retardation in BRR syndrome, tuberous sclerosis, TSC mutation, Crockett-Canada syndrome, it is not inherited. Here there are polyps plus derma problems. Derma includes skin, hair and nail, skin pigmentation, hair loss and nail atrophy. Done. Next, neoplastic, brother, neoplastic. Neoplastic intestinal polyp includes adenomas, intestinal adenomas, which are microscopically of 3 types. Tubular adenoma, because there are tubular glands within the polyp, lots of tubular glands within the polyp. Villus adenoma, because the polyp has lots of villi-like structure, villus adenoma. Tubulovillus adenoma, that's like a mutated version of both. So there are tubular glands, lots of tubular glands within the polyp, as well as lots of villi-like structure within the polyp. Out of all these 3 adenomas, the most dangerous one, or the most cancer converting risk carrying one, is villus adenoma. V for villus, V for very dangerous, it can turn into cancer. Tubular adenoma, it has tubular gland within the polyp. Villus adenoma, the polyp has lots of finger-like structures. And tubulovillus adenoma, it contains tubular gland plus finger-like structure. Sessile serrated adenoma. Sessile serrated adenoma is like copy-paste of hyperplastic polyp. Okay, in hyperplastic polyp there was increase in the number of crypts. In sessile serrated adenoma also there is increase in the number of crypts. In hyperplastic polyp there are serrated crypts. In sessile serrated adenoma also there are serrated crypt. But here are the differences. So there is hyperplastic polyp, sessile serrated adenoma. It is non-neoplastic. Hyperplastic is non-neoplastic, right? This is neoplastic. In case of hyperplastic polyp, the serrated crypts were present only in the upper 1/3. However, here it is present throughout the whole thickness. Plus, there are no boot-shaped crypt here. Here there are boot-shaped crypt. Again, so the serrated crypts are present throughout the full thickness. Second, if you look at the bottom, there are boot-shaped crypts. Then, familial adenomatous polyposis. There's posis at the end. That means there has to be multiple polyps, not just one. Familial adenomatous polyposis, or in short written as FAP. What I do is add a C at the end and remove F. FAPC, C at the end, remove F. I'll get APC. So familial adenomatous polyposis is due to APC gene mutation, which is present in which chromosome? Which letter did I take out? F for 5. So it is present in chromosome number 5. APC gene mutation present in chromosome number 5 leads to familial adenomatous polyposis. It's polyposis. It contains at least 100 polyps. At least there has to be 100 or more than 100. At least 100 polyps. And it has 100% risk of cancer. That is, if there is familial adenomatous polyposis, it will develop into adenocarcinoma. That is, if familial adenomatous polyposis is present in your stomach, it will eventually convert into gastric adenocarcinoma. If it is present in your colon, it will eventually result into colon adenocarcinoma, 100%. So the only way to prevent that from occurring, the only prophylaxis there is to cut and remove the colon with polyps. So there is normal colon and then there is colon with polyps, right? This much colon has lots of polyp. As a surgeon, what you need to do is incise and then take this portion out, throw it away. Get rid of that portion. Prophylactic colectomy, removing the colon with polyps. This doesn't mean it will stop the extraintestinal manifestation, but it will at least make sure that there will not be cancer. FAP will not, familial adenomatous polyp will not lead to colon cancer because the part of the colon with the polyps has been removed. Good. It is of three major types: classical, Torcott, and Gardner. They also more than 100 polyps, at least 100 polyps, but then all three of them have different extraintestinal manifestation. The difference lies in the extraintestinal manifestation. In classical familial adenomatous polyposis, the problem arises in the eye. There is congenital hypertrophy of RPE, that is retinal pigment epithelium. Due to increased pigmentation, eventually this leads to blindness. Torcott familial adenomatous polyposis. So your central nervous system is affected. Brain is involved here. CNS tumor occurs. Gardner familial adenomatous polyposis. So there is involvement of skin, tissue, bone, teeth. Skin, epidermal cyst. Tissue, fibroma. Bone, osteoma. Teeth, supernumerary teeth, increase in the number of teeth. And remember, all these three FAP, all types of FAP, all familial adenomatous polyposis, they are autosomal dominant disease. Autosomal dominant, that means APC gene mutation is carried out through generations, through which pattern? Autosomal dominant pattern. Okay, once again. So we have familial adenomatous polyposis. What I'll do is add a C in the front and remove F from the beginning. This will give me APC. So familial adenomatous polyposis occurs due to APC gene mutation, which is present in chromosome number 5, because I have gotten rid of which letter? F for 5. This leads to familial adenomatous polyposis, where there are more than or at least 100 polyps within the affected part of the colon. And these polyps, they carry 100% risk of cancer. 100% risk of cancer. And the only way to prevent the development of cancer is prophylactic colectomy. That is cutting and removing the part of the colon with familial adenomatous polyposis. Familial adenomatous polyposis, they are majorly three types: classical, Torcott, and Gardner. All three of them, they show hundreds of polyps in the colon. The difference lies in the extraintestinal manifestation. In classical, eye is involved. In Torcott, CNS, brain is involved. In Gardner, skin, bone, fibers, and even teeth, they get involved. Then you have MUTYH associated polyposis. Here is also polyposis. That means here is also more than one polyp, multiple polyps. But then there is clear difference between familial adenomatous polyposis and MUTYH associated polyposis. Let's look at the difference between the two, okay? So there is familial adenomatous polyposis and MAP, FAP and MAP. Difference between FAP and MAP. First difference, in familial adenomatous polyposis, there is at least 100, that means more than 100 polyps, 100 or more than 100 polyps. But in MAP, there are less than 100 polyps. In familial adenomatous polyposis, it is due to APC gene mutation. Here it is due to MUTYH gene mutation. Familial adenomatous polyposis is autosomal dominant. MAP is autosomal recessive. And that's it. And with that, you are done with intestinal polyp. All you had to know was the name of the polyp, and that was more than enough to answer all your queries. See, under adenomas, you have tubular adenoma. So it is adenoma with tubular glands within. Villus adenoma, adenoma with finger-like projection. tubulovillous adenoma, adenoma with tubular gland plus finger-like projection. Out of these three, V for villous, V for very bad, so it carries the highest risk of turning into cancer. Then there was sessile serrated adenoma, which is the same as hyperplastic polyp. Here is also hyperplasia, increase in number of crypts, serrated crypts, but then the serrated crypts, unlike hyperplastic polyp, where they were present only in the upper 1/3, it is present throughout the full thickness, plus below are also present boot-shaped crypts. Then familial adenomatous polyposis, insert that's FAP, add a C at the end, remove F, it is due to APC gene mutation present within chromosome number 5, and there are at least 100 polyps within the part of the colon which has familial adenomatous polyposis, which carries 100% risk of developing into cancer, and this is autosomal dominant. However, MUTYH associated polyposis, where there are less than 100 polyp, again polyposis means there are multiple polyps. Okay, this is due to MUTYH mutation, and this is autosomal recessive. By now, we have already studied all the intestinal polyps. That means, yes, we are also done with familial adenomatous polyposis. Now we are entering into cancer. And first, we are going to study about hereditary non-polyposis colorectal cancer. And the best way to do that would be by comparing HNPCC or hereditary non-polyposis colorectal cancer with familial adenomatous polyposis. So buckle up, because after this session, there will be absolutely no confusion for you in distinguishing the features of both of them. Both of them will be crystal clear, the concept will be all cleared up. Alright, so let's begin. First, familial adenomatous polyposis, or simply FAP. Hereditary non-polyposis colorectal cancer, or HNPCC. Familial adenomatous polyposis, there is polyposis, that means there is presence of multiple polyps within colon and rectum. And in fact, there has to be at least 100 polyps. At least 100 polyps. There can be up to 1,000, but there are at least 100 polyps. Hereditary non-polyposis colorectal cancer, non-polyposis, obviously there are no polyps at all. FAP, or familial adenomatous polyposis, with at least 100 polyps has 100% risk of cancer. 100% risk of cancer. That is, if there is FAP or familial adenomatous polyposis within a certain part of the colon, it is eventually going to develop into colon adenocarcinoma. So 100% risk of cancer. Hereditary non-polyposis colorectal cancer is itself a cancer. It's a cancer. We are talking about a cancer here. Cancer. Now, another thing is, both familial adenomatous polyposis and hereditary non-polyposis colorectal cancer are inherited and accompanied by mutation. There is a genetic mutation causing both. FAP is also caused by genetic mutation. HNPCC is also caused by genetic mutation. The question is, which genetic mutation? So, familial adenomatous polyposis is due to mutation of tumor suppressor gene. So, there is mutation of tumor suppressor gene. Question is, which gene? Which tumor suppressor gene? And I have already taught you a method of remembering it. You have familial adenomatous polyposis, add a C at the end, get rid of F. So what do you get? You get APC. So it is the APC gene, which is present in which chromosome? Which letter did we remove? F. F for 5. So APC gene is present in chromosome number 5. This mutation leads to no suppression of tumor. See, whatever was responsible for the suppression of tumor has been mutated. APC gene is mutated, so the tumor does not get suppressed and it eventually develops into cancer. Simple as that. What about HNPCC? So this takes place due to genetic mutation of which gene? Of repair gene, or more specifically DNA mismatch repair gene. The mismatched repair gene is also written in short as MMR gene. So there is MMR gene mutation, mismatch repair gene mutation. Now there are multiple mismatch repair gene. Mismatch repair gene, it is a collection of multiple genes. Okay, so most commonly the mismatch repair genes that get mutated are MLH1 and MSH2. Both of them are DNA mismatch repair gene, MMR gene. The way to remember, L looks like 1, S looks like 2. So MLH1 and MSH2. Due to mutation in DNA mismatch gene, what happens? There is MSI or microsatellite instability. Microsatellite instability. So MMR gene mutation leads to MSI, and this leads to cancer. All right. Both FAP and HNPCC are associated with certain syndrome. FAP is commonly associated with two very common syndromes. First is the Torcott syndrome. Since it's a syndrome, there is obviously familial adenomatous polyposis. So there are lots of polyps within colon and rectum, plus an extraintestinal manifestation. Here, the extraintestinal manifestation is in the brain. How do I know that? You can remember that from the name itself. The name contains tur. So the Torcott contains tur, and tur is for turban. Turban is something worn by sick on their head. So within head is brain. So there is some pathology of the brain, that is brain tumor. So FAP along with brain tumor, Torcott syndrome. Second, Gardner syndrome. Again, there is familial adenomatous polyposis, plus in garden there is soil. Soil is arranged in multiple layers. Similarly, your body also has multiple layers. So there is pathology of these multiple layers of your body. Like skin, under skin there are fibers, under fiber there is your bone, and then there's your teeth. So there's pathology of each of them. Skin, there is epidermal cyst. Under it there's fiber, so fibroma. Under it there's bone, so osteoma. Then there are your teeth, so there's supernumerary teeth. HNPCC is also referred to as Lynch syndrome because it is very commonly associated with Lynch syndrome. The best way to remember Lynch syndrome is via the mnemonic CEO has gone for lunch, where lunch refers to Lynch syndrome and CEO refers to the presence of C4 colon cancer. I mean, obviously, because there is HNPCC, there is colon cancer. Lynch syndrome is something that has HNPCC, colon cancer. E4, endometrial cancer. And O4, ovarian cancer. Ovarian cancer. Colon cancer is more specifically on which side? It is on the right side. And this is significant for you to remember. The reason being, depending on whether the colonic carcinoma, adenocarcinoma, is present in the left colon or right colon, the gross morphology are of completely two different variety. So, and that I will be describing under the topic of colon adenocarcinoma itself. So for now, remember, HNPCC is most commonly seen in which colon? Right or left colon? The right colon. Okay. Both FAP, that is familial adenomatous polyposis, and HNPCC or hereditary non-polyposis colorectal cancer are autosomal dominant diseases. What? Autosomal dominant diseases. By now, we have learned about intestinal polyps. Now we are going to learn about intestinal cancer. More specifically, the colon cancer. The most common colon cancer is colon adenocarcinoma. And the fact is that it is in fact the most common gastrointestinal tract cancer. See, throughout gastrointestinal tract, we talked about the cancers of esophagus, the cancers of stomach, and now we are learning about the cancer of intestine. Throughout the gastrointestinal tract, the most common cancer is colon adenocarcinoma. So we have to learn about colon adenocarcinoma in detail. But before getting into colon adenocarcinoma, a small revision of something that I have already taught you previously, and that is HNPCC, hereditary non-polyposis colorectal cancer. Again, hereditary non-polyposis colorectal cancer. Hereditary, that means there is certain genetic mutation leading to the formation of HNPCC, and that genetic mutation is what? Which gene gets mutated? The DNA repair gene gets mutated. It's the repair gene that gets mutated leading to cancer. Which repair gene? More specific, the DNA mismatch repair gene gets mutated. Again, DNA mismatch repair gene or MMR gene. Mismatch repair gene gets mutated. There are many mismatch repair genes. Ones that get more frequently mutated in HNPCC are MLH1 and MSH2. Both MLH1 and MSH2 genes are DNA mismatch repair genes. They get mutated. How can you remember? L looks like 1 and S looks like 2. So DNA mismatch repair gene mutation leads to microsatellite instability, and microsatellite instability is seen in HNPCC. It's hereditary, and the inheritance pattern it follows is autosomal dominant. Remember, I have taught you that HNPCC and FAP or familial adenomatous polyposis are autosomal dominant, but MUTYH associated polyposis is autosomal recessive. Remember this. HNPCC and FAP is autosomal dominant. MAP, MUTYH associated polyposis is autosomal recessive. Non-polyposis. See, normally during the formation or development of colon cancer, what happens? This is your normal colon. In this normal colon, there is development of polyps. And these polyps, they either increase the risk of cancer or they themselves convert into cancer. Okay, normal colon, polyps in colon. Now these polyps, they increase the risk of cancer or they themselves convert into cancer, right? However, in HNPCC, non-polyposis, that means there are no polyps present. No polyps. Colorectal cancer, yeah, it is the cancer of your colon and rectum, which is associated with a syndrome called Lynch syndrome. What is syndrome? It is a collection of disorders. The disorders that are found is obviously the colorectal cancer plus some other disorders. And the way to remember that is CEO has gone for lunch, where lunch is referring to Lynch syndrome, and CEO for C for colon cancer, obviously because it is colorectal cancer, E for endometrial cancer, and O for ovarian cancer. Remember, the colon cancer that is seen is in the right colon. Which colon? Right colon. And it is significant for you to remember this cause colon cancer are of two types, right colon cancer and left colon cancer. And there is a characteristic difference in the gross morphology of right colon cancer and left colon cancer, which I'll be describing soon enough within this lecture. With that, we are done with HNPCC. One last time. Hereditary non-polyposis colorectal cancer. Hereditary, there is genetic mutation, which DNA mismatch repair gene or MMR gene. Which MMR gene? MSH2, S looks like 2, MLH1, L looks like 1, which leads to microsatellite instability. The inheritance pattern is autosomal dominant. What else? FAP also has autosomal dominant. What has the recessive? MUTYH associated polyposis is a recessive. Non-polyposis, that means that there is absolutely no polyps. Colorectal cancer, which is associated with which syndrome? Lynch syndrome. How can you remember Lynch syndrome? CEO has gone for lunch for Lynch syndrome, CEO for colon cancer, endometrial cancer, and ovarian cancer. The colon cancer seen is on the right or left side? The right colon. Etiopathogenesis. So now we are learning about colon adenocarcinoma. Starting off with the causative factors, the etiology of colon adenocarcinoma. See, there are lots of etiology like fatty food, alcohol, smoking, infection. However, there is another pathway as well, and that is through polyps. Polyps also lead to the formation of colon cancer. And fortunately, hopefully, you have already learned about intestinal polyps, because I have already taught all of them. And under the lecture of intestinal polyps, I said that even if you just remember the name of the polyp, that will be more than enough for you to describe every fact that you need to memorize under that polyp. So I hope you know about all the intestinal polyps. Intestinal polyps, they are of two types, non-neoplastic and neoplastic. Neoplastic intestinal polyp, they can convert into cancer. Non-neoplastic intestinal polyp, they do not convert into cancer. Do you understand what I am saying? Neoplastic intestinal polyp can convert into colon adenocarcinoma. Non-neoplastic intestinal polyp does not convert into colon adenocarcinoma. But remember, few of the non-neoplastic intestinal polyp, they can increase the risk of colon adenocarcinoma. There is difference. Listen, hear me out. There is a difference between the two lines that I am saying. Neoplastic intestinal polyp, this is your colon. This colon has polyp, right? This colon develops polyp. These polyps are neoplastic polyps. Now they themselves can convert into cancer. These polyps, they themselves can convert into cancer. These polyps, they turn into cancer. On the other hand, here is normal colon. This normal colon develops non-neoplastic intestinal polyp. They do not convert into cancer. They do not become cancer because they are non-neoplastic. But some of them, they can increase the risk of occurrence of cancer. Neoplastic intestinal polyp, they turn into cancer. Non-neoplastic intestinal polyp, they do not turn into cancer, but wherever they are, there they will increase the risk of cancer. Okay, that means under etiopathogenesis via polyps, you need to know two pathways. One pathway is where neoplastic polyp convert into cancer, and another pathway is where non-neoplastic polyp, they simply increase the risk of occurrence of cancer. So there are your intestinal polyps. There are how many types? Two types. What are they? Non-neoplastic intestinal polyps and neoplastic intestinal polyps. Neoplastic intestinal polyps have the tendency to convert into colon adenocarcinoma. On the other hand, non-neoplastic intestinal polyps, they do not convert into colon adenocarcinoma, but few of them, they increase the risk of colon adenocarcinoma. The question is, which non-neoplastic intestinal polyps increase the risk of occurrence of colon adenocarcinoma? They are the inflammatory polyp, juvenile polyposis syndrome, and Peutz-Jeghers syndrome. Under neoplastic, all of them, they have the tendency to convert into cancer, but we are going to separate them into adenomas. Under adenoma, you have tubular adenoma, villous adenoma, and tubulovillous adenoma. Then there's sessile serrated adenoma, familial adenomatous polyposis, and MUTYH associated polyposis. Remember, V for villous adenoma, V for very bad. It is the villous adenoma that has the highest tendency to convert into colon adenocarcinoma among tubular, villous, and tubulovillous. Villous, V for villous, V for very bad, has the highest tendency to convert into cancer. So first, let's look at this pathway. In that pathway, what is there? There is your colon. This colon is normal. Now, in this colon due to mutation, what happens? Or mutation or other reasons. Mutation or other reasons, what happens? There is development of polyps. What types of polyps are they? Neoplastic or non-neoplastic? Non-neoplastic polyps. Do they convert into cancer? No, they don't. What they do? They increase the risk of cancer. Okay, cancer, simple. So what are the non-neoplastic polyps that increase the risk of cancer? Inflammatory polyp, juvenile polyposis syndrome, Peutz-Jeghers syndrome, inflammatory polyp, juvenile polyposis syndrome, Peutz-Jeghers syndrome. You know, inflammatory polyp is as a result of inflammation, and the inflammation of colon is ulcerative colitis. You know, juvenile polyposis syndrome is seen in juvenile, that is children under the age of 5. So it loves small numbers. So the mutation of small number takes place, like SMAD2, SMAD4, and BMPR1A. You know that Peutz-Jeghers syndrome loves the number 11. So it is seen in children of 11 years, and the mutation of STK11 takes place. These polyps, once they occur in the colon, they increase the risk of colon cancer or colon adenocarcinoma. Simple. Okay, so one pathway done. Now let's look at the other pathway. In other pathway, multi-step carcinogenesis takes place. What do I mean? See, there is your normal colon. In this normal colon, mutation number 1 takes place. As a result, there is formation of polyps. These are neoplastic polyps. These are neoplastic polyps. Now, in these neoplastic polyps, second mutation takes place, and then it converts into colon adenocarcinoma. So, is mutation taking place in multiple steps or not? Yes, it is taking place. So it is a multi-step carcinogenesis. Is it occurring from neoplastic polyp or not? So it is multi-step carcinogenesis of neoplastic polyp. So multi-step carcinogenesis of neoplastic polyp leads to the formation of colon adenocarcinoma. The same thing is written here. First, it's normal. Then mutation number 1 takes place. Then there is formation of neoplastic polyp. Then mutation number 2 takes place, and then there is cancer, colon adenocarcinoma. Now I have divided neoplastic polyps into 2 pathways. One via adenoma and second via sessile serrated adenoma. Within adenoma, I told you that V for villous, V for very bad, it has the highest tendency. So first there is formation of tubular adenoma and then villous adenoma, and this villous adenoma becomes cancer. However, in sessile serrated adenoma, there is simply formation of sessile serrated adenoma, and then that becomes cancer. Let's see how. Again, so there is normal, there is mutation number 1, formation of tubular adenoma, mutation number 2, then villous adenoma, mutation number 3, and finally adenocarcinoma. So is there multi-step carcinogenesis of neoplastic polyp? Yes, there is, because mutation is taking place in multiple steps. First it was normal, then mutation converted the normal colon into colon with neoplastic polyp. Then the other mutation converted the colon with neoplastic polyp to colon with adenocarcinoma. What you have to do is remember the name of the polyp and the name of the mutation associated with the polyp. Tubular adenoma via APC mutation, villous adenoma via KRAS mutation, and finally adenocarcinoma via P53, SMAD2 and SMAD4 mutation. Remember, normal APC mutation leads to tubular adenoma, then KRAS mutation leads to villous adenoma, then P53, SMAD2, SMAD4 mutation leads to adenocarcinoma. Another, normal mutation 1 takes place, then sessile serrated adenoma, mutation 2 takes place, adenocarcinoma. Mutation 1 is mutation of MMR gene. What is MMR gene? Again, bro, mismatch repair, the DNA mismatch repair gene. Most commonly MLH1 and MSH2. L looks like 1, S looks like 2. MMR gene mutation leads to microsatellite instability. Second mutation is BRAF mutation. So there's normal, MMR gene mutation leading to MSI, sessile serrated adenoma, BRAF mutation, and adenocarcinoma. Okay, this is the diagram from Robbins. There is your normal colon, first mutation, APC mutation, leading to tubular adenoma. Second mutation, which is KRAS mutation, leading to villus adenoma. Third mutation, which is P53 mutation, SMAD2 mutation, SMAD4 mutation, leading to adenocarcinoma. Again, normal colon, first mutation, leading to sessile serrated adenoma, which is MMR gene mutation, which causes MSI or microsatellite instability. Then sessile serrated adenoma, second mutation, leading to adenocarcinoma. The second mutation is BRAF mutation. So remember these two pathways. Then there is again multi-step carcinogenesis, but by other pathways where the formation of polyp is not concerned. Okay, here what happens is that yes, there is your normal colon, there is mutation 1, but after mutation 1 there is not formation of neoplastic polyp, simply there is risk. Then there is mutation 2, and then finally there is colon adenocarcinoma. Mutation 1, mutation 2, multi-step carcinogenesis. Here there is no polyp, simply the mutation 1 puts the colon at risk, and finally via mutation 2 there is colon adenocarcinoma. Let's see. So there is normal colon, mutation 1 puts the colon at risk, mutation 2 leading to colon adenocarcinoma. All you have to remember is what is mutation 1 and mutation 2. So there are two pathways, SIMP BRAF pathway and SIMP KRAS pathway. Simple. SIMP BRAF pathway, first you have SIMP, second you have BRAF. Simple. In SIMP KRAS pathway, again simple. First you have SIMP and second you have KRAS. But then there is difference in SIMP. See, in SIMP BRAF pathway also there is SIMP. In SIMP KRAS pathway also there is SIMP. But the SIMP here and the SIMP here are different. But first things first, what the hell is SIMP? See, SIMP BRAF pathway. In SIMP BRAF pathway, SIMP is leading to MSI or microsatellite instability. Wait, till now I have been telling you that it's the MMR gene mutation, that is MSH1, MSH2, MLH1 gene mutation that leads to microsatellite instability. Then what is the difference in microsatellite instability from MMR gene mutation and microsatellite instability from SIMP? This is the difference. See, there is your MMR gene. Okay, this MMR gene leads to microsatellite instability via two ways. Number one, through mutation. When MMR gene get mutated, it leads to microsatellite instability. Second is without mutation. Without mutation how? By the addition of CH3 group. What is CH3 group? Methyl group, which is called hypermethylation. The process is called hypermethylation. Again, there are two ways. First, you have MSH2 and MLH1 gene. What are they? They are MMR genes. They get mutated. Mutation takes place and they lead to microsatellite instability. This is via mutation. In second way is that there is MLH1 gene. What is it? It is still the MMR gene, bro. It is mismatch repair gene. Here mutation does not take place. Instead, CH3 group gets added. Hypermethylation takes place. Hypermethylation takes place, leading to microsatellite instability. And this hypermethylation is seen in SIMP. That's why the full form of SIMP. What is it? It is CpG island hypermethylation phenotype. So it's such a phenotype where hypermethylation is seen. So instead of mutation of MMR gene, hypermethylation of MMR gene takes place. It's such a phenotype where hypermethylation is seen. CpG island hypermethylation phenotype. I hope you understand. One last revision. Fine. So there is your DNA mismatch repair gene. It leads to microsatellite instability, either by number one, mutation, or number two, without mutation simply by the addition of methyl group, which is seen in hypermethylation. And hypermethylation is seen in what phenotype? It is seen in SIMP phenotype or CpG island hypermethylation phenotype. Good. Now the difference in SIMP of SIMP-BRAF pathway and SIMP of SIMP-KRAS pathway is that in SIMP-BRAF pathway, SIMP leads to MSI via hypermethylation of MMR. But in SIMP-KRAS pathway, SIMP does not lead to MSI because there is no hypermethylation of MMR genes. Okay. All right, let me revise everything for you. What's there? See, so there's your normal colon. This is complete etiopathogenesis via polyps through one single flowchart. So there's your normal colon. Now in this normal colon, what happens? There is mutation leading to formation of non-neoplastic polyps, and they simply increase the risk of colon adenocarcinoma. They don't themselves convert into adenocarcinoma. They increase the risk of adenocarcinoma. The question is, which non-neoplastic polyps? The inflammatory polyp, juvenile polyposis syndrome, and Peutz-Jeghers syndrome. Inflammatory polyp is as a result of ulcerative colitis. Juvenile polyposis syndrome is as a result of SMAD2 mutation, SMAD4 mutation, and BMPR1A mutation. And Peutz-Jeghers syndrome is as a result of STK11 mutation. So this is via non-neoplastic polyp, increasing the risk of colon adenocarcinoma. All right. Next is via neoplastic polyp. Once there is neoplastic polyp, it itself gets converted into colon adenocarcinoma. First is through the adenoma pathway. Okay, the first one is the adenoma pathway. The second is sessile serrated adenoma pathway. First, adenoma pathway. So there is tubular adenoma followed by villous adenoma. V for villous, V for very bad. It has the highest potential to convert into colon adenocarcinoma. The second pathway is via sessile serrated adenoma. Sessile serrated adenoma, which eventually converts into colon adenocarcinoma as well. All you have to do is remember the mutations, brother. Remember the mutations. In sessile serrated pathway, there was MMR gene mutation leading to MSI. And second, there was BRAF mutation. In tubular adenoma, first, which mutation took place? APC mutation. Second, KRAS mutation. Third, P53 mutation. SMAD2 mutation. SMAD4 mutation. Then there's other pathway. In other pathway, normal colon, which comes at risk, and then there is colon adenocarcinoma. Mutation number 1. Depending on which pathway are we talking about. First, the SIMP-BRAF pathway. So we have the SIMP-BRAF. The second, the SIMP-KRAS pathway. Again, SIMP-KRAS. The difference between two is that here SIMP leads to MSI. Wait, let me write it properly. Here SIMP leads to MSI. Here SIMP does not lead to MSI. That's it, everything in a single flowchart. At the very beginning of the lecture, I was continuously emphasizing on the fact that colon cancer, depending on it is on the right colon or left colon, has a distinguishing characteristic gross feature. For example, I said that HNPCC, hereditary non-polyposis colorectal cancer, is a right colon cancer. That means it has the characteristic features of a right colon cancer. So gross morphology, You have right colon cancer and left colon cancer. Let's look at the difference between the two. First, the right colon cancer. The right colon cancer, the right colon tumor, it is large. It is large. It is fungating. It is polyploid. See, the right colon cancer. It is large. It is fungating. It is polyploid. What does it look like? It looks like a cauliflower. So grossly, it looks like a cauliflower. On the left hand side, on the left colon, the tumor, it is within the wall, and it is annular. It is along the wall of the left colon. So it is annular. The annular growth of the lumen leads to constriction of the lumen. Again, the annular growth of the lumen leads to constriction of the lumen, resulting in stricture. And this looks like what? This looks like the napkin ring. See, this is the napkin which is constricted right in the middle due to napkin ring. Similarly, this is the left colon which is constricted right in the middle due to the annular tumor. See, this is the left colon as well. Here you have the tumor which is restricted to the wall. This is the left colon. There is constriction in the middle due to the annular growth of the tumor. So there is annular growth of the tumor. This is the difference in the gross morphology. But why is it that the right colon cancer is large, fungating, polyploid, cauliflower-like, but the left colon cancer is restricted to the wall, annular, constricting, stricture-forming, napkin ring-like? Why? Here's the reason why. Anatomically, the right colon, it is larger, wider, and has a wider lumen. The left colon, on the other hand, it is narrower and it has a narrower lumen. Second thing, the formation of feces or stool starts here and then it follows the arrow like this. And then finally it comes out of the rectum. The beginning is here and the end is here and then it comes out here. At the beginning, has the stool yet formed? No, the process has just begun. So what is inside the colon? Liquid is inside the colon. But by the time it reaches the left colon, the formation of stool has taken place. So there is stool in the left colon. There is solid in the left colon. Now imagine, here's the right colon with a tumor that is trying to grow. Can this tumor grow and become big? Yes, it can, because there is enough space due to large lumen. Plus there is liquid, so there is no solid restricting the growth of the tumor. However, in left colon, can the tumor grow into the lumen? No, it can't, because number one, the lumen is too narrow, and number two, there is solid. The solid stool is going to restrict the growth of the tumor within the lumen. So the tumor is confined only within the wall, so the annular growth. Why? Because the tumor is confined within the wall. It does not grow into the lumen because there is solid inside. It is filled. The thing is filled. The lumen is filled. So the tumor can't grow inside. The solid is pushing against the wall. There is no space for the tumor to grow. So the tumor is confined only till the wall. What happens eventually? The tumor grows and grows and grows, and the lumen constricts and it becomes narrower. Okay. So right-sided colon cancer, left-sided colon cancer. Right-sided tumor is polyploid, fungating, large mass. Left side you have annular. Right-sided looks like a cauliflower. Left-sided looks like a napkin ring. The reason behind right-sided colon cancer becoming polyploid, fungating, large mass, looking like a cauliflower is because of the presence of liquid content plus a wider lumen. The reason behind left-sided cancer becoming annular and napkin ring-like is due to narrower lumen and the presence of solid content inside. Right-sided colon cancer leads to iron deficiency anemia due to bleeding. Left-sided colon cancer leads to blockage because there is constriction, stricture formation, and occult bleeding. What is occult bleeding? Occult means hidden. That means if you examine the stool, the blood is not visible with our naked eye, but under microscopy there is blood in stool. Microscopy. So colon adenocarcinoma microscopy, you have well differentiated colon adenocarcinoma and poorly differentiated colon adenocarcinoma. First things first, what is it? It is adenocarcinoma. So what are you gonna see? You're gonna see glands. You're gonna see glands. Now, if it is well differentiated, then the gland is gonna look closer to, similar to normal gland. If it is poorly differentiated, the gland is gonna look nothing like the normal gland. Simple. Colon adenocarcinoma. Adeno, there is gonna be glandular structure. There is gonna be glandular structure. If it is well differentiated, that means the glandular structure are going to look similar to that of normal glands. If it is poorly differentiated, that means the glandular structure are going to look nothing like the normal glands. First, well differentiated. These are your glands. These are the glandular structures. These are the glandular structures seen in colon adenocarcinoma. Do these glandular structures have hyperchromatic elongated nucleus? Yes, they do. They have hyperchromatic elongated nucleus within the glandular cells. Second, within the lumen, there is presence of necrotic debris. This is well differentiated. Poorly differentiated, there are few glands here and there, but majority, it is filled with tumor cells. It is infiltrated by tumor cells. Now, within poorly differentiated, there is a special type of colon adenocarcinoma called mucinous colon adenocarcinoma. The name says everything. Come on. There is mucinous colon adenocarcinoma. That means the thing is filled with mucin. The lumen is filled with mucin. Plus, the individual neoplastic cells are also filled with mucin. Look at the neoplastic cell. It is filled with mucin. As a result, what has happened? The nucleus and cytoplasm is pushed to the periphery. As a result, what does it look like? It looks like a ring. What do we call such cells? We call it signet ring cell. See, this is what you need to draw in exam. It is colon adenocarcinoma. Adeno, that means you are going to see glands. What are you going to see? You're going to see glands. Now, it is well differentiated. If it is well differentiated, that means the glands, they are similar to that of normal glands. They are made up of neoplastic cells, but they look similar to that of normal glands. They are made up of neoplastic cells, the tumor cells, the cancer cells, but then they look like the normal glands because they have hyperchromatic nucleus. Hyperchromatic nucleus. What is present within the gland? Within the gland, there is presence of necrotic debris. Necrotic debris. Second, it is poorly differentiated. Poorly differentiated. If it is poorly differentiated, there are rarely any gland. Most of it is just filled with tumor cells. So just draw lots of tumor cells. So there is tumor cell infiltration. Tumor cell infiltration. Within poorly differentiated, you have the special type called mucinous colon adenocarcinoma. Here, the gland, it is filled with mucin. Not just the gland, but then the tumor cells, right? Tumor cells, they are also filled with mucin. As a result, the nucleus and the cytoplasm is pushed to the periphery, giving signet ring cell. Signet ring cell. That's it. Diagnosis. The gold standard diagnosis is obviously biopsy. But previously I said that in case of colon adenocarcinoma, blood is present in the stool, but then this blood is not visible with the naked eye. Instead, we need to look it under the microscope. That is called occult blood. So you can search for occult blood in stool, and that is done with the help of Guayuk test. So remember, gold standard is biopsy. Search for occult blood in stool via Guayuk test. Third, tumor marker. It is CEA or carcinoembryonic antigen. And fourth, barium enema. What is barium enema? X-ray gonna show. Look right here. Under colon cancer, I said that whenever there is annular growth in the colon cancer, okay, that is the cancer is restricted within the wall of the colon, resulting in annular growth, what happens? It constricts the lumen, leading to formation of narrow lumen, which in pathology is referred to as stricture. So this stricture is visible in barium enema X-ray. Simple. See, there is normal colon, and all of a sudden stricture due to annular growth, thickening wall, constricting the lumen. So there is stricture right here, and these are the broad shoulders leading to normal colon. Again, stricture right here, broad shoulder leading to normal colon. What does it look like? It looks like an eaten apple. So this is called apple core deformity. It looks like the core of an apple. See, there is the stricture with broad shoulder, stricture with broad shoulder, apple core deformity. Neuroendocrine tumors. Neuroendocrine tumors are the tumor of your neuroendocrine cells. Neuroendocrine cells, they are a part of diffuse endocrine system. What is diffuse endocrine system? See, within your body, you have the endocrine system, which is made up of endocrine glands like pituitary gland, hypothalamus, adrenal gland. But along with these endocrine glands, forming the endocrine system are various cells scattered all over the body that also produce hormone, just like the endocrine glands. Okay, endocrine glands are there in your body. These endocrine glands, they produce hormone and they make up the endocrine system. Just like the endocrine glands, there are endocrine cells scattered throughout your body, present diffusely throughout your body, that form the diffuse endocrine system. Now these endocrine cells, they are either present singly, isolated at a place, or they are present in a group. For example, within your stomach, you have the gastrin producing G cells. You have the serotonin producing argentaffin cells. Similarly, there are cholecystokinin producing cells. Throughout your gastrointestinal tract, multiple local hormones are produced. And these local hormones are produced by the endocrine cells. Similarly, within your pancreas as well, there are islands of endocrine cells referred to as islet of Langerhans. They are also diffusely present. They also make a part of the diffuse endocrine system. So, diffuse endocrine system contains endocrine cells either isolated or present in group that produce hormone, present scattered throughout the body, diffusely arranged in the body, present in various systems of the body, not just GIT. It is present in respiratory system as well, in other organs as well. These cells are referred to as the neuroendocrine cell. And the tumor of these neuroendocrine cell is the neuroendocrine tumor. Simple as that. I know I'm taking a lot of time to explain what neuroendocrine tumor is, but hear me out. This neuroendocrine tumor is seen in almost all the organs of your body. So throughout pathology, throughout the systemic pathology, under each system, I repeat, under each system, you are going to learn about various neuroendocrine tumor. And if you just know one single neuroendocrine tumor properly with concept, that concept is going to repeat in every neuroendocrine tumor. So hear this lecture very properly, because the concept and the ideas used here will be repeatedly appearing on and on in every systems. So neuroendocrine tumors, they are either well differentiated or poorly differentiated. For example, carcinoid, they are well differentiated neuroendocrine tumor. One last revision. So neuroendocrine tumors are the tumor of your neuroendocrine cells. Neuroendocrine cells, they form a part of your diffuse endocrine system. Diffuse endocrine system, it's a system of cells present either isolated or in groups, present scattered throughout the body, diffusely present throughout the body, that produce hormone. The tumor of these cells, neuroendocrine cells, neuroendocrine tumor, they are either well differentiated or poorly differentiated. Now we are going to learn about a well differentiated neuroendocrine tumor, and that is carcinoid. Carcinoid tumor. It is a well differentiated neuroendocrine tumor. It's a neuroendocrine tumor. That means it is arising from neuroendocrine cell. The question is, which neuroendocrine cell? There are many neuroendocrine cells throughout your body. G cell, argentaphene cell. It is due to the tumor of argentaphil cell. Which argentaphene cell? Argentaphene cell is also referred to as enterochromaphene cell or Kulczycki cell. Since it is a tumor of argentaphene cell, it is also referred to as argentaphenoma. Argentaphene cell is a part of apod cell system. So the tumor is also referred to as apodoma. Simple. Carcinoid tumor is a well-differentiated neuroendocrine tumor. Since the neuroendocrine tumor is that of neuroendocrine cell, which neuroendocrine cell? Argentaphene cell. It is also called argentaphenoma. Argentaphene cell is a part of apod cell system, so also called apodoma. Done. Now, site. Where are carcinoid tumors seen? It is most commonly seen throughout the gastrointestinal tract and then the respiratory system. Within gastrointestinal tract, you have three major parts: the foregut, the midgut, and the hindgut. The highest prevalence, the highest occurrence is in the midgut, in the intestine like ileum and appendix. In a respiratory system, it is seen in the trachea or bronchi or the lung. However, the highest frequency of occurrence is within the midgut, where the midgut of the gastrointestinal tract. So this is the introduction to carcinoid tumor. One last time. Carcinoid tumor is well-differentiated neuroendocrine tumor arising from neuroendocrine cell, which argentaphene cell, also called enterochromaphene cell or Kulczycki cell. Since it arises from argentaphene cell, it is also called argentaphenoma. Argentaphene cell is a part of apod system. So the tumor is also called apodoma. Where is it most commonly found? In gastrointestinal tract. Where in gastrointestinal tract is it most commonly appearing? In midgut. And then respiratory system like trachea, bronchi, and lungs. Okay, grossly, carcinoid tumor is yellow to tan and form in consistency. It is yellow or a tan due to lipofuscin and form due to desmoplasia. Since there is desmoplasia, obviously in microscopy you are going to look at desmoplasia. See, throughout all neuroendocrine tumors, the diagnostic features are gonna be similar. That is, microscopy is gonna be same. Immunohistochemistry is going to be same. Electron microscopy is going to be same. So listen to the diagnosis very carefully because it will be repeating again and again and again. So first, the microscopy of carcinoid tumor. What is there? There is desmoplasia, lots of fibers. And in between these fibers, what are there? There are nests of cell. In individual nest, what are there? There are these tumor cells. And these tumor cells, they are surrounded by a single layer of special tumor cell. The tumor cell is special, this single layer, due to their arrangement because they are palisading. Palisading means one stacked over the other. So if you look at a single nest, this is what it looks like. The tumor cells at the periphery forming the boundary of the nest is stacked over one another, and this is referred to as palisading tumor cells. The palisading tumor cells, they are stacked one over the other. Okay, the palisading peripheral cell. Within it are the rest of the tumor cells. So what do you have? You have desmoplasia. In between these desmoplastic fibers, you have the nests of cell. An individual nest of cell is surrounded by palisading peripheral cell. Inside, if you zoom inside, right? If you zoom in, what do you get to see? You get to see these cells, right? Tumor cells. The special feature of these tumor cells are that, number one, they are small and uniform. Number two, can you appreciate the boundary of the cell? No, you can't, because it has poorly differentiated cell boundary. That's why. Second, it has less cytoplasm with a larger nucleus. So the nucleus are large, but the cytoplasm is scanty. Second, if you zoom into one nucleus, see, if you look at this nucleus right here, what do you see? Wait a second, all right. This nucleus right here. It is not solid. The nucleus does not appear solid. Instead, there are these dark dots present with white patches in between. Dark dots all over with white patches in between, giving salt and pepper arrangement. Because pepper is black, salt is white, the same is seen. It seems as if there's a plate with salt and pepper all over it. Salt and pepper arrangement. So in exam, in microscopy, what are you going to draw? This is what you are going to draw. So there are these desmoplastic fibers. In between are the nests of cell. The individual nest of cell has a palisading peripheral cell layer, and inside are the tumor cell. Is the boundary of the tumor cell seen? No, only the nucleus of the tumor cell is seen, and the nucleus was salt and pepper arrangement. That's it. Immunohistochemistry. Remember these 6 that is common for all neuroendocrine tumor. Synaptophysin, chromogranin, bombesin, and NSE, CD56 and CD57. Electron microscopy. Within the cytoplasm of the tumor cell, there are these granules, which are the neurosecretory granules. Tumor marker. See, it is the tumor of the argentaphin cell. Argentaphin cell is responsible for the production of serotonin. The metabolite of serotonin is 5-HIAA. So what is going to be seen, which level is what is going to be seen region in the blood serum? 5-HIAA. So obviously the tumor marker is 5-HIAA. The metabolite of serotonin, 5-HIAA, is the tumor marker of carcinoid tumor. Salivary gland tumors, really easy. My approach is going to be to show you 3 different pictures for various tumors. And in exam, every time you get to write on any one of these tumors, just remember those 3 pictures and then interpret the theory. But as always, drawing the diagrams itself on that sheet of paper is gonna be best. So remember the picture and then draw that diagram in the exam. With that being said, salivary gland tumor, like any other tumors, is of 2 types, benign and malignant. Benign tumors, they are well circumscribed. Malignant tumor, they are not well circumscribed. Under benign salivary gland tumor, we are going to learn about 2 tumors in detail and then compare both of them so that you can remember it to write in exam. They are pleomorphic adenoma. Again, pleomorphic adenoma, also called mixed tumor. It's in the name itself. It is called mixed tumor because it is pleomorphic, multiple morphology. Within tumor, there are various components, multiple morphology. And Warthin tumor. Malignant salivary gland tumor, mucoepidermoid carcinoma, and adenoid cystic carcinoma. Before progressing, small concept. Pleomorphic adenoma is a benign salivary gland tumor. Yes. But it has the potency to become cancer. It has the potency to become malignant. And when it does become malignant, it is called carcinoma X pleomorphic adenoma. So pleomorphic adenoma can become carcinoma X pleomorphic adenoma. See, X means before, in the past. So X pleomorphic adenoma means it was pleomorphic adenoma in the past. It was benign in the past, but now it is carcinoma. So carcinoma now before pleomorphic adenoma. So carcinoma X pleomorphic adenoma. Okay, now let's continue. First, the benign salivary gland tumor, starting off with pleomorphic adenoma. Pleomorphic adenoma is the most common salivary gland tumor. Out of all these tumors you see written in Robbins, out of all of them, the most common salivary gland tumor is pleomorphic adenoma. It is most commonly seen in parotid gland. It is seen in other salivary glands as well, but most commonly in parotid gland. It is due to PLAZ1 and HMGA2 mutation. See, easy to remember. Take PL from pleomorphic and A from adenoma. So pleomorphic adenoma, G for what? Gene. Pleomorphic adenoma, gene 1 mutation. Again, see. Write the 2 numbers 1, 2. Then pleomorphic adenoma, gene 1 mutation and HMGA mutation. 1, 2. Pleomorphic adenoma, gene 1 mutation and HMGA2 mutation. Simple. Okay, so previously I said that pleomorphic adenoma has the capacity, potency to become a cancer, a small concept. The longer the pleomorphic adenoma is there, the higher is the risk of it becoming cancer. What do I mean? Let's say I and you, both of us have pleomorphic adenoma. I'm sorry, but then hypothetically, both of us have pleomorphic adenoma. But I have pleomorphic adenoma for 10 years. You have pleomorphic adenoma for 5 years. That means my pleomorphic adenoma, since it is there for a longer period of time, has a higher potential to become cancer. That's what I mean. This is the data from your Robbins. No need to mock up. Just know the concept that longer a time pleomorphic adenoma is there, higher is the risk of it becoming cancer. See, less than 5 years, 2%. More than 15 years, tremendous increase in time. So there is increase in risk as well, 10% risk. I said pleomorphic adenoma, multiple morphology, so-called a mixed tumor, because it has two components, epithelial component and mesenchymal component. Under epithelial component, epithelium and myepithelium. Under mesenchymal component, cartilaginous component. So there is epithelium, myepithelium and cartilage. Epithelium, myepithelium and cartilage. Okay. Now the three pictures that I promised you earlier. First, history. There is a round discrete mass right here. And when you palpate that round discrete mass, it moves. So it is mobile. And the thing is, it is painless. So there is painless, slow growing, because obviously it is benign, mobile, when you palpate it moves, discrete round mass, gross. So grossly, what type of tumor is it? It's a benign tumor. What are benign tumors? They are well circumscribed. So this tumor right here is also well circumscribed, as I have shown with color red. See, all these pictures, most of them, they are from Robbins. So you can trust the source. So it is well circumscribed. See, well circumscribed. Here is the tumor. This whole thing is the tumor, and this is the normal parenchyma of the salivary gland. The tumor is, as I said earlier, round. So it obviously has a diameter. The diameter is mostly less than 6 centimeter. Look at the color. Color is yellow and somewhat white as well. So it is white yellow. But is it only white yellow? No, there are areas that appear blue as well. Areas that appear blue. See, I said earlier, pleomorphic adenoma is a mixed tumor. It has two components. The cartilaginous component is there now. It is myxoid in nature. And this myxoid cartilaginous component gives blue color in gross morphology. So everything said in the diagram itself, it is benign, and as you can see in the diagram, it is well circumscribed. It is round, so obviously it has a diameter. The diameter is less than 6 centimeter. The color is white yellow, but is it white yellow all the way through? No, there are some blue areas as well. That is due to myxoid cartilage. Okay. One very special thing about pleomorphic adenoma that you need to know from theory point of view, viva point of view, and entrance point of view as well. And that is, see, benign tumors, they are well encapsulated. That much you must know. But pleomorphic adenoma, even though it is benign tumor, it is not well encapsulated. It is encapsulated, but the capsule is incomplete. There is incomplete capsule, so you do not perform enucleation. 3 questions. What is incomplete capsule? What is enucleation? And why should you not perform enucleation for pleomorphic adenoma? Let's look at this concept right here. There is your parotid gland. This parotid gland has a benign tumor with very complete capsule, as seen in yellow, as shown in yellow. There is a complete capsule. In this case, the surgeon can simply cut through or incise through this plane of incision. Simply cut through and then remove this tumor. Boom. There is no longer any tumor left. So along with the capsule, the tumor only can be completely removed. This is enucleation. Only the part of the tumor along with the capsule is removed. Can only be performed for well encapsulated benign tumor. But then let's look at pleomorphic adenoma now. There is the parotid gland. There is pleomorphic adenoma. It has capsule, but then look at the yellow thing. It is not complete. It is partial. So there is opening here, opening here. What will happen from the opening? The tumor will spread and give papillary projection. It spreads and give papillary projection. Now let's say the surgeon performs enucleation here. That is, removes the tumor along with its capsule, only this much part of the tumor. There is still remnant. There is still papillary remnant of the tumor. And these papillary remnant can give rise to the tumor again. There can be reoccurrence of pleomorphic adenoma. So due to presence of incomplete capsule giving rise to those papillary projections spreading outside, enucleation can't be performed, because after enucleation there is going to be remnant of the tumor, and this remnant of the tumor will lead to reoccurrence of the tumor. So instead, do what? Remove the whole gland, remove the whole organ, that is called parotidectomy. So you don't do enucleation, you do parotidectomy for pleomorphic adenoma. All right. Microscopy. So just like I said in gross, you can look at the microscopy. It is well circumscribed. This much is the tumor, and this is the normal parenchyma. Parotid gland, it has acini. What kind of acini? Serous acini. So you can see all these serous acini that are well stained, all these serous acini along with ducts. Okay, that's normal. Here's the tumor. Let's zoom into the tumor, okay? Let's zoom into this tumor. After zooming in, you can see two different components. One looking like this, another looking like this. This is the epithelial component. This is the mesenchymal component. I said it is a mixed tumor with two components, epithelial component and mesenchymal component. The epithelial component is made up of epithelium and myoepithelium. The mesenchymal component is made up of myxoid, chondroid, myxoid, cartilage. Boom, done. Remember the three diagrams in your brain. Next, Warthin's tumor. If pleomorphic adenoma is the most common salivary gland tumor, Warthin's tumor is the second most common salivary gland tumor. If pleomorphic adenoma occurs mostly in parotid gland, Warthin's tumor is exclusive to parotid gland. That is, it occurs only in parotid gland, rarely in other salivary gland. Warthin tumor has strong connection with smoking. A smoker has 8 times higher risk of having Warthin tumor. See, you might think that what's the significance of remembering such worthless point? It is important from history point of view. The three pictures. First, the history. See, there is an adult male who is a chronic smoker with a bilateral parotid swelling. Again, adult male, because Warthin tumor is seen in male more than female. Chronic smoker, because due to smoking there is 8 times higher risk of having Warthin tumor with it can be unilateral as well, but then in diagram it's shown bilateral parotid swelling. See, let's change the scenario a little bit, okay? Instead of quite a bit. Instead of adult male, there's a child. Instead of chronic smoker, the child has an infection. And then there is bilateral parotid swelling. Then it is what? It is most probably mumps. But in this condition, there is an adult male. He does not have any infection, but he is a chronic smoker and he has bilateral parotid swelling. Then most probably it is Warthin's tumor of parotid gland. Let's look at the gross. What type of tumor is it? Benign. So is it well circumscribed? It is well circumscribed. Color, look, it looks gray, kind of gray, and then yellow. It looks gray yellow. Pleomorphic adenoma was white yellow. Here it is gray yellow. You see these spaces? These are cystic spaces. You know what a cyst is, right? Cyst, they are either empty or they are filled with fluid. In this case, it is filled with mucinous or serous fluid. So it is well circumscribed. It is yellow gray. It has cystic spaces filled with mucinous and serous secretion. Okay. As for microscopy, just remember the alternate name of Warthin's tumor and that will tell you everything. So the alternate name for Warthin tumor is papillary cyst adenoma lymphomatosum. I know it is a long name, but let me break it down for you. Papillary. So in microscopy, you have papillary projection. The papilla is lined by epithelium. This epithelium is special. Why? See, there is your papilla which is lined by epithelium. The epithelial cells, they are present in 2 layers. See, there's a bottom layer and then there's a luminal layer. The bottom layer is round cuboidal. The luminal layer, it is columnar. Now, why these epithelial cells are special is because they contain lots of mitochondria. And epithelial cells rich in mitochondria is oncocytes. So these cells are oncocytes. So papillary, there is presence of papilla lined by 2 layers of epithelial cells rich in mitochondria called as oncocytes. Cyst adenoma, see, oma, that means it's a benign tumor. Cyst, there is presence of fluid-filled cyst. Lymphomatosum, so there's going to be lots of lymphocytes. All these blue dots that you see right here, all these blue dots, what are they? They are lymphocytes. There's so much lymphocytes that they end up forming lymphoid follicles. What happens when there is too much lymphocytes? They form lymphoid follicles with germinal center. So that is there here as well. That's it. Boom, we are done with both the benign salivary gland tumors. Let's compare both of them. Pleomorphic adenoma, it is the most common salivary gland tumor. Warthin's tumor, it is the second most common salivary gland tumor. Pleomorphic adenoma, it most commonly affects parotid gland. Warthin tumor, it is exclusive, that is, it is mostly only found in parotid gland. Mutation, pleomorphic adenoma, right, 1, 2. Pleomorphic adenoma gene 1 mutation and HMGA2 mutation. Warthin tumor, nothing to remember. History, there is painless, round, discrete, mobile, parotid mass. Warthin's tumor, there is adult male. Remember, it is seen more in male. Chronic smoker, because smoking increases the risk by 8 folds. And there is bilateral or unilateral swelling, parotid swelling, because it is exclusive to parotid gland. That's why parotid swelling. Gross. So grossly, it is circumscribed because it is benign, circumscribed. Warthin tumor is also circumscribed because it is benign, circumscribed. As for color, pleomorphic adenoma, it is white yellow. Warthin tumor, it is pale gray. Special point on both of these, pleomorphic adenoma, there is incomplete capsule. So there is papillary projection. That is why you are not supposed to perform enucleation. Instead, you perform parotidectomy. Warthin's tumor, there is cysts, cystic spaces filled with fluid. Remember, don't write these points in exam. Draw the diagram and then label that diagram. Microscopy. So pleomorphic adenoma, pleomorphic multiple morphology. See, for microscopy, very simple. Remember the alternate names for both of these tumors and that will explain the microscopy. Pleomorphic adenoma, it is mixed tumor. Mixed because there is 2 component, epithelial component and mesenchymal component. Epithelial component contains epithelium plus myoepithelium and mesenchymal component includes the myxoid chondroid, that is myxoid cartilage, myxoid chondroid. Warthin's tumor, alternate name, papillary cyst adenoma, lymphomatosum. So easy. Papillary, there is presence of papilla with epithelial cells arranged in 2 layers, the bottom cuboidal and the luminal columnar. They are rich in mitochondria, so referred to as oncocytes. Cyst adenoma, oma because it is benign, cyst because there is presence of cyst. Lymphomatosum, so the matrix, right, of the papilla. The matrix of the papilla, it is rich in lymphocytes forming lymphoid follicles as well. Whew. Now, the malignant salivary gland tumors. Mucoepidermoid carcinoma, so it is malignant. Mucoepidermoid, 2 components. Muco referring to mucinous component, cells rich in cells filled with mucus, and epidermoid referring to epithelial cells. See, look at this microscopy. There are these empty looking cells. What are these empty looking cells filled with? Their vacuoles are filled with mucus. So these are the mucinous cell. But at the same time, there are also these strongly stained cells. What are these? These are the epithelial cells. So the tumor contains two components, the empty looking mucinous cells and the strongly stained epithelial cells. Remember, very important concept. More the epithelial component, higher is the grade of the tumor. Again, more the epithelial component, higher is the grade of the tumor. Look at these three microscopy, B, C, and D. Here the grade of the tumor is low, here it's intermediate, and here it's high. Why? Because in B there is more which cells? Mucinous cell. In C there is mixture of both, and in D there is more squamous cell. So as you go from mucinous cell to squamous cell, the grade of the tumor is increasing as well. When there is mucinous cell, it is low grade tumor. When there is mucinous and squamous cell, it is intermediate grade tumor. When there is squamous cell, it is high grade tumor. So with the increment in epithelial cell, not the squamous cell, I'm so sorry, the epithelial cells. With the increment in epithelial cell, with the increment in epidermoid component, there is increment in grade of the tumor as well. It is due to translocation 11-19, resulting in formation of a fusion gene. Adenoid cystic carcinoma. Carcinoma, it is malignant. Cystic. So in a microscopy, you can see these empty looking space giving of which appearance? Cribriform appearance. These are tumor cells forming cribriform appearance. But then there is tubular structure as well. There is solid structure as well. So see, adenoid cystic carcinoma, microscopically, it gives cribriform pattern, but rarely it is tubular or solid. Cribriform pattern means it looks like a Swiss cheese. In Swiss cheese, you look at these empty spaces now. Similar to these empty spaces, you have empty spaces here as well, cribriform pattern. You look at this channi na, the tea filter. There is empty spaces there for tea to go down, right, to filter. Similarly, here are empty spaces as well. Look at this microscopy. There is nerve which is completely surrounded by the tumor cells. The nerve which is completely surrounded by the tumor cells, which is referred to as perineural invasion. And when there is perineural invasion, there is compression of the nerve leading to pain. See, cribriform pattern, it is seen in adenoid cystic carcinoma plus in ductal carcinoma in situ of breast cancer. Remember, perineural invasion, it is seen in adenoid cystic carcinoma. Where else? In prostate carcinoma, there is perineural invasion. This is due to translocation 6-9. Okay. Done. Now let's compare the two tumors. Mucoepidermoid carcinoma is the most common primary malignant tumor of salivary gland. Again, the most common salivary tumor, the most common salivary gland tumor is pleomorphic adenoma. Don't get confused. But if you are specified that the most common primary malignant because it is a cancer, primary because it is arising from the organ itself. So most common primary malignant salivary gland tumor, then that is mucoepidermoid carcinoma. Nothing here. Mutation, this is due to translocation 11-19. Translocation 11-19, this is due to translocation 6-9. Microscopy, simple, mucoepidermoid. So there is mucinous element and there is epidermoid element. Remember, more is the epithelial element, higher is the grade of the tumor. Adenoid cystic carcinoma, it is mostly present in cribriform pattern, but then rarely there can be tubular and solid. Also there is perineural invasion resulting in pain. Remember, don't write these points in exam. Draw them. Draw the cribriform pattern with tumor cells like this. Draw that there is a neuron here and it has been invaded by the tumor cells. With that being said, we are done with salivary gland tumors. This is going to be a very short series under GI pathology, which is going to include all the congenital abnormalities. And yes, this is also going to mark the end of the series, the end of GI pathology series. And what's better way to kick things off with rather than learning the most common congenital abnormality of GI tract first, and the most common congenital abnormality of gastrointestinal tract is Meckel Diverticulum. First things first, what is diverticulum? Diverticulum is a blind outpouching of hollow structure. The hollow structure can either be a hollow organ or a hollow tube. For example, this is a hollow organ in your body. This hollow organ develops a blind outpouching. This is diverticulum. This is a hollow tube in your body. The hollow tube develops a blind outpouching. This is a diverticulum. Simple. Here are the example. The urinary bladder, it is a hollow organ. It develops a blind outpouching. This is a diverticulum. The cavity inside the outpouching and the true cavity of the organ is able to communicate with one another. And the outpouching has a closed end. It has a closed end, so called a blind or closed outpouching. Similarly, here's a hollow tube in your body, which is the gastrointestinal tract, which also develops a blind outpouching, which is diverticulum. Blind outpouching, blind outpouching, blind outpouching. They are all diverticula. Diverticula, they are of two types. Just like aneurysm, you might have already learned aneurysm, or you will be learning soon enough under CVS pathology. Aneurysm, they are of two types: true aneurysm and false or pseudo aneurysm. Similarly, diverticulum is also of two types: true diverticulum and false or pseudo diverticulum. The difference is same as well. In true diverticulum, all the layers of the wall are involved. In false diverticulum, only few of the layers of the wall is involved. For example, in gastrointestinal tract, from inside to outside, what do you have? See, for example, in gastrointestinal tract, inside you have mucosa, then submucosa, then muscular layer, then serosa. In true outpouching, true blind outpouching, or true diverticulum, all the layers of the GI tract is involved. So here's the true diverticulum. Inside there is mucosa. Inside there is mucosa. Then there is submucosa. Submucosa. Then there is muscular layer. Muscular layer. See, is this a blind outpouching? Yes. Does this blind outpouching contain all the four layers of the GI tract? Yes. That means, are all the layers of the wall involved? Yes. Then is it a true diverticulum? Yes. Next, see another. Here is muscular layer. Muscular layer. Outside there is serosa. Serosa. This time it is only the submucosa and mucosa. Only the submucosa and the mucosa that is outpouching. Submucosa and mucosa that is outpouching. See, mucosa and submucosa, it is herniating or pushing out through the muscular layer. But is the muscular layer involved in forming the outpouching? No, it is not. So, first thing, is it a blind outpouching? Yes, that means it is a diverticulum. Does this blind outpouching or diverticulum contain all the four layers of the GI tract wall? No, it does not. It only contains mucosa and submucosa. That means it is false diverticulum. The example of false diverticulum are the pseudo diverticuli that you see in sigmoid colon. And the example of true diverticulum is what you are studying today, and that is Meckel Diverticulum. In fact, Meckel Diverticulum is the most common true diverticulum, and it is also the most common congenital abnormality of gastrointestinal tract. How exactly is Meckel Diverticulum formed? So this is the pathogenesis. During fetal development, you have the primitive gut and then yolk sac. The primitive gut communicates with yolk sac with the help of a duct, which is called the vitelline duct. As the fetus develops, the vitelline duct, it obliterates, it disappears. So only what remains is the GI tract. But let's say due to some reason the vitelline duct does not obliterate. It persists. A part of vitelline duct, it persists, it remains. And this persisting vitelline duct, the remnant of the persistent vitelline duct, outpouches on the gut, outpouches from the gut. And this diverticulum formed by the remnant of the not obliterated vitelline duct is Meckel's diverticulum. Once more, your primitive gut has three parts: the foregut, the midgut, and the hindgut. The midgut is going to form structures like ileum and such. The midgut is communicating with the yolk sac with the help of a duct which is called the vitelline duct. Normally, the vitelline duct obliterates completely, and what remains is a continuous tube of ileum. But what has happened is that the vitelline duct has not obliterated. There is still vitelline duct remaining. So it forms a outpouching in this ileum. Here is primitive ileum, and then here is the outpouching. Now here see, here is the ileum. This ileum has this outpouching. The outpouching is formed by what? This outpouching or diverticulum is formed by what? It is formed by vitelline duct, which did not obliterate. This diverticulum is a Meckel diverticulum. I can't explain more. This diagram is from Robbins. Let me tell you first. Okay, that's it. Now, the 6 rules of 2s of Meckel diverticulum that you need to have mocked up in your brain. And they are, number 1, 2 types of mucosal lining. See, since the Meckel diverticulum is an outpouching in the ileum. This is the ileum. It is the outpouching of the ileum. So obviously, the mucosa of the ileum is going to be continuous with the mucosa of Meckel diverticulum, right? So native ileal mucosa is found. However, other than native mucosa, ectopic mucosa or heterotrophic mucosa, that is mucosa found in some other place in the body, is now also found in Meckel diverticulum, and most commonly that is gastric mucosa. And if you remember correctly, I have already taught you under the topic of peptic ulcer disease the most common places where peptic ulcer is seen, and in the series we also had Meckel diverticulum. So forget all that. See, since Meckel diverticulum is found in the ileum, the native ileal mucosa is gonna be found in the Meckel diverticulum. Okay, one thing, that is the native mucosa. The second thing, heterotrophic or ectopic mucosa is also found, and the most common is gastric mucosa, the mucosa of the stomach. If gastric mucosa is going to be found inside, what is going to be produced there? HCl. HCl leads to what? Ulcer formation. So you have peptic ulcer here. This is most common, gastric mucosa. Other than that, pancreatic mucosa may also be present. Then it is found within 2 years of life, found in 2% of population, present 2 feet proximal to ileocecal valve on anti-mesenteric side. See, this is the cecum with the appendix. This is the ileocecal junction, and 2 feet away from the ileocecal junction or the ileocecal valve is the diverticula, and the diverticula is present on the anti-mesenteric side. What is ileum? It is small intestine. Small intestine is attached with mesentery. The side to which mesentery is attached is the mesenteric side, and the other side, which is free from mesentery, is the anti-mesenteric side. And the outpouching is seen on the anti-mesenteric side. It is a 2 inches long, found 2:1 ratio, male is to female. That is 2 times it is more prevalent in males. Okay, let me make a diagram to make everything clear. So here's the cecum with appendix, and then here's the ileocecal junction, 2 feet from ileocecal junction. How much? 2 feet from ileocecal junction is the Meckel diverticulum. Here's the Meckel diverticulum. It is 2 inches long. 2 inches long. It is present on the anti-mesenteric side. So this side is attached with mesentery. These are the fat of the mesentery. This is the mesenteric side, and this is the anti-mesenteric side. So 2 feet away from the ileocecal valve and 2 inches long, you have the Meckel Diverticulum on the anti-mesenteric side. Can't explain you better than this. One last revision, okay? So the topic is Meckel Diverticulum. What is diverticulum? It is a blind outpouching of hollow structure in your body, which can either be a hollow organ or a hollow tube. It is of 2 types, true diverticulum, false diverticulum. In true diverticulum, all the layers of the wall is involved. In false diverticulum, only few layers of the wall is involved. Example of false diverticulum is pseudodiverticulum seen in sigmoid colon. The example of true diverticulum is Meckel Diverticulum, which is in fact the most common true diverticulum and the most common congenital abnormality of GI tract. Meckel Diverticulum occurs due to failure of obliteration of vitelline duct. As a result, the remnant of vitelline duct forms a diverticulum on the ileum of small intestine. The six rules of twos of Meckel Diverticulum are: number 1, 2 types of mucosal lining. Obviously, since the diverticulum is seen in ileum, the native ileal mucosa is continuous. But along with that, some ectopic mucosa is also there, most commonly the gastric mucosa. Gastric mucosa produces HCl. HCl leads to peptic ulcer disease. It is seen within 2 years of life in 2% of population with a ratio of 2:1. That is more common 2 times in male as compared to female. It is 2 inches long, 2 feet proximal to ileocecal valve on anti-mesenteric side. 2 feet proximal to ileocecal valve on the anti-mesenteric side and 2 inches long. That's it. Bye. Continuing with our series of congenital abnormalities of gastrointestinal tract, up next we have the Hirschsprung disease. But first things first, you gotta know your basic histology and physiology. This is something you must have already known, but if you don't, learn now. The gastrointestinal tract has a nervous system of its own, which is called the enteric nervous system, which contains 2 nerve plexuses, the Meissner's plexus and the Auerbach's plexus. The Meissner's plexus is also called the submucosal plexus, and the Auerbach's plexus is also called the myenteric plexus. The Meissner's plexus is responsible for carrying out the secretion of glands, and the Auerbach's plexus is responsible for carrying out peristalsis throughout the gastrointestinal tract. From your basic histology, you must know that the complete gastrointestinal tract is made up of 4 layers. From inside to outside, you have mucosa, submucosa, muscularis propria, and finally serosa. In between submucosa and muscularis propria, you have a nerve plexus, the nerve plexus. This nerve plexus is obviously called the submucosal nerve plexus or the Meissner's plexus, responsible for carrying out the secretion of glands. Similarly, in between the 2 layers of muscularis propria, that is the outer longitudinal layer and the inner circular layer, in between these 2 layers, there is another nerve plexus which is called the Auerbach's plexus or the myenteric plexus. Myenteric comes from the word myo, referring to muscles. So this plexus is indeed responsible for contraction and relaxation of muscularis propria, allowing peristalsis to take place. Nerve plexuses, they contain a special type of cell which is called the ganglionic cell. And these nerve plexuses right here also contain the ganglion cells. Let's take myenteric plexus for example. So the myenteric plexus is present in between what? It is sandwiched between the outer longitudinal layer and the inner circular layer. Here is the myenteric plexus. It is made up of special cells called the ganglion cells. What will happen if there is no ganglion cell? See, ganglion cell forms the Auerbach's plexus, and Auerbach's plexus allows for peristalsis to take place. If there is no ganglion cell, there is no Auerbach's plexus, and there is no peristalsis taking place. Got it? Got it. Second question. Where exactly do these ganglion cells even come from? They come from something called the neural crest cells. Yes, during the embryological development, the neural crest cells, they migrate to the gastrointestinal tract and they travel through the whole of the tract, whole gut, and proliferate, giving off ganglion cells. Let's take large intestine for example, okay? So the neural crest cells, they migrate to the primitive cecum. Then they further migrate from the primitive cecum to ascending colon, then the transverse colon, then the descending colon, then the sigmoid colon, and finally the rectum. Everywhere the neural crest cells go, they proliferate into ganglion cells, and these ganglion cells, they give rise to the enteric nervous system. So the starting point is the neural crest cell. It's the migration of the neural crest cell to the gastrointestinal tract that gives rise to ganglion cells, and it's the ganglion cells that make up the enteric nervous system. So let's take one analogy, for example. Okay, consider these neural crest cells to be a school bus carrying a bunch of children. This school bus is going to drop these children to their respective homes, starting from the cecum. Cecum is the school, so it goes from the cecum to the ascending colon, drops children to their home, and these children, for some reason, they convert into ganglion cells. All right, I don't know what kind of analogy am I taking, but then these children, they end up forming ganglion cells. Then the school bus goes to transverse colon. There also they drop off these children, and then these children, they end up forming ganglion cell. The school bus further travel to the descending colon. They leave off, drop off children, and they end up forming ganglion cell. But then all of a sudden, there is a traffic jam. Due to this traffic jam, the bus is unable to travel beyond that point. That means it is unable to drop children beyond that point. That means beyond that point, ganglion cells are not being formed. Now replace the school bus with neural crest cell. So the neural crest cell traveled all this distance forming ganglion cell, but now due to some traffic jam, the neural crest cell migration has, what's the term? Arrested. There is arrest in the migration of the neural crest cell, due to which beyond this point the neural crest cell want to go. So beyond this point there will be no ganglion cell. If there is no ganglion cell beyond this point, what do we call this segment? This is a non-ganglionic, aganglionic segment of the colon, and this is your Hirschsprung disease, which begs the question, what's the definition of Hirschsprung disease? It is a congenital aganglionic megacolon. Congenital because the disease is present by birth. The disease occurred due to defect in embryological development. So obviously it is going to be congenital. If there is defect during embryological development, then the disease is obviously going to be there by birth. Means it's congenital. Aganglionic because the affected part of the colon is without the ganglion cells. Megacolon because the part of the colon proximal to the affected part is larger in size. So mega, large colon, which begs another question. How exactly does such a condition arise where there is distal narrow aganglionic segment and a proximal larger megacolon ganglionic segment? How does such condition arise? What is the pathogenesis? Here's the pathogenesis. There is RET gene mutation resulting in mutated tyrosine kinase receptor. Yep, that's all you have to mock up. After that, everything is in the story itself. RET gene mutation resulting in tyrosine kinase receptor. Earlier, did I not say there was traffic jam for the bus or traffic jam for the neural crest cell? The traffic jam is this right here. RET gene mutation is the traffic jam. The mutation in the tyrosine kinase receptor is the traffic jam. After that, everything is the same as in the story. See, the neural crest cell, let's take this diagram for example. So the neural crest cell, it was migrating and proliferating into ganglion cell, migrating, proliferating into ganglion cell, migrating, proliferating into ganglion cell, migrating, proliferating into ganglion cell. But now, due to RET gene mutation, tyrosine kinase receptor mutation, there is arrest, traffic jam, there is arrest in the migration of neural crest cell beyond this point. As a result, there is no neural crest cell beyond this point. As a result, there is no ganglion cells beyond this point. As a result, there is no Auerbach plexus beyond this point. As a result, peristalsis does not take place beyond that point. And this is the involved aganglionic segment of Hirschsprung disease. See, there is stool here, right? The stool needs to pass down, right? But then this involved part does not show peristalsis, because there is no ganglion cell to show peristalsis, will not show peristalsis. That means there is what? Functional obstruction. There is functional obstruction. As a result, the stool is unable to pass down. So what will happen? What will happen to the stool? It is going to accumulate there. The stool that is to pass down is going to accumulate at this region, keep on accumulating. As a result, the part proximal to the involved part will dilate. It will swell up, it will dilate, it will become larger. Second thing, the part proximal to the involved part has the ganglion cells, because neural crest cell was there, so it formed ganglion cell, so it can show peristalsis. So this part will show peristalsis. It will show peristalsis. So the stool will be pushed down. But is the stool able to go down? No, because there is functional obstruction, brother and sister. There is functional obstruction here. As a result, the stool is not able to go down. But does that mean peristalsis will stop? No, peristalsis will not stop. The colon thinks that there is still stool here. The colon, in its mind, the colon's mind, the stool is still there. The colon want to get rid of that stool. So it will keep on showing peristalsis till the stool is thrown out. As a result, what will happen? The muscular layer will get used up too much, resulting in hypertrophy. That's the word, hypertrophy. The same thing is written in text here. Red gene mutation, mutated tyrosine kinase receptor, resulting in arrest in migration of neural crest cell, result in affected segment without ganglion cells. Obviously, if there is no neural crest cell, there is no ganglion cell. As a result, a ganglionic distal segment with no peristalsis. Again, no neural crest cell, no ganglion cell, no Auerbach's plexus, no peristalsis, resulting in functional obstruction. I use the word functional obstruction. Accumulation of meconium in the proximal segment. What is meconium? Areba, hear me out. See, is the disease congenital? Yes, it is. That means the disease is present by birth. Yes. That means the stool that is accumulated here is the very first stool of the infant, because the disease is present by birth, at the early stage only. So this stool is the very first stool, and the very first stool is meconium, nothing else. Meconium is the very first stool of the child. Due to accumulation of the stool, the proximal segment becomes dilated. There is progressive dilation. And since it is showing peristalsis on and on and on, there is hypertrophy. That's it. One last revision for your dummy dumps. All right, one last revision. The story. The neural crest cells, they migrate along the gastrointestinal tract, like the large intestine, traveling through the cecum, the ascending colon, the transverse colon, then the descending colon, and everywhere it migrates, it forms the ganglion cells, But all of a sudden, the migration of the neural crest cell has been arrested. It has come to a stop due to ret gene mutation or tyrosine kinase receptor mutation, the traffic jam. Since beyond this point, the neural crest cells do not go. So beyond this point, there are no ganglionic cells. So beyond this point, there is no Auerbach plexus. So beyond this point, peristalsis will not take place. As a result, there is functional obstruction right here. Since there is functional obstruction right here, the stool will get accumulated in the proximal segment. Due to accumulation of the stool in the proximal segment, the proximal segment will swell up or become dilated. Since the proximal segment still has ganglion cells, it can show peristalsis. The peristalsis will keep on going on, but the functional obstruction is still there, so stool will not pass down. Due to excess peristalsis, there is hypertrophy of muscularis propria. Got it? What does it result in? It finally results in this thing, that is the proximal dilated ganglionic segment and the distal narrow aganglionic segment. See, the rectum is always involved. Use your tiny brain, brother. The rectum is always involved. See, neural crest cell is migrating like this, so it doesn't matter where the arrest comes. The migration stops here or here or here. It is always the segment after that which is involved, and the very last part itself is rectum. So obviously, even if the arrest of the neural crest cell comes here, let's say the neural crest cell migration stops here, what is the part beyond that? Rectum, because rectum is the very last part. So rectum is obviously by default always involved. But the question is, beyond the rectum, behind the rectum, what more is involved? On the basis of that, you have short segment Hirschsprung disease and long segment Hirschsprung disease. In short segment Hirschsprung disease, it is only the rectum and the sigmoid colon which is affected. In long segment Hirschsprung disease, it is the rectum, sigmoid colon plus some more beyond that which is affected, which does not have ganglion cells, where the neural crest cells could not migrate. Okay, this diagram, it is from Robbins. So before surgery, in diagnosis, a barium enema X-ray was performed, and you can clearly see the distal narrow aganglionic segment and the proximal dilated hypertrophied megacolon. The same thing is shown during the operation as well. Microscopy, rectal biopsy of neonate is done. Why neonate? Because it is a congenital disease. Why rectal biopsy? Because rectum is always involved. So you have a neonate rectal biopsy without Hirschsprung disease and another with Hirschsprung disease. Without Hirschsprung disease, you can clearly see marked by black the ganglion cells. Marked by your white are the nerves, But then here are the ganglion cells, the important feature, the ganglion cells. But then when there is Hirschsprung disease, there are no ganglion cells. The black arrow is showing you the nerves, but then the ganglion cells are not there. See, previously there are ganglion cells. Now there are no ganglion cells. Hirschsprung disease is what? Aganglionic segment na, means there is no ganglion cells na. So microscopically also you can't see any ganglion. This is the last video under congenital abnormalities of GI tract. I know there are still few topics left like congenital diaphragmatic hernia, tracheoesophageal fistula, omphalocele, gastroschisis. However, these topics are well understood once you know the embryology of those particular structures. So they are best studied under anatomy rather than pathology. As for pathology, this is it. Pyloric stenosis. What is stenosis? It is the abnormal or pathological narrowing of a passage or opening. Again, what is stenosis? It is the abnormal or pathological narrowing of a passage or opening. The question is, what is the difference between stenosis and stricture? See, both stenosis and stricture refer to abnormal narrowing of a passage present within your body. But the difference lies in the cause. Stricture is due to inflammation, scarring, and fibrosis. So that's the difference. Stricture is the abnormal narrowing, but it is due to inflammation, scarring, and fibrosis. Okay. The topic is pyloric stenosis. See, I said that stenosis is what? It is the abnormal narrowing of opening or passage in your body. Yes? If this opening we are talking about, if this opening is pylorus, then it is pyloric stenosis. Khatam, over. Where is pylorus? Pylorus is present right here. Pylorus is an opening through which the stomach communicates with the duodenum. If the narrowing of this opening takes place, the narrowing of the pylorus takes place, we call it pyloric stenosis. It can either be acquired or congenital. Congenital means it is present by birth, so obviously it is seen in infants. Acquired means it develops later on in life, so obviously it is seen in adults. Acquired pyloric stenosis in adults is due to various pathologies of the pylorus of the stomach. For example, gastritis of the pylorus of the stomach, tumors in the pylorus of the stomach, peptic ulcer in the pylorus of the stomach can hinder and bring about stenosis of the pylorus. Congenital pyloric stenosis seen in infant is the one that you have to learn more in detail, and that is infantile hypertrophic pyloric stenosis. Again, infantile hypertrophic pyloric stenosis. What? Infantile hypertrophic pyloric stenosis. Let's break this huge terminology. Stenosis because there is narrowing of an opening. Pyloric stenosis because the narrowing of the opening is of which opening? The pylorus. Infantile pyloric stenosis because the narrowing of pylorus is seen in infant because the condition is congenital. Hypertrophic Because the reason behind the narrowing of pylorus is hypertrophy of pyloric sphincter. Again, where is pylorus? Pylorus is present right here. Pylorus allows for communication between stomach and duodenum. The pylorus is guarded by pyloric sphincter. What is sphincter? Sphincter is nothing but a circular band of muscle. This circular band of muscle can contract and relax, allowing for things to pass through it, right? That is what is sphincter. The pyloric sphincter is also a circular band of muscle. Now, hypertrophy of pyloric sphincter means what? There is thickening of the pyloric sphincter. There is thickening of the circular muscle of the pyloric sphincter. See, there is circular muscle present right here, okay, which is the pyloric sphincter. Now, let's say due to any etiology, this pyloric sphincter becomes thicker and thicker and thicker and thicker and thicker. What is happening to the opening? It is becoming smaller, narrower and narrower and narrower and narrower, and ultimately it becomes very narrow. So this pathological narrowing of the opening is called what? Stenosis. Here the pathological narrowing of which opening is taking place? Pylorus. So pyloric stenosis. In whom? In infants. So infantile pyloric stenosis. Due to what reason? Due to hypertrophy of pyloric sphincter. So infantile hypertrophic pyloric stenosis. That's it. That's it. Everything explained from the terminology itself. Associations. It is found associated with Turner syndrome and trisomy 18 or Edwards syndrome. In those cases, infantile hypertrophic pyloric stenosis is obviously congenital. However, later on it was found that infantile hypertrophic pyloric stenosis can be acquired as well. And that is when within first 2 weeks of infant life, right? The baby has been born. Within first 2 weeks, there is exposure to erythromycin or azithromycin. Then that can lead to infantile hypertrophic pyloric stenosis as well. Why? See, erythromycin and azithromycin, both of them are motilin receptor agonist. And motilin receptor is responsible for frequent contraction of the smooth muscle present within the GI tract. As a result, there is overstimulation of pyloric sphincter smooth muscle. As a result, there is hypertrophy of the smooth muscle of pyloric sphincter, leading to pyloric stenosis. This is how erythromycin and azithromycin exposure in first 2 weeks of infant life can also lead to infantile hypertrophic pyloric stenosis. Grossly, the stenosis is present in the form of a 1 to 2 centimeter olive-shaped mass, which is palpable as well. Microscopically, I have already said there is hypertrophy of the smooth muscle. There is hypertrophy. So you can see the thickening of the smooth muscle in pyloric sphincter. As for clinical feature, see, the gastric content, it has to go into the duodenum. However, there is obstruction due to stenosis. So where does it go? It goes up in the form of vomiting. Does the vomitus contain any bile? No, it does not. Bile gets added later on in the duodenum. Since there is no communication with the duodenum, there is obstruction. So vomitus is without bile. So it is projectile non-bilious vomiting. Second, since the gastric content does not reach the intestine, the body does not receive any energy. It is unable to absorb any nutrition. So the body feels hungry. There is still starvation to the cell and your body. As a result, there is a repeated feeding demand. Number 3, your stomach, it travels from left side of the body to the right side of the body, right? So does the peristaltic waves traveling through the stomach. So it goes from the left side to the right side. The peristaltic wave go from the left side to the right side. Due to this peristalsis, the gastric content gets pushed into the duodenum. However, there is obstruction due to stenosis, so it will not get pushed into the duodenum. So where will it go eventually? It will go through above. So there is vomiting. So there is left to right hyperperistalsis, then vomiting. Which kind of vomiting? Projectile non-bilious vomiting. As for treatment, what is there? There is thickening of smooth muscle. So what can you do? You can go and cut off pieces of the smooth muscle, just tear it off and throw it. That is myotomy. So the treatment is surgical myotomy. That's it. Bye.